microcirculation organized by Abbott. We are very happy and honored. Olivier will lead that. Olivier is our head of Department of Cardiology in CHUV, one of the 5 university hospitals in Lausanne. He will do that together with BDB. BDB is Bernard de Bruin, together with Nico Pels, the creator, the inventor of FFR, a technology that has changed the life of interventional cardiologists. And of course, they go one step beyond, which is microcirculation, the other box we don't know so much about. So this is after the introduction lecture by Malcolm Bell. Other things. We have a few flying doctors with microphones. I'll be part of that, but also Nathalie, Iulian, and Alexei will do that. So please, we understand you have something urgent to say, but wait until the microphone is there and don't speak all together. This is not a political debate. We are educated people, so we speak one after the other. And if we say that we are not politicians, that means, as I mentioned yesterday evening, let's try to be polite and constructive. You can really say whatever you want. There is no embargo on opinion, but there is embargo on nasty comments. I think everybody agrees on that. Malcolm? So there is also at 11:15 a symposium organized by B. Brown. It's about drug-eluting balloons, of course, and there is also a session about vanishing stents. So that's all. There will be a satellite at noon organized by Biotronic that will be chaired by Olivier and by me. So I think we have a busy program. And as usual, we start with the honorary guest. That will be Malcolm. So I ask maybe Malcolm now, and then Olivier, to say a few words. You have to be there.
Thank you very much, Eric. Good morning, everyone. I'm really sorry that I wasn't here yesterday afternoon, and also like to say welcome to all of the people who may be listening and watching online. Many of them are our friends and colleagues from many years of meeting together here in Lausanne. This is actually my first trip back to Europe in 3 years. Travel hasn't become any more pleasant, but I'm very pleased to be here. And just reflecting on this, this is now, for me, it's 21 years, I think, of coming to this meeting. And for those of you who weren't here at its inception, but certainly even this meeting here, if this is your first time that you've been here, you will realize these complications are so interesting and so unique. And if you've been in the business for 10, 20, 30 years or so, if you think you've seen it all, you haven't until you've come to this meeting. And even then, you have to wait for the next meeting. So it's really extraordinary. And I really want to congratulate Eric and Olivier and Christian and others here who have put this meeting together. This truly represented a very unique vision, I think, 20-odd years or so ago, to have a complication meeting of interventional cardiology. To my knowledge, there really isn't such an equivalent meeting anything outside of cardiology, and it really has become the premier meeting for complications of interventional cardiology. But anyway, you're going to hear too much of me in the next half an hour, so I'm going to hand the microphone over to Olivier, and again, welcome everyone.
Thank you, Malcolm. Welcome, everybody. I will just say a few words about complications, and thank you very much, Eric, for organizing this meeting for more than 20 years now. We are very happy here in the name of the CHUV to host this meeting for this 20 years of experience. And I would like to just say a few words about experience. And experience is years, so you can wait years, or you can try to come to this meeting and you can win some years in terms of experience. And this is all about your talk, I think, Malcolm, is to gain experience, how to gain experience. We shouldn't wait too long to gain experience, and we have to share. And this is the spirit of this meeting, is to share, and learning by sharing is the main word that we have to keep in mind. So Malcolm, I think I'll welcome you for this talk about how to gain experience.
So when we look at the title here, Interventional Wisdom, Tips and Tricks to Build Skills and Knowledge Over Time. So for those of you who are here to listen to my experience of all the complications that I've ever had, or you're going to be disappointed. And for those of you who are older, and you may think, well, what relevance does this have for me? And it reminds me, actually, and some of you in the audience will no doubt remember some very famous British film actors, one of whom was Sir Laurence Olivier. And Sir Laurence he was one of the great actors in the middle of the 20th century. And he wrote a book just towards the end of his life, and it was called How to Act. And one of his colleagues, also a world-famous actor, was asked on a talk show, have you read Sir Laurence Olivier's book on how to act? And the response was, oh no, of course not. I may realize after all these years that I was doing it wrong. And of course, this is an Academy Award winner. And so I feel a bit like that today, but all of the talks that Eric's given me over the years have been puzzling. I spend about 6 weeks wondering, what am I going to talk about here? And what I'm going to do here is I'm going to just take you through some tips of, particularly for younger trainees and junior faculty, and really sort of outline what are the things you can do to really maximize the chance you're going to have a successful career. That's what this talk is really about. I hope it makes sense to you. And as we think again about the title, knowledge and wisdom and skills were in the title, and I thought, well, what does that really mean? And do you want to just listen to some old man waxing lyrically about his career? No, that would be pretty boring. Also, if you came here thinking that you're going to hear lots of amusing anecdotes, you're going to be disappointed. But knowledge is something that you learn. You can read this here, and it's gaining that information and facts, and some of it's gained from experience. It's not all just reading the books or listening to lectures. It's knowledge because you're doing things. But it might be selective. You may be very selective in what you're learning. Wisdom, on the other hand, is something that you develop. You don't really learn this. It's something that's developed, and you're applying the knowledge that you've gained, and it comes to sort of making the right choices. What's good judgment? What makes that erudite clinician someone that you're always going to go to looking for advice when you've got a complex patient? And skills, well, they're learned and developed as well. And certainly, as Eric and Olivier can attest to at this meeting, you will learn some skills. You may not have hands-on, but you'll see how your colleagues got into trouble and got out of trouble. And it can be cognitive. I mean, skills are just not our hand skills. It's our clinical skills, and again, judgment. So Erica put in the title, Tricks. I don't really have any tricks, so I'm not going to be talking about any tricks. You'll learn lots about tricks here at these, when people are presenting these cases. The first thing I'm going to strongly recommend is that for people starting in their career, you must find a mentor. Particularly if you're in a large academic institution, the expectation is that you're going to be successful in research, education, but you can't do it by yourself. There are other people who've gone that path, they've learned by experience again, and these are the people that you should seek out. And I'm responsible for the faculty development at Mayo Clinic of our cardiology faculty when they first come on staff. And the people who really have struggled, and fortunately it's just a small number, it's usually because they don't have a strong mentor. And a mentor is not someone who's just going to be your research supervisor. It could be someone who's there just to give you career advice. I mean, that's what you're going to them for. It could be employment. Should I go and work in this city or this hospital? What do you think about doing this elective, this extra training? What about going to London or Paris or wherever, for a year? These are the people who can give you some advice because they've seen most of this. They know where the field is going and what the needs are. So again, that could be someone that also provides information about resources, where to go to if you're looking for something, resources for research or collaborators. And it doesn't have to be an interventional cardiologist, it could be anyone, but a mentor and someone that you really trust. The second thing I would recommend, and this has been part of my experience almost from day one, is to have a colleague that you trust and respect, and that respect and trust is mutual, that you share cases with. And even after a busy day, almost every day, I'll go and knock on one of my colleagues' doors when I say, hey, look at this case that we did. And it may not be to share a complication, it could be a near miss, or it just could have been a very interesting case. And sometimes it could be planning a case, just to strategize. And it doesn't have to be one person. And I recognize that that's really difficult if you're in a small private practice and you don't have anyone else there. But if you're in an academic practice, don't do it by yourself. And it's very interesting. At Mayo, we have about 15 interventional cardiologists. And when we have someone who comes in, particularly from the outside, who's new, they feel as though they've got to do everything themselves and prove themselves. But there is nothing wrong with stopping in the middle of a case or after the diagnostic angiogram. You've thought about what you're going to do, but then to call someone else in and just discuss it with them. It's that unity of joining forces, and it's been so helpful. So you don't ever feel as though you have to do this by yourself. And I think that, as I said, it's also fun. At the end of the day, maybe it takes an extra half an hour before you go home, but I, over many years, have learned so many things there, and I hope that my colleagues have been the same. Now, knowledge and wisdom were two of the key points in the title there. And I'm going to spend a good part of the talk here talking about how to be smart in gaining knowledge and developing wisdom. All of us did well in school, didn't we? We had to get into medical school, and we did residencies and fellowships. And so we have to make an assumption that everyone's highly educated, they're highly intelligent, and they're very good at problem solving. One of the things that I have noticed is that then when you become, you join a faculty and you're working, that you start putting some of that knowledge or your approach to knowledge, or that intelligence aside. And you're very quick to believe something or to disbelieve something. And of course, there's an aphorism that we only believe what we want to believe. And so I'm just going to take you on a little journey here just to go through some examples of where I think that there have been instances where I think that we as cardiologists have failed. On the other hand, cardiology, we know, and particularly interventional cardiology, is so full of really well-run randomized trials. I mean, every week, and whether it's the Lancet, the JAMA, New England Journal of Medicine, there's a cardiology randomized trial. So I want to take you through some points about how to interpret the trials. There's so much content there, and so many of us can easily we're just going to look at the title, have a quick look at the methods and the abstract, and look at the conclusion, and it fits with the paradigm of how we want to treat a patient. And if it doesn't, we're going to ignore it. But if it does, we'll embrace it and say, yep, that means that I'm doing the right thing here. Keep an open mind. Stay curious. You don't have to accept everything. There are so many myths out there that have been promulgated over many decades. And again, we'll come back to that in a moment. I'm not a Twitter user, but I recognize that there's a lot of education and sharing of cases on Twitter. Just be aware, though, that those are unfiltered, but many people find it really fascinating. And many of my junior colleagues swear by this and come up with some great ideas. But I'm not going to spend any time on that because I'm just ignorant to that. But let's just take a few minutes to think about interpreting clinical trials, and particularly how you're going to use that information to continue what you're doing in practice or to change your practice. Really important, was this a randomized trial? Was it a non-randomized trial? Was it blinded or was it open label? Now, that may seem obvious, but many interventional cardiology trials, just by their very nature, have to be open label. So you think about PCI versus bypass surgery. It's open label, isn't it? I mean, it can't be almost anything else. Now, we've seen some sham studies now finding their way into the literature. But it was once said that if you want to prove anything, then run an open label, non-inferiority study, and perhaps you can be a little careless. And if you satisfy those three things, then you can prove almost anything. So be aware of that, particularly in cardiology, and particularly interventional cardiology, is full of non-inferiority studies. And they find something is non-inferior to something else, and then something else is compared to that one that was non-inferior, and you have this non-inferiority creep. And be very, very careful as you interpret that. The most obvious example of that is distal protection for vein grafts. You know, Eric, Olivier, you remember the Percusurge. You know, it was a balloon that you occluded, and then it was thought that it would be unethical to have any randomized trial against a control. So the control had to be that Percusurge balloon. But the Percusurge balloon, as good as it was a bit awkward to use. So it just went off to the side, and then we had all these non-inferiority studies of the various distal protection devices. And it would be very interesting, it's never going to be done, of course, is to compare, you know, the last inferiority study that proved that it was non-inferior back to the original control, which was the Percusurge balloon. What was the primary endpoint? And I'm going to give you some examples of this, because we're so quick to look at other endpoints and to say, well, that again proves what I thought all along, whether you agree with something or don't agree. Power, very, very important. What about surrogate endpoints? What do our patients really care about? They don't want to die prematurely. They don't want to have a heart attack. Those are the two main things. They also want to be free of symptoms. But do they care what their nuclear stress test shows after intervention? Do they care what the myocardial blush score was at the time of their infarct? Think about all the studies that have used these, and then go and prove that something is effective. Think about the hard clinical endpoints. And then finally, does it make a difference to my practice? Who routinely, when they look at a study, beyond the absolute differences, looks at the number needed, does a calculation, the number needed to treat? Just hands up. Who routinely does that? Okay, so about a third of you. Number needed to harm is the same, and then we can look at net benefit, and I'll give you some examples of this. How many of you then look at something and say, well, if I treat 1,000 patients, how many are going to get benefit? Who's gone through that exercise? Do you find it useful? No, okay. Well, then I'll give you some examples there. But these are things just to think about, because these are the things that you should then look at, all of these things, when you're looking at these trials and thinking about whether what they're trying to propose makes a difference. And then, of course, cost comes in. I mean, there could be a very small difference, but if the treatment's going to cost $200,000 a year for some various, a monoclonal antibody, then it's probably not worth it. So I'm just going to go back here, looking at the history of stents here. And this is something I put together for a talk a few months ago. And it's very interesting here because many of you in the audience have come in, maybe beyond 2009, 2010 or so. But many of us in the room here were right there at the very beginning, and particularly here in Switzerland, of course, which is where the first stents were developed and used. In those days, we would give aspirin and dipyridamole. Turns out dipyridamole had no effect. It came from some animal studies, pig studies, and they tried to prove that dipyridamole would stop thrombosis. It turned out that the pig studies at Mayo Clinic, this is Valentin Fuster and Jim Cheeseborough, then worked out actually after all those years that pigs, they don't even absorb dipyridamole. And so these came from animal studies. So that was sort of interesting. But these patients would be anticoagulated, have a stent, have a sheath left in all night. This was in the early days of PTCA as well. And everyone felt very strongly that you had to have a sheath in all night, and then the cardiologist would come and take the sheath out in the morning. And I can remember sitting in an audience with Urs Kaufmann and Ulrich Sigwart at I think it was an American Heart Association meeting, and there were data being presented, I think, from my institution, showing our horrific vascular complication rate with stents. And Dr. Sigwart was mortified, said, we don't do that anymore. And it took a long time in the States for people to move away from this heavy anticoagulation. And fortunately, with the work of Antonio Colombo, you really told us that, no, you didn't have to do that. So we went, using ticlopidine and then aspirin and with clopidogrel. Then along comes, more supposedly potent agents, prasugrel, ticagrelor. But they're only ever studied and approved for the use in ACS. How many of us use those drugs for people with stable angina, for elective PCI? I can tell you in the States it's almost routine. People just feel that that's a better drug, so they're going to use that instead of a cheaper drug such as clopidogrel. DAPT. You see that the duration of the antiplatelet therapy is there along the x-axis. And I have no idea why, honestly, I have no idea why, at a certain time, people felt that you needed to be on DAPT indefinitely. And so we would have patients, we just kept on it for 2 years, 3 years, and told they could never stop it. If you stopped it, you'd have a heart attack, you might die. And again, it then took a very large randomized trial to show that it probably wasn't of great benefit, particularly when we looked at second-generation drug-eluting stents. But despite that, so many of us just believed that you couldn't stop the DAPT and that you would just continue it, despite the fact that the guidelines gave it nothing more than a 2B recommendation. Again, I'll show you something which is sort of interesting that makes that point. Of course, now we've moved to short DAPT and shortening that. I mean, again, how many people are stopping DAPT after 1 month in this room? Very few of you. A lot of compelling data out there. And of course now the second generation, third generation drug-eluting stents are very, very good. But let's just keep in mind that the landscape has changed. Everything we know about ticagrelor and prasugrel comes from the Plato and the Triton studies. These studies were published 15 years ago, which meant that they were enrolling patients almost 20 years ago. Things have changed. We do a better job in the cath lab. We have better stents. We don't use 2B3 inhibitors very much at all. Stent thrombosis rates, probably about 0.5% now. It's going to be impossible to show a benefit or harm. We use transradial access. And I think what has really leveled the playing field is the increased use of statins, particularly high-potency, high-dose statins. So I just referenced the fact that monotherapy, there's lots of studies on de-escalating DAPT to monotherapy with a P2Y12 inhibitor. You're aware of this now. I'll just point out that these were open-label studies. As powerful as the message is, and they're all very consistent with no signal of harm, that you can stop DAPT and go to monotherapy with a low incidence of bleeding, which is really what the main thing we should be concerned about now once the patient leaves the cath lab. It's not stent thrombosis, it's bleeding. And so it's really challenged our belief that aspirin is the cornerstone of antiplatelet therapy because it's been there for so long. But how many people in the audience realize or remember that clopidogrel was never compared to aspirin alone in the PCI population? It was always aspirin versus aspirin and clopidogrel. So whenever we talk to a surgeon about a patient being on clopidogrel, the understanding, of course, is that they're also on aspirin. So something to keep in mind. But that's been looked at recently, another big Korean study, and I suspect, Eric, do we have people from Korea listening here, or maybe not, but maybe not. I think we have to be very grateful to the Koreans and the Japanese. So they've really pushed this concept. But you can see here a large randomized study, again, open label, comparing, and this is a PCI population, clopidogrel to aspirin, and look at this. There was no penalty to pay in terms of an ischemic or a thrombotic event, but there was actually decreased bleeding with clopidogrel versus aspirin. Who would have thought that? I suspect very few people. And I'll show you some more data. Here are data from large studies, randomized and double-blinded studies of thousands of patients. These are in peripheral arterial disease patients. These are high-risk patients. They're not necessarily coronary patients, but these are old studies. But the Capri study, now published 25 odd years ago, that clopidogrel was more effective than aspirin in terms of an ischemic event, and that might make sense, but the bleeding was the same. And so if you're having these conversations now about monotherapy, keep that in mind. Is ticagrelor a better drug than clopidogrel? What it wasn't in the Euclid study. This is actually a more recent study. Again, 13,000 patients. Some of these had PCI, but that wasn't the primary entry point. And ticagrelor wasn't superior to clopidogrel, and bleeding was the same. So something to challenge our thinking. So again, that's what I really want to get the message across here. Don't just take everything at face value or what you've been taught in the past. Things will change. Have a re-look at things. Look at it in a fresh state. Here's a slide of mine from a long time ago. Actually, I think I put this slide together even before 2011. But I just want to point out this was a discussion of primary PCI and STEMI with multi-vessel disease. And I want to draw your attention to the second to last row there. It was permitted if the patient was in shock. This was in the guidelines. And of course it was, doing multi-vessel PCI just routinely was a class 3 indication. But why was it a class 3 indication? People felt that it might be dangerous. There were no studies. We had recent studies, but I just want to focus on the shock thing here. Here's another slide, about the same time. And despite the fact that there was a large meta-analysis, and this is in patients with cardiogenic shock with multi-vessel disease, showing that there was a 30% reduction in mortality if it was culprit only. And yet, we would still have people saying, yes, but the shock trial told us that we should do multiple interventions on multiple vessels if the patient's in shock. And it was very clear from the shock trial. Anyone disagree with that? It was never studied in the shock trial. In fact, a lot of patients in the shock trial actually had emergency bypass surgery, and that's actually where the particular benefit was. There was nothing there about doing multi-vessel PCI, and in fact, in the shock trial, only 11 patients had multi-vessel intervention. 11. And yet in the guidelines it was telling us it was permitted. And the vast majority of interventional cardiologists said we should intervene on every single vessel because it says it there in the guidelines. And it was there, it was published. And of course you know that the culprit shock trial came along, an adequately randomized, powered study, looked at this, and again it's open label, but the patients who had culprit only had a better survival. And so finally we have good data here. Now, we can't have a randomized trial to answer every question we have, can we? But let's be careful what dictum we are going to follow in terms of people saying you can't do this or you should do this in the absence of any data. Here's another interesting study. So this is out-of-hospital cardiac arrest. These are data from Paris, 1,700 patients. The French have been very good at this. They've really contributed to our understanding of management of out-of-hospital cardiac arrest. But then the question is, do you do a routine angiogram on every patient? And I'm not talking about STEMI patients, so those who don't have STEMI, you take them routinely to the cath lab. And in this study, you can see here that, yes, the people who had PCI did better. But look at the people who had a diagnostic angiogram. They did better as well. That's not a therapeutic intervention. There has to be selection bias, doesn't there? And a number of cities in the United States, they would have hospitals that were blacklisted because they were not offering immediate coronary angiography, and ambulances would bypass them and take them to hospitals that would offer immediate diagnostic coronary angiography. And of course, the Tomahawk study shows that this, in fact, we shouldn't be doing routine angiography in the absence of ST elevation. And so there was no benefit. Pre-treatment of V2Y12 inhibitor. Again, I was just going to look at the guidelines here. The ESC guidelines 2 years ago, it's a class 3 indication. How many studies support that? And it's the ACOAST trial. To my knowledge, it's the only randomized study. And which drug did they use? The most potent, prasugrel. But we don't use prasugrel. And it showed that there was no benefit and the patients bled more. But one study. And it made it a class 3 indication. The American guidelines, interestingly, made no recommendation. They said maybe avoid prasugrel, but it was okay to use ticagrelor or clopidogrel. But they made no recommendation. So it comes from that one study. And this is interesting. I just came across this recently. So the Scandinavians have these massive national registries, and they do really well, and they capture every single patient in the country who has PCI or acute myocardial infarction. And they looked at 60-odd thousand patients. That was a retrospective study. And they found that if you loaded with a P2Y12 inhibitor, that it didn't improve outcome, but it was more bleeding. But I want to point out here that 65,000 patients, but 92% were pre-treated. I mean, again, there has to be selection bias here. The vast majority of patients were pre-treated. So what was it about the patients who weren't pre-treated? Was it because they were considered to be lower risk anyway, or I mean, who knows? But I think you, again, have to be very, very careful. So just to begin sort of wrapping up here, let's be careful about what we read and understand in the guidelines. We know that probably less than 10% of the guideline recommendations over the last 20 years are level evidence A. Less than 10%. There's biases, there's conflict of interest. You have a surgeon sitting around the table, they're going to have a bias. You're going to have an interventional cardiologist, they have a bias. And it's hard to get rid of that. And it's like a consensus expert opinion. Well, it really depends who's on that guideline committee. And they do fantastic work, but we have to be very careful. My father, who was not a doctor, is an engineer. Remember he telling me when I was in high school, he said that rules or guidelines were made for the obedience of fools and the guidance of wise men. Think about that. But here are temples that you can last hundreds, if not thousands of years, but eventually they decay, and our guidelines decay even faster. Here's some examples. Aspiration thrombectomy, the TAPIS trial. I'll just run through this very quickly. Meta-analyses. Not a single study did they use survival as a primary endpoint. And then they go and put it into a meta-analysis. The TAPIS trial, that was a myocardial blush study. But both the Europeans and the Americans put it in the guidelines as a 2A. And do you know why they didn't make it a class 1 recommendation? Because they recognized you might not be able to do it in everyone just for technical reasons. Otherwise, it would have been a class 1. And we know the end of the story here, don't we? The total trial, big, large, randomized study, showed no benefit. In fact, there was a higher risk of stroke. It's now a class 3 recommendation within a few years. So practice your changes. So again, be very careful how you interpret those studies. And I think it's really shocking that they got into the guidelines based on those studies. I talked about short DAPT. Look at the American guidelines here. I won't go into this detail, but there are some recommendations made that are not supported by any data at all. Now, they do say, well, you could go to monotherapy after 1 or 3 months. That's fine. Put them on a P2Y12 inhibitor. But why on earth would, at 6 months, instead of a P2Y12 inhibitor, put them on aspirin monotherapy? It's there in the guidelines. and they made it a 2B. I just don't know what the discussion was, but it doesn't seem to be supported by literature, and it's telling us that there are personal biases and again, sort of expert opinion. The European guidelines, which I won't go into, but for a change, they look more complicated than the American guidelines. DAT. I talked about the 1,000 patients. So for if you treat 1,000 patients with prolonged DAT over 12 months, this is what you can expect. You'll see 8 fewer MIs, you'll see 6 more big bleeds, and you'll see 2 more deaths. That tells us that 990 or so patients are doing just fine. Doesn't matter what you're doing to them. And yet people would stamp their foot and say, no, we've got to continue DAT long term. But this puts it into perspective. Power. Not many interventional cardiology studies will ever reproduce this. This is the partner trial, comparing to no treatment. We wouldn't compare that now. But to save 1 life, number needed to treat 5. You're not going to see that number again for a long time. To prevent 1 CV death, you only have to treat, again, less than 5 patients. The Pegasus TIMI study was using ticagrelor long term, 60 versus 90 after a year. You can see some, maybe some slight benefits there. But if you put the net benefit, take the number of MIs that you prevent, put the bleeding in, you have to treat over 3,000 patients to get net benefit. And yet, there it is, the New England Journal of Medicine and everyone telling in and asking me, why don't you keep your patients on ticagrelor long term? This is why. Last one I'll just show you, the Augustus trial, showing that aspirin added to an oral anticoagulant in clopidogrel, you only have to do that to 13 patients before you're going to have a major bleed. And yet, we still have so many of us are reluctant to stop the aspirin for at least a week or a month. And occasionally people say, no, you've really got to stay on it. And now ask yourself the question, what if aspirin was a new drug? You'd never heard of aspirin before. And they did this study to bring aspirin as the treatment group. The conclusion would be, it didn't work, it's not safe, never use it. But we are just bound, we have this allegiance to aspirin. And I see a world that we're not going to be using much aspirin in the future. I'll skip over this in the interest of time, but we know that for primary prevention, aspirin is pretty much out now. And again, just do your 1,000 patients treated with aspirin, primary prevention. You're going to have 3 fewer non-fatal MIs. 3 fewer if you're on aspirin. I think it was like 20 versus 17 or something. You're going to have 1 more fatal MI. There's no mortality difference. You're going to have 64 more bleeds. That's why it's really not effective. And you know what's happened? You know, we generally like to think that people are living a little bit more healthily. Not everyone. But statins, again, I think have just changed the playing field. Finally here, strive for excellence. Let us get away from knowledge and trials. This is talking about if, when you're doing the angiogram, you don't want to make your premature closure. You don't want to, you have a diagnosis in mind and you see something that proves it. Don't miss the SCAD. Don't miss the flush occlusion of a branch. Again, just excellence. You have a team that you're working with. Make sure that they're contributing as well. You're the leader of that team. And everything you do should be just with the idea that it's going to be something of really first-rate quality, and making sure that if there's, again, getting that second opinion, maybe we're not going to do ad hoc PCI and something that's really complex. We get more time to plan that if we can plan it before the procedure. Prevent complications. But we talk about that here. You ought to focus and concentrate. We shouldn't be talking about our kids' soccer games or some music concert that you saw. When we're in there doing the case, we should be focused on the patient and only the patient. You should know your equipment. And above all, remember you're a clinician. Put everything into perspective. Understand what the patient's expectations are. Think about shared decision making. These are all so important. And I'll just show you an example here. It's a patient I saw last week, actually. He was 83, and he was sent for PCI of a dominant circumflex with this CTO that had been recognized for about a year. And he had progressive dyspnea, and he had iron deficiency anemia. It was corrected, but he continued to have dyspnea. They did a stress test, showed lots of ischemia. It was recommended that he have PCI, seen by 4 interventional cardiologists. And I walked into the room the day before he was coming to the cath lab to talk to him. He acknowledged no angina. I get really suspicious when men don't have angina. If it's dyspnea, we say, oh, it's an angina equivalent. But is it? So there was something that just didn't seem right here. The gastroenterologist said, it doesn't matter. We found no reason for this anemia. You can go ahead and treat him. We canceled the study. I said, we need more information. And this is what we found. I don't know what the pathology is here. This is still being worked up. But he's not getting his CTO fixed. Be humble. Learn from others' mistakes. That's what we're going to learn at this meeting over the next couple of days. As invaluable as our industry partners are, they truly are. We cannot be doing what we're doing today if it wasn't for industry and for people like yourselves who are innovators. I think one of the game changers for me were guide extensions, guideliners. Just think about the things that really changed your practice. But just keep in mind, your interests are not aligned with industry. With all respect to our industry partners, our interest is a patient. They'll say it's the patient, but they want to make a sale. There is no question about that. And if they don't sell, they won't be there because they'll be out of work. So just keep that in mind. Again, valuable partners, but remember, they have different interests. And I'll just finish with these closing comments here. Bernard Lown died last year, and I think it's just worth remembering the motto of his institute. Do as much as possible for the patient and as little as possible to the patient. So as the interventional cardiologist, we don't have to go stenting every small diagonal branch and every little distal OM lesion. We want to make sure that we're doing the right thing for the patient. And one of the Mayo brothers, this is really what drives the culture at Mayo Clinic, is the best interest of the patient is the only interest to be considered. And the final thing here is, again, this is getting back to advice and experience, and it's not just my experience, it's actually watching other people's careers unfold. Your career should, it's going to be successful, but you should enjoy it. You really need to enjoy it. If you're not enjoying it, then you've got to ask yourself if you should be doing something different. And this quote comes actually a consultant who just retired from Mayo Clinic, not in cardiology, but she made this very important comment here. Your clinical practice will always demand more than you can ever give. And it's so true. So you've got to learn where to draw the line. So pay attention to your work-life balance and particularly take care of yourself. Because if you don't, there won't be anyone there to take care of your patients. So thank you very much, and happy to entertain any questions, but I think it's a talk that probably doesn't really need any questions. Thank you.
So thank you very much, Malcolm, for this brilliant presentation about experience. Without any further delay, I think we have to move on. Thank you very much, and I welcome Brahim, Harboui, Theodor, Iulian, Matei, and Geraud Souteyrand to chair the next session with the Thailand Society.
Hello, everybody. So the next session. Okay, we sit here. Okay. So we will start the next session with our friends from Thailand, who are connected, I believe. Hello, everybody. Hello, Mampech.
Hello, Brahim. Hello,
Good
morning. How are you? Long time no see.
So, can Mr. Purich, Surunchupakorn from the Central Test Institute, can you begin your case, please?
Okay, I will share my. Okay, should I begin or everyone see my slide?
It's okay.
Okay, see well.
Okay, see you. So I will begin now. Okay. Okay. So I thank you for inviting me to ECC conference, and thank you our chairman Dr. Wacin and Dr. Wirash to encourage me to share the case. So I titled this case "Unexpected Thai A lesion." I don't have any conflict of interest about this case. So my case is a 61-year-old female. She had risk factor of type 2 diabetes, hypertension, dyslipidemia, and presented with progressive dyspnea for 2 days. EKG was shown 30 kV block, day 42, and referred for permanent pacemaker implantation. So this is her EKG is quite slow, approximately 40 beats per minute with dyspnea and syncope. So we put on the temporary pacemaker first. So at that time, my electrophysiologist friend, he asked me to perform the cholangiogram before because she had a significant cardiac enzyme lysis. Echo was shown good RV ejection fraction. So CT was done in EP cath lab. Actually, there's some kind of pre-op before permanent pacemaker in the cath lab, in the EP room. So left main was non-sick and 90% LED stenosis at the mid part and 40% stenosis at the proximal part. So however, the RCA show 99% diffuse stenosis at the proximal part. It's quite tight. So at that time, my friend, he told me that maybe if I did the PCI to the RCA, patient might not need to put the permanent pacemaker in at all. So what will you do? You will immediately PCI to RCA as they ask you, or CABG because they are triple vessel disease, or the permanent pacemaker first, then state for revascularize.
Okay, so who will do a PCI to the RCA? Okay,
okay.
the majority, a CABG.
Okay.
And primary pacemaker.
Pacemaker.
Yes. Okay. Two. You can move on.
Yes. So may I ask that do you think that after PCI to the RCA, they will the complete heart block will go? I'm not sure, but I rarely see that except for the STEMI case. So however I perform PCI to RCA as he asked me to. So I think it's a quite Type A lesion. It look not too long, and maybe I can perform it in the EP cath lab, which don't have much intervention instrument, only the device and the EP catheter. However, after I put the guiding in and I try to balloon, so the balloon cannot dilate the lesion. So all can pass, but the lesion was undilatable, as everyone can see. So I moved the lotabrator machine to the EP room, and then I began to lotabrate. The patient already have the temporary pacemaker already, so I begin with 125 at 180,000 to 190,000, but Lota could not cause. So I maximize the load of the lotabrator up to 220,000, and as everyone can see, all the lotabrator and Y was jump out to the aorta. So what will you do next? Change to French guiding catheter, use mother and child catheter, change to extra support Lota Y or chain operator. Actually, I want to ask him to perform pacemaker first, and then I state PCI to the RCA, but he won't allow me. And all consultivity for cabbage again.
Yes, we will ask to the audience who will change the catheter and try again. Majority, yeah. The second option. Eric, you want to?
No, I just wonder how is the patient doing? No signs of ischemia at this stage when the whole thing jumped out. The ECG was okay.
ECG is a pacemaker rhythm, and the patient don't have chest pain. She in stable condition.
Okay. And who use extra support water wire? All body, all will try again with 7 French catheter.
You have to say 7 French backup guiding.
Okay.
Dr. Purich, you can continue.
So you can move on.
Continue. Okay.
And show what you've done.
Thank you very much for your opinion. So so my EP friend, he still persuade me to continue PCI. So I continue to PCI with French guiding catheter. I use the extra backup support guiding short tip L1. And I still use the Lota 40Y, I didn't change to extra support Y, and I begin to lotabrate again with the same speed, 220,000. As everyone can see, the lotabrator can go in, but it jump in quickly. However, after lotabrator go in, it cannot bring out. So the lotabrator was entrapped at the proximal lesion, and the guiding was sucked in like this. And while I try to pull the wire up to the lotabrator, and I try to pull everything out together with the guiding, as you notice, the burr was stuck. The guiding cannot bring out, and RCA almost evacuated to the aorta. So at this time, what will we do next? The Lota entrapment, and I was trying to bring everything out, deep guiding catheter, and pull the wire up to the tip of the Lota and bring out, and it still cannot bring it out.
So does someone have a solution or experience the same situation?
I think this is the typical complication of the stall burr. I think many people can give some advice. Yeah, please go ahead.
Yeah, maybe you can just insert a second wire and try just to go with the balloon and try sort of like dilate slightly and just pull it back. This is one of the tips which I just done before.
So it's suggested to put a parallel wire and to perform a balloon dilatation.
So maybe for the audience here in Lausanne, I would like to introduce the chairs in Thailand. We have Wacin. Wacin is the current president of the Thai Interventional Society, and Wirash is the previous president, and Mumpech is a colleague also in the board of the CIT organization. So maybe we'll ask, of course we have the very experienced, one of the most experienced Thai doctors here on the live in Zoom. Maybe we'll ask, maybe first Dr. Wirash, what you would do.
you. I think that in the rotablator obstruction, the entrapment of the spur, I also agree that we will try the second guide wipe and try to dilate the proximal lesion with the high pressure balloon first. If not success, maybe we have to proceed to disassemble the rotablator and use the mother and child to pull it out. Thank you.
Yes, I think that the step one is to try with the balloon, and after the mother and child technique could be the best at this time. So what was your work at this time?
Okay, so I perform as the Europa group recommend me. So if a stuck burr, call for surgeon, call for help, and use the second guiding catheter and perform the parallel wire and balloonate the proximal part. And if fail, so cut the shaft and put the guide extension in. So I perform as the diagram and as Dr. Virat suggested before. So I puncture the left femoral artery and put the other guiding in with which was a Sven French GRT 0.5. I used the Chiong Y, which was a workhorse Y, and then parallel with the first Y. So to begin with, I put the low burr at high speed and put it in first to prevent it move it from the stuck part to the distal part, and put the second Y in from the other side. And I used the 2O balloon, which was already on the table at 14 and 16 atm at the proximal part, but the balloon was ruptured because the peak of the calcium. So I changed to 2.5 NC balloon and try to dilate again at the proximal part. It was dilatable. So after that, I tried to bring the lotar burr out. However, the lotar burr was still cannot pull out. It's still stuck at the proximal part. So next step, so I cut the dive shaft of the lotar wire and then put the mother and child catheter, which was over the wire, mother and child catheter, and put in. I cut here and then snap here and then put the mother and child catheter in, like this. And then I put the mother and child catheter as deep as possible and bring the wire up to the tip of the lotar burr and then bring everything out together. So I was lucky, and after that I checked the flow of the RCA. There are severe dissection at the proximal part of the RCA up to the aortal ostial. But luckily that aortal ostial is only type 1. So not much dissection to the aorta. So after that I perform PCI and I do the IVAS. And as everyone can see, there are calcium crepe at the proximal part of the RCA. Some calcium nodule and 360-degree calcium. Yes, lady. I like a chunk of calcium at the eccentric part. I think the lotar burr is stuck here. So we'll explain in the next picture. So I continue predilate with a 3.5 NC balloon up to 16 atm. And then I put the two stents inside with a T5 18 and T5 13, and then post-dilate again. So final angiogram look good. So this is the hypothesis that Dr. Virat taught me about this case. So we think that lotar burr was entrapped in the calcified cap that I showed you before in the IVAS, and the Base of the rotor was stuck at the cave of the calcium. Balloon dilation was too close to the rotor burr, so it caused embedment the shaft and the shaft of the rotor burr to the calcium cave more. Mother and child catheter tip could hardly insert in the embedded plane like this. This caused the catheter tip look like rolling inward when pulling force applied. So my learning point in this case, stuck rotor burr is quite rare complication and nightmare for every rotator user. The event can be defined as entrapment of the rotation burr in a correlation with impossibility to rotate or retrieve the burr. Stuck rotor burr can lead to acute occlusion and sometimes require immediate cardiac surgery. If this situation happens, be patient and try to solve step by step. So in this case, other learning point for me is that I'm feel too impatient and anxious to move the rotor burr out. So while I dilate the balloon at a tight lesion and try to bring the rotor burr out, my last dilatation might embed the shaft of the rotor burr inside of the calcium crepe. That's why I was failed to move the rotor out with only parallel wire technique and balloon at the proximal part. So I'm too impatient and anxious about this case. So thank you for your attention.
Thank you very much for this nice case. Do we have a burning question in the audience?
Yeah, maybe we could ask Wacin, one of the senior doctor in Thailand, to explain to us what are the tips and tricks to anticipate a stuck rotablur, because we have seen yesterday several rota cases with some complications. Do you have any tips and tricks for us?
Yes, I think rotablator has been something that we're doing more and more in this drug-eluting age, as we attempt more complex anatomy. And I think one needs to know how to overcome or treat the complication, as demonstrated in this case. The stuck rotablur is something that you sometimes cannot foresee that it may happen, but you need to know how to get it out. And I think Dr. Purich has demonstrated, or one of his slides has shown various options that one may use. I think if the patient is stable, you relatively have some time to either call for help or look into what or how to fix it. But if the patient is unstable, and this particular artery causes a lot of ischemia, then it's going to be a bit more tricky. But I think the way he cut the rotablator and use the mother and child is technique one's need to know. That's all I have right now.
Thank you very much. I think it's a very interesting case because you show all the step-by-step techniques to treat it. I have one question for the rotator, for the burr. Somebody and colleagues advise a slow speed to cross the lesion. What was the speed of the rotablator at the time of the crossing?
20,000 is too much. It's the maximum speed that I perform because it cannot put inside the tight lesion like this. Usually I perform like 180,000, except for the case that it cannot cross the lesion.
And just
it's too high.
Last question. You said that you have cut the shaft. Was it easy to cut it? Because one time I cut myself when I wanted to cut the shaft.
So it's difficult, but because I perform in the EP lab, so they have the sister to cut the wire of the pacemaker. So I borrowed him.
So Purich, that's a very important remark. So they have device in the EP lab to cut. So I think next week I'm going to get these devices when we have to cut something. I just one question there. Has anybody used the STAR technique to retrieve during that suboptimal tracking and reentry? like a CTO technique parallel to the rotabur to retrieve. I know that some French, like Benjamin Fauré, has been doing that in Grenoble. Has anyone done that technique? I'm sure in Thailand you must have done that. No?
No.
No?
No,
So
I haven't.
we're going to go on with Michal Rezek from Santan University Hospital in Brno. Good morning.
Good morning, ladies and gentlemen. Thanks for the invitation. Thanks to be in Thailand. I never was, so I will show you a case from Czech Republic from myself, usual diagnostic coronary angio. Typical patient in a cath lab, a 70 years woman with dyspnea on effort, sometimes with chest pain, stress test positive with ST depression, hypercholesterolemia, hypertension. So usual patient. We use right radial access. Our usual diagnostic catheter is Tiger from Terumo, standard wire with the J-tip from Cordis. And by this patient, she had a tortuous subclavian artery, so I changed to hydrophilic wire, usual that we use. Also, our university hospital cardiology clinic, we do approximately 2,500 to 3,000 diagnostic coronography each year with dominant right radial access, and this hydrophilic wire are not used very often, but not in 1 to 2 patients in a year, so probably 100 cases per year we use that wire. And by this patient, the usual wire stay stuck in the tortuous right subclavian artery, as I said, and it was not possible to advance to the ascending aorta with the usual maneuvers, so I put the diagnostic Tiger catheter on the wire and tried to go on to pass this tortuosity. And then then I make quick fluoro with the diagnostic catheter. I see that I'm in the artery. I didn't capture this because it was fast to see that I'm in the artery. So I changed this to this hydrophilic wire and advanced this wire with mild resistance after some effort and go to the ascending aorta with the Tiger catheter. So I'll show you the first, it may be the last picture that I saw after this effort and after this diagnostic. So this was the first fluoroscopy injection, and I couldn't believe what I see, so I just pull out the catheter by reflex, what I saw. So this is captured after. It is not the cine when I do this first injection, and this was something I never saw. I hope I will never see again. So this was the first picture. We can have a bigger picture to enjoy the dissection and the picture. You can see the dissection on the CT that we did. That's from the other perspective. Some reconstruction. And on this picture, if you can focus on the right subclavian artery, it will repeat. There is some kinking, but there is nothing specific on the. You can even not see some dissection. The dissection is then seen in the brachiocephalic trunk. So, what to do? Patient is stable, complains of some mild chest pain, BP is normal. You see that we did the CT, so maybe. I'm not asking about the possibilities 3 or 4 because I don't want to know how many of you would fire me immediately. But let's vote who will send the patient for the operation without any hesitating. And somebody would watch and stay and take a conservative approach by this patient when you saw the dissection.
Maybe let's ask our colleagues from Thailand. Mimpech, what would you do? Can we hear the opinion of Mimpech?
I have never seen this before, but to me, it's like a Taiwan dissection. But probably the entry point is not in the ascending aorta, it's in the I think it's still in the brachiocephalic artery. So probably I try to seal the entry point at the brachiocephalic, if possible, by the stent, and I will check the CT after that, after the procedure, and if the serial CT show the progression, we have to do the urgent operation on the dissection.
Yeah. Just one, Christian Roglo from Lausanne. We discussed with my colleague Grégoire. It's maybe interesting because the entry point, it's a subclavian. Maybe it's not so difficult to close the entry point with a cover stent.
Yes, this could be the idea, but I didn't say. When I took out the wire, I put the pressure, and there was a normal arterial pressure when I start the injection. So before inject, I have the pressure. It was not that I was in some dissection. So I was thinking, okay, I'm asthenic aorta, I have a pressure, I start the angio. So the problem is what to do is I needed to consult a cardiosurgeon. It's not possible in our institution to see, okay, I will do it conservative and to say my colleague, oh, don't call to cardiosurgery and wait. So I did this consultation and it was quick. There was no discussion with the cardiosurgeon. He said, you really don't want to operate? So we can discuss, yes.
A great case, I guess, something that could easily happen to any of us. I mean, I would say depending on the clinical status of the patient, if there's no evidence of coronary obstruction with the hematoma, or there's no severe AR and the patient is hemodynamically stable and relatively well, the presumption is that you've got a retrograde dissection from your hydrophilic wire. So presumably that will eventually seal with time with antegrade flow. Do you need to do anything? I mean, obviously, I think you, as you have got a CT scan and consult with a cardiothoracic surgeon of some kind or vascular surgeon. But if the patient remains well, it's potentially an argument to watch and wait. I don't know what other people think.
I was a little bit hoping to be able to discuss with the surgeon if we can wait, because I was thinking also that it could heal. The patient was stable, but there was no discussion. As I said, it was. I had no arguments to not to do it. So this is what they did. This emergency operation. It was done the same day. And what was interesting, they described a small hole in the middle of ascending aorta. So maybe the catheter tip did out of the dissection and so there was also some communication in the ascending aorta. So the operation went well. They resected the dissected part of the ascending aorta, and the patient was discharged after 10 days. What was interesting, we didn't have the labs before she came to the cath lab. She had only stress test. She was anemic at the admission to the cardiosurgery. The coronary anatomy is still not known after discharge. Even from the CT, we can see clearly that the right coronary artery is completely normal. So this patient came again, and not to us, but to the cardiosurgery department for the check of the ascending aorta. The graft was normal on the CT, but she still complains of angina. So she was referred from the cardiosurgery to their cath lab, again for the coronary angio. They didn't use the CT to see the coronaries because they first make the CT to control the aorta, then they make the check of the patient. She complains, so she was sent it to coronary angio, and in the cardiosurgery they, on the first angio, described that there could be some left main osteostenosis, which is not very good seen, that there was no better picture. I took what I found from them, and so she was planned after consultation with cardiosurgeon and the heart team for PCI next day, not for reoperation. And then when they do selective cannulation of the left main, they finally found or we finally found that the patient has no coronary artery stenosis or coronary artery disease, but at the time she still had anemia and finally was diagnosed with chronic lymphatic leukemia. So my take-home message is simple. Even every procedure can have complication. We all know it. I will keep this in mind when taking the hydrophilic wire in my hands again. That is a dangerous tool. And when I was thinking of the patient, I think that the 2 last coronary angios were not necessary because the information was on the CT also to find. So sometimes we have to think what we want to know from the CT. And this is my last message, that for sure everyone thinks that this could not happen to me, and I agree strongly. I would think also. Thank you.
Thank you very much, Michal, for this beautiful and a little bit frightening case, I think, and which stresses out why it's important to have a surgeon friend around every time. So if there are any other questions, maybe? Okay. Thailand?
One here. Yeah. Do you think the hole they found was the exit point or the entry point? As some suggest that the entry point could have been, in the branch.
The entry point, in my view, was for sure in the subclavian artery, because it was also seen in the CT scans that there is a dissection of the brachiocephalic trunk, and it goes to the kinked part of the subclavian artery. So probably when I injected the first dye of the contrast, the tip of the catheter succeeded to go straight to this thin aortic wall, and that was the hole.
So probably the most dramatic aortic dissection or intimal dissection, intramural hematoma, whatever you want to call it, that I've ever seen. So thanks for sharing that. When you started talking about the hydrophilic wires at the beginning, I had a feeling this is what's going to happen. I mean, I could see it on your face. But the hydrophilic wires, I mean, I've avoided those even before I became a radiolist, a long time ago. So we're talking about like an angle glide. And this is a wire that's going to find its way outside the vessel, not infrequently if you use it enough. So I think it's something for everyone to be aware of, that the tortuosity up here can be really extreme at times. Most of the time, just with a deep breath, and then maybe a little manipulation of the catheter to help direct a more friendly wire, will overcome that. But you've just emphasized to me that I would still not use a hydrophilic wire here, unless it's a J-tip wire. So I think that this is something that everyone should be aware of. We see this in the femorals, we see it here, and you have to be very, very careful. I would actually also agree with Theodor that if the patient was doing well, maybe there was a case for observation, and it could heal, but you'd have to watch it very carefully. You're absolutely right, though. You need a vascular surgeon and cardiovascular surgeon on deck, and they make the final call. And I don't think anyone can fault what you did with the patient here. But thank you for sharing that.
Thank you for the comment. I, for sure, every time when I can't pass, I use this inspiration, deep inspiration. I did, for sure. And in my view, when I think of it, this was not a lady to be calcified with heavy tortuous vessel due to calcification and fibrotic plaques in the vessels. So this was a typical lady to cause dissection. That was the problem. In these ladies, we have to be very cautious and probably not to use it. Sometimes the hydrophilic wires by these calcified vessels, which are very tortuous, are very helpful and very fast passage. So it's the selection of the patient also.
Just a simple, basic question. I like to use a regular coronary wire when I have trouble, and it's rare to have trouble. I also never give heparin unless I'm in the aortic arch. I never give heparin before. Maybe I'm too precautious, but I don't know how many people are using regular 014 wires when they feel it's tricky. I'm not alone. Thank you so much.
I would say I use it even more often when I can't pass. I use the 014 wire, but sometimes I took, and it's not that often, but sometimes I take also this wire.
But
not.
That's just a great thing that you share this complication, because it happens maybe to you once in your career, but you're so proud.
I hope so.
You stand there to share it. That's great.
Thank you very much. It was an amazing case. So we will ask for Dr. Montrivade from Bangkok to share with us a case.
Okay. Good morning, everyone. My name is Dr. Sakolwat Montrivade from the Police General Hospital, Bangkok, Thailand. It's my honor to present at the ECC Conference 2022, and my case is entitled Parallel Canals and a Hidden Waterway. I have nothing to disclose, and this case is an 80-year-old woman with hypertension, lipidemia, and who presented with acute heart failure. On physical examination, she was not in shock, and there was an obvious sign of heart failure with congested lungs. And from the chest X-ray, you can appreciate a huge cardiomegaly here. And on the echocardiogram, her systolic function is impaired with LVEF of 32%, dyskinesis of anterior and anteroceptive walls, and a severe ischemic MR. So we brought the patient for coronary angiography, and this is the RCA. As you can see, we can appreciate the CTO of the proximal RCA with a limited flow downstream. And here is the left coronary system. From the caudal view, we got only intermediate stenosis of OM1 and left circumflex. But on the other hand, on the cranial view, you can appreciate the heavy calcification of proximal to mid LAD. And also, you can see that LAD and DG1 run parallel to the apex. So in this case, I think DG1 is acted as a dual LAD, like a second LAD. And also one thing to point out is that there's a collateral to the RCA via the LAD branch. Okay. For the PCI planning, this case is a flail elderly with low LVEF and has a cerebral disease with CTO RCA, high syntax goal, but I think she was not a good case to do a CABG. So we proceed to do CTO RCA first. Okay. At that time, my plan is to do the PCI of RCA first and then stage her for the PCI LAD and DG with a possible use of rotational atherectomy because there was a heavy calcification at proximal LAD. And for the circuit OM, just leave it like that because it was only an intermediate stenosis. So the PCI of CTO RCA is quite straightforward. We use a dual injection and then successfully passed the wire using anti-grade wiring approach with filter XTR in 5 class. And then we confirm the presence of luminal tracking. And this is the final result of CTO RCA PCI using only one stent, a 3.5 by 33 millimeter stent, and push still up to 4.5 at the proximal segment. Okay, and here is the from the after we open up the RCA, you can appreciate that the flow is now backwardly flow back into DG1 via this big marginal branch and epicardial channel here on the left-hand side. And then the patient was stabilized and scheduled for PCI of the LAD. This time, I was using a femoral approach, 7 French, and guiding catheter was SB 3.5, also 7 French. And for the dual LAD bifurcation lesion, at first, I planned to use a 2-stent technique because it was a complex bifurcation lesion. However, I could not cross the lesion, so I proceeded to do the rotational atherectomy on both LAD and DG using a rotor burr of 1.25 millimeter. Okay, so luckily I performed the patient of LAD is quite uncomplicated using 1.25 millimeter and high speed for 5 rounds at LAD, and then swap the wire to DG, and then also performed the rotational atherectomy on DG. Okay, and this is the immediate post-vertebration. As you can see, the flow is quite good, but there was some haziness around the bifurcation lesion. So I put in an IWAS to measure the size of LAD and DG. Okay, so for the LAD, as you can see, there was some dissection hematoma at the just distal from the carina, and also a heavily calcified proximal LAD. Okay, so I will show you the still image here. So for the proximal LAD, we can appreciate the heavy calcification in some area of ablated out plaque here on the left-hand side. However, the calcium was not fully fractured, and the EL size was 3.5. And this is at the level of carina. As you can see, there's some part that calcium was ablated, but the size of the carina is quite small compared with the proximal LAD. This is just distal from the carina. We appreciate the haziness here is from dissection and hematoma of the mid LAD, and the EL size at this point is 3.0 millimeter. However, just below this segment, the vessel tapering down into 2.0 millimeter. So this one is concerned with the negative remodeling of the distal mid to distal LAD here. And for the DG, it was surprisingly bigger than the downstream of the LAD with the EL size of 3.0. And here at distal DG1 is quite bigger than the distal LAD with an EL size of 2.25. So if we're going to do the PCI of this bifurcation lesion, our concern is the size of the carina and also the size of the distal mid to distal LAD if you need to put in a stent or do like complex anatomy lesion stenting. So I proceed with further pre-deal using a 2.0 NC balloon in the DG first, and then 2.0 again in proximal LAD. And then because from the IWAS, there was no evidence of calcium fracture, so I used scalding balloon 2.5 millimeter and SE alpha, inflated at the carina segment first, and then at the proximal LAD. Okay, and this is the immediate result of a scalding balloon predilation. This is a severe LS class 3 coronary perforation, and the patient rapidly hemodynamically collapsed. Okay, so as I mentioned before, my concern is the negative remodeling downstream at the mid to distal LAD, possibly like this in this figure. Okay, so how should we treat this bifurcation perforation? Our options is first to use a prolonged balloon inflation, or fully reversed with protamine using covert stenting. Call our friend CT surgeon to do emergency surgical repair, or just put it on ECMO and wait for stabilization. Okay, what do you all think about this treatment?
So what do you think we should vote maybe? If the public wants to raise a hand for the first option, prolonged balloon inflation. Okay, would anybody do protamine reversal? Okay, no. Put a cover stent. And emergency surgical repair? Nobody. And the ECMO wait for stabilization? Also nobody. So the vast majority is for a prolonged balloon inflation and a cover stent.
Maybe we could ask to the panel in Thailand. And the problem is, in this case, is hemodynamic instability. That's why maybe the first option is the balloon after to to go with a covered stand with a ping pong technique to go in the LED. We have a comment here.
Thank you for an excellent case. I just wondered, looking at the diagnostic angiography, are we sure of the anatomy here? Because I just wonder whether what you're calling the LAD is in fact a very large septal branch because of chronic disease in the LAD.
Could we see the first angiogram?
Because in some of the LAO views, it looks like what you're calling the LAD is actually a septal.
If I need to say, I think from the IWAS, I check LAD, so we see a pericardium also at the LAD. So I think this one should be in an epicardial vessel from the IWAS. But thank you for your comment.
Okay, thank you. Are there any comments on the panel?
Maybe some comments from the Thai colleagues, the Thai chairs. One point maybe is when you have a type 3 perforation, the first question is it a perforation or a rupture? If it's a perforation, then you know the technology we have. If it's a real rupture, it means that you have to do something quickly, because if it's rupture, whatever ballooning technique will never help, because you have basically destroyed the vessel. And then you need to know how extensive the rupture is and see if you can handle it with any percutaneous technique. That means covered balloons. Also, therefore, it's so important to know where is it bleeding. So that when I see this, my first question is always, where is it bleeding? So maybe my question to you, where do you think it is bleeding right now? If you can show us maybe again the angio of the perforation.
Yeah, from my hypothesis is that the rupture site should be just below the carina of the LAD and DC perforation, because from the IWAS, I think that it is at very high risk because of the negative remodeling at the size and balloon and vessel size mismatch. So it should be at the mid-LAD below the carina.
Can I confirm that? Hi, this is Raj. I'm not from Thailand, from Brunei. Can I confirm, at this point you had wires in both the branches, right? In the LAD and the diagonal?
Yes, yes, yes.
Yeah, so in real life, I think when this happens, we have to do 2 or 3 things. The first thing, as others in the panel said, get a balloon down, inflate it, and you believe it's in the LAD. It's difficult for us to see on the screen and confirm it. But if you believe the perforation is in the LAD past the carina, I think get the first balloon you have and inflate it and tamponade the perforation. And then it gives you time to think, and you can do a test and make sure the perforation is indeed where you think it is. And if the perforation is in the other vessel, then get another balloon there. And while the vessel is tamponaded, you can look at the hemodynamic picture, get an echo done quickly, and if there is an effusion, it's tamponade, you drain it, and by that time the surgeons arrived. And unfortunately, I've had a couple of these cases in recent months, so it feels like a flashback. So, and I think then you can make a decision on whether you need to go with ECMO or and if you need surgery at all. Look at what color covered balloons you have, covered skins you have in the shelf, and and try fixing it. That's probably the in real life, probably the sequence of events, I guess. One way to do it.
Can I make a comment here? I don't really understand the role of ECMO. You have a pericardial perforation, you have pericardial effusion, you aspirate it, the blood pressure becomes normal. It's imperative to put a cover stent and arrest the bleeding as soon as possible.
Oh, I completely agree. So ECMO is not the first thing I'll be going for, but I think it was mentioned previously. So those are things if you want to think about.
Yes. Okay.
Can we continue? Let's see what happened next. What did you do?
Okay. So as I mentioned before, the patient rapidly collapsed. So first, I agree with everyone here using a prolonged balloon inflation, as am I using an 2/0 balloon inflated at the subnominal pressure, and also pericardiocentesis is performed using a pigtail catheter and aspirate free flow of fresh blood. And one thing that is very good to do is to do the auto auto transfusion back into the femoral venous access. This way we can minimize the use of a packed red cell and the time to get that transfusion. Third is I fully reverse protamine, but we need to take the risk of catheter thrombosis. But I try to flush the catheter frequently instead to prevent this thrombus propagation. And also for the cover standing, the thing is that, as I mentioned before, this large diagonal is acting as like a dual LAD or second LAD. So if we put in a cover stand, it will totally occlude this large DG. Okay, so if the patient cannot tolerate ischemia from occlusion of this large diagonal, the condition could be much worse. So at first, I tried to first attempt using just a regular standing, because sometimes if the bifurcation flap, the perforation flap is still intact, sometimes it will put in a stent, it can seal some of them, but this one was failed as we all think. Okay, so normal standing cannot seal the perforation, even with multiple attempts of prolonged balloon inflation, full protamine reversal, and also the stent. So my last option is to sacrifice this large diag using a cover standing. So at that time on my shelf, I have a Graftmaster 3.5 by 90 millimeter, and I deploy a crossover from proximal to mid LAD and try to place it at the location that I think there was a perforation site. However, at first attempt, it was not sealed. So this time I pushed the dilate at proximal segment up a bit using a 3.0 balloon NC. And here we can appreciate the post-dilation of the proximal segment of the cover stents. And this is the angiography after we put in the cover stent. As you can see, we can appreciate that now the perforation was completely sealed, but we also completely lost this large diagonal. Okay, but fortunately, as if you can remember the result of PCI of CTO-RCA, okay, I checked the RCA, and then this time the collateral circulation from the marginal branch back into the DG1 is now backward flow back into the ostium of the DG1. So in this case, fortunately, we have this branch to prevent catastrophic ischemia of this large diagonal. Fortunately. And after that, the patient was stabilized, and from the repeat echocardiogram, there was no pericardial effusion, and her systolic function was stable as before we do the PCI, and her heart size is the same, and she can be discharged after a week, and I plan to optimize her HFrEF medication instead. I don't want to go back or do anything with her coronary again. So in this case, the learning point is that if we have a perforation at the bifurcation lesion, the main thing is to call the surgery first, because especially at the left main, that we cannot lose big side branch, surgery may be the first option. But if the side branch, we can lose it, we can just sacrifice it using a cover standing across main branch to the distal main vessel. And second is that this case has a 3 risk factor of perforation. First is the negative remodeling. Second is post-vertebration. Sometimes the vessel becomes very fragile and more susceptible to perforation. And third is the balloon vessel size mismatch. As I mentioned before, the size is only 2.0, and I use a scoring balloon of 2.5 millimeter. And lastly, this type of severe perforation, we need cover standing. but we may sacrifice the side branch if it was a bifurcation lesion. Okay. Thank you.
Congratulations, it was an amazing case with a very good result at the end. It was very difficult. Sometimes when you have the collapse and you have a step patient with a balloon, it could be difficult to withdraw the balloon. And in that way, you could go with another catheter to put another wire to go with a covered stent. It could be an option. So is there any comments on the case? Yes?
This was an 80-year-old female who presented with heart failure. And we have no evidence as to whether there's a viability in the LED territory. I've not seen a report of a CMR showing viability in different areas. I think this patient, if it looks like there's an apical infarct and the LED territory was not viable, probably this intervention could have been avoided in an 80-year-old female. Just a comment, that's it.
Yes. I agree with you.
Could I hear the opinion of the panel and the various panels on the protamine, timing of protamine, because there's quite a few guidelines now suggesting that we should not use protamine at all.
Yeah, well, I personally do not use protamine with perforation unless it's desperately needed. Pericardiocentesis, leave the catheter in the pericardial space is what I would do with periodic aspiration and try to seal the perforation like Dr. Montrivade did. I have one question though, or two questions. When you do the prolonged balloon dilatation, did you inject and kind of prove that the perforation is right where you think it is? And number two, if you do have a cover stent, a length and the size that you could deploy just distal to the bifurcation, would that or should that be considered, or would that be too risky?
Thank you for the question. The first, the balloon is, I checked with the angiography and I confirmed the presence of perforation at the distal part of the carina when I inflate the balloon across the bifurcation lesion. And for the second question, as I mentioned before, the 3.5 is only one in the shelf, but if I need to choose the size myself, I will maybe choose a 2.5 or smaller size stent, and then maybe postulate it up a bit at the proximal part instead. But I only got a 3.5 at my cath lab at that time.
Yes, the issue is, I don't know, is the situation in Thailand, because in your country you have restrictions and only if certain stents are available. And I don't know what's the situation in some countries, but it's true that the graft master is completely outdated in coronary practice. I think everybody agrees. The stent, this layer structure, what we need with covered stent is to have it relapposed, well-sized to the vessel, so that it can really exclude and really close the rupture. The reason here it was rather ruptured than a perforation. That's why losing your time with balloons is sometimes not the issue. And people say that stent thrombosis is high with covered stent. The current generation of covered stents give excellent results. There are 3 brands on the market with excellent trackable devices that we should use. And then I look at our US colleagues, because I know FDA is making life terrible in the US. Do you have a modern covered stent, Malcolm, at Mayo?
Finally, yes. So we had the graft master sitting there, and hopefully you never had to use it. But we used it in a few cases. But no, we've got better balloons now, so we're not using the graft master anymore. The question came up about protamine. I mean, can we reach a consensus in this room about whether we should be using protamine or not? Because I can tell you that we've been going backwards and forwards of this over the years, and particularly when you start talking about the graft master, your concern about stent thrombosis in that particular device. The other issue, though, is, and we've seen this in various emergencies when they've got pericardial tamponade. that if you've reversed the heparin, the blood's still going out, but then it becomes just a big coagulum, and you can't actually remove it, and that can cause hemodynamic collapse. So in recent years, when we've discussed these cases at Mayo Clinic, we've generally now sort of said, we're not going to use protamine. We can just continue to do it and just focus on the mechanical thing of, I agree here, though, that the balloon was needed initially just to try to stabilize things, but very quickly you got to put a covered stent in. I had a question, though, and first of all, congratulations. I mean, you saved the patient's life. I mean, this is a horrific complication, one of the ones that we really fear, like having a rota burr stark. I mean, this is in those lists of really horrific complications. But you then excluded the large diagonal branch. And I'm just wondering, who's had experience here with, not particularly in this case, but you made the mention about like a left main bifurcation of actually them perforating the covered stent to then reestablish flow, let's say in the circumflex. My experience is zero. I hope it will remain zero, but I'm just wondering who has that experience and how easy and how hard was it to do, and what tricks could we learn?
I've seen several cases in the early days at the complication sessions at PCR, mostly from, you can imagine, our Japanese colleagues. So they don't bother. They just go for CTO technology, open up the cover stent, and it works. I think with variable success, those cases where they fail, they will probably never be presented at meetings. So, but they exist, I think. But for the protamine, maybe let's ask Wirash. He's one of the most senior cardiologists in Thailand. What is your vision on protamine and perforation?
Yeah, thank you for the question and a very nice case. In my opinion, I think protamine should not routinely used. But in case that we have the very serious hemorrhage, sometimes we will partially reverse, but not totally reverse. So this is in my practice. But if you think that you can control it with the cover stent, I think better not to reverse to avoid the stent thrombosis. In this case, I have another question and another viewpoint, because this is a bifurcation perforation, and I'm not sure that it's exactly really the perforation is at the negative remodeling, because it's look in the IVAS is far away from the bifurcation. But I think that the bifurcation itself, the main branch after the bifurcation, the carina, have a very severe calcification, and I suspect that that is the point of perforation. In my view, I think in this case it's a bifurcation, and if you already have see a good collateral from the RCA to the diagonal, sometimes I will assess this patient with the ping pong technique to use another guiding to assess, to help to assess the balloon and the graft stent. But before do a ping pong, I will inject the right choreangiogram while you occlude with the balloon to see whether if there are some leakage from the side of diagonal, to ensure that if you put a graft stent across the LRD bifurcation, it will completely seal. And the other question from Dr. Eckhout, that the bifurcation stenting with the cover, I have only one experience, but failed to penetrate the sideband with the very steep CTOY. I think this is depend on the angle of the bifurcation and the sideband takeoff, that is suitable for perforate with the penetrate with the steep Y. So in that case, I lost the patient. And in my opinion, if I have to do that again, sometimes I will do something like the Sabo technique to penetrate the the cover stent first before put in the bifurcation. This is my opinion. Thank you.
Thank you. Thank you, Dr. Montrivade, for a beautiful case, who started all these discussions. And we invite Dr. Rajinikanth Rajagopal from Brunei to present his the next case.
Thank you very much. We'll bring my case up. Right. My name is Rajinikanth Rajagopal, with the name Raj. Well, I would like to thank ECC for inviting me to give this talk. It's a real pleasure to be here, albeit online, with some old friends and new friends. It's great cases and learned a lot, so I hope I can continue to keep you interested. So my patient, the topic is cardiogenic shock CTO and an unexpected complication. Well, I'm not from Thailand. I'm from a place called Brunei, which is about 2 hours from Thailand and from Singapore. But we work very closely. Dr. Wacin and Dr. Wirash, we tend to meet every few weeks or months for various meetings. So it's a pleasure to be here. So my patient is a 45-year-old man who was referred with ischemia and ST elevation in AVR. He was hypotensive when he came to the emergency department, was started on dopamine and transferred to us, diabetic, smoker. When he came to the cath lab, his BP was 74 systolic, drowsy, heart failure. He was hypoxic. His ABG showed a PO2 of 60 on 100% oxygen. The ECMO team was activated and we started the procedure. So the diagnostic angiogram is shortly assumed non-culprit artery first, and you can see there is a CTO in the mid-RCA, but there is antegrade flow and the RCA continues to give collaterals to the LAD. And not surprisingly, the left main was occluded completely with a little bit of flow in the distal vessels. So this is the uncomplicated part. This is the complications meeting. The PCI to the occluded LMS was what we did first. Went in, got a wire, it went into the LAD. We ballooned with a 2.5, restored flow, and we used a 3x18 drug-eluting stent and ballooned, and then we put in, 3x18 and deployed it. And you can see that's a flow. It's not great, but that is flow. By this point, we inserted an IABP from the left femoral artery, and we started further inotropes. The ECMO team was still on the way, and they were about here at this point. And patient went into VF. We delivered DC shock. The BP dropped further, and patient was going into PEA. We decided to start ECMO. The patient actually arrested. We started chest compressions and managed to get a VA ECMO in. We swapped the IABP sheet for an arterial cannula, put in a venous cannula. Then we did further PCI to the left main LAD. There was thrombus in the left main LAD. We aspirated it. We put in another drug-eluting stent further down in the proximal LAD. We post-dilated in the left main with a 4x8. We did the circumflex. We just did a quick pour bar. We're not going to do anything fancy there. And this was a final result with decent flow from the left main into the LAD and a little bit of flow in the circumflex. We transferred the patient to ICU to stay on ECMO and ventilation. Decided to give agrostat and heparin for 24 hours. And then we brought the patient back for PCI to the RCA 3 days later. And this is where we had the complication. So this was the first picture. We used an AL1 guide, given that the CTO might be quite tricky. And we took a first picture. Some of you may have noticed something wrong with this picture. If you didn't, it will be clear now. So we had a big dissection of the aortic cusp. If you look at the first picture on the left, you can see that even with the first injection, there is a little bit of dissection from the ostium of the RCA spreading into the cusp. At the time, we were paying more attention to the CTO and whether it's microchannels, bridging collaterals. And we went on to take a second picture. And clearly, the contrast is now filling the right coronary cusp. And it's a bit like, I wish I'd used the word horror like the previous speaker had done. And this was absolutely one of the worst moments of my life, just seeing this. So we had a large dissection in the aortic cusp. Luckily, the patient happened to be on ECMO intubated. So we are able to drop a TOE probe now into quickly and confirm there was no effusion. We also made sure there was no significant aortic regurgitation. And the plan was to stent the ostium to seal where we think the dissection is. Although it's right at the ostium and the dissection is mostly in the cusp rather than in the artery. But to do that, we need a wire into this RCA to deliver the stent. And and the wire needs to cross the CTO and needs to be in the true lumen. At the oscium, we need to make sure we don't enter into the dissection. So I switched the guiding catheter, took out the AL. We didn't really have any kind of engagement or support, so it made no difference replacing the guiding catheter. So put in a JR4 guide, negotiated a PT2 wire. Of course, during this point, we cannot inject any contrast because we risk making the dissection bigger. So based on the diagnostic angiogram, we had to manipulate the wire. So the wire only got this far, as you can see in the picture here. And I tried to pass a stent. Obviously, the stent wouldn't go, that would have been too easy. There was no support in the wire to pass the stent. And so the only option was to cross the CTO to get more support so we could place the stent. I had to confirm that I was actually in the true lumen, even proximal to the CTO. So I passed, I don't have the picture here, but I passed a fine cross over this wire, took the wire out and took an injection, and it confirmed that we were in the true vessel proximal to the CTO, as that vessel filled, and it also filled the CTO antegradally beyond the occlusion. So the next point was to cross the CTO. So now that we had a fine cross right at the proximal cap, we used a Gaia second wire to cross the CTO. As soon as the wire went in, even on the Gaia, placed a resolute, 2.5 by 12 drug-eluting stent at the ostial RCA. And when this, until this point, we had not taken any injections from the guiding catheter. So once the stent was delivered on the same stent balloon, using the balloon, I delivered a guideline, a guide extension into the, through the stent and into the proximal vessel. And with this guide liner in place, I was able to take test injections and balloon the CTO. And the rest of it was fairly straightforward. Then deployed a 2.530 drug-eluting stent. The oscium was post-dilated and flat with a 2.75 balloon. And that was the final picture of the RCA. You can see it's not a massive RCA, but so that finished. And 2 days later, I brought the patient back to optimize the LAD. There was a large clot in the proximal LAD. The left main stent was undersized, underexpanded. If you remember, I used a 3.0 stent, and that is probably not the right size for a middle-aged man. It should have been bigger. Aspirated the clot, post-dilated, and I realized that there is only so far I could expand that particular stent. So I put in a larger 4 by 12 stent and got a reasonable result. And that's not the best picture, but the stent deployment was good, and we had TIMI3 flow. Did serial CT scans for the patient on the same day post-procedure and on day 1 that showed resolution of the dissection. Of course, we saw it on the DOE on the table. We did serial echocardiograms that showed there is no pericardial effusion. The patient was weaned off ECMO and he was discharged home. He survived for a few more months, but he remained quite ill subsequently, and it did pass away. This was about a year ago. 1 or 2 years ago, we did this case. So for me, the learning points, we all know that with an Amplatz guiding catheter, you could get catheter-induced dissection. It's an infrequent but potentially fatal complication. And we always have to have extra caution. Doesn't matter how many procedures we do. And this was a bad situation to be in, but with careful use of wires, microcatheter, guide extensions, we were able to negotiate this combination, quite nasty combination of CTO and ostial and cuspal dissection. So I thought I'd share this with you and pick your brains, and look forward to hearing your views on how, on the case. Thank you very much once again, Eric and the ECC organizers, for having me here.
Thank you very much for this amazing case. Do we have a burning question in the audience or in Thailand? I have one question, perhaps. We have seen many cases of right cusp dissection. Do you have experience with left cusp dissection?
Personally, not yet. Right, yeah, funnily enough, I think it may be just the fact that we tend to use Amplat's guiding catheter for the RCA. You think you jinxed me, I'm going to be scared from next week. Maybe that's the factor, because we use Amplat's for the RCA and with a double bend guiding catheter. I think I did some literature search before this, and I think it's quite much more common with the RCA. Personally, I haven't. I don't know, Wacin, Wirash, you guys do some very complex cases. Have you got any?
Yeah, I suggest to
Thank you for your nice
Wirash.
case. Yes. The most of the aortoosteo dissection is from the right. According to the manipulation of the guiding catheter, you have to do quite not as convenient as the left one. But I have seen a case that it used the extra support backup catheter for the left PCI with the side hole, and during the procedure, the operator did not realize that there has a catheter cross pressed against the osteo of the left main, and the final shot for the injection caused a dissection as well. So this is only the case that I saw for the left chori osteo dissection. But that case we can treat conservatively, and the patient survive. Thank you.
We had a case in Lausanne a few years ago where we had both, during a CTO of the circ, both by forceful injection, probably not well aligned, both left main occlusive dissection, so the flow to the LAD was gone, and aortic dissection. So that was quite a scary moment. We had very few time to solve it. We were lucky to get the wire through. And the patient was still perfectly well. She started to get broad QRS complexes, pressure was going down. Everybody excited. The patient was looking at us, didn't know what was going on until she gently started to shake, but we were able to get the stand down. So I've seen over the years quite some left main dissections with potentially going into the aorta. And once again, the message is the same. Our threshold to put a cover stent at the ostium of the right is a bit lower because, of course, you think you have less risk to feed the bleeding of the aortic dissection, while on the left, of course, you can't do that. But most of these dissections, as said before, and as we saw from the case from yesterday, they will heal. Yeah.
I'd like to add please.
Just one comment. Sometimes it must to be vigilant when we think about the occlusion of the left main, because sometimes you have a aortic dissection with occlusion of the left main, and you are in the false lumen. You think that this is the thrombotic occlusion. So in the beginning, when I saw this case, I think it was some kind of dissection near to in the end of the left main. So think about aortic dissection.
That's a brilliant point. I've actually had a similar experience recently when a patient was referred to us for an angiogram who turned out to have an aortic dissection. And it was like a perforated flap in the aortic dissection. So we were able to, I think we were going from the true false lumen into the true lumen, and managed to engage the coronary arteries. And it was exactly like you said, it gets some very funny appearances. And it's pertinent to think about aortic dissection. It's a great point.
Okay, and another quick comment or question maybe. When you did a CTO of the right coronary artery, the patient was stable. Did you ever consider just starting by rechecking the left coronary? And I don't know, because without a dissection, maybe you could have left the patient on anticoagulation for some time and to avoid to stent in a big thrombus in the LAD. That's another strategy.
Oh,
maybe.
right.
I don't know if it's right.
Yeah. Yes, I'm just trying to get my... Yeah, so if I had checked the LAD first and seen that was thrombus, I could have treated that first and then brought back a few days later to treat dossier CTO. I think that would have been very, is that right? That's a question, right?
Yes, just leaving the CTO for later, for another time. And
I think it would have been quite reasonable. I think what we thought was that there was ischemia. I think we thought there was significant ischemia and we wanted to achieve something close to complete revascularization. The circumflex we knew was a small vessel. Well, it was, we had done a POBA and it was, we thought along with the LAD, we should probably have the RCA open to improve the chances of myocardial recovery. How accurate that thinking is, I'm not sure. I think the other option would have been quite reasonable to anticoagulate first and plan the CTO later.
Thank you.
So I also had a case of a left main dissection coming up into the ascending aorta. It happened to be an older woman who actually was the mother of one of our perfusionists in the operating room. So it was an awkward thing, but she was too old for surgery. We couldn't completely seal it, and the dissection had come all the way up the ascending aorta. We treated that conservatively. I thought it was the first one I'd ever had. I thought she was going to die. But 1 year later, she was still alive, and she eventually died of non-cardiac causes. I want to go back to Christian's comment, though, about aortic dissection. So it's so important because, again, we always think of atherosclerosis. And so if it's a young patient, if they have a history of a bicuspid aortic valve, I've seen one of those, and no one thought about dissection. You know, there was no calcium. It was an dissection. Osteoocclusion, and the diagnosis wasn't made, and it was an aortic dissection. The other condition to look out for, and perhaps I'd like to ask our Asian colleagues whether they have seen this, and that's aortitis. So there was a case shown at ESC a few years ago, and it was again, it was a diagnosis that was made sort of later, but there was someone who actually had Takayasu's aortitis. So if you see unusual findings, and if it's osteo and you don't see calcium, it's a younger patient, you should always be thinking about these other unusual things. But maybe the question to the panel here in Thailand and Brunei, have you seen cases of aortitis with with coronary occlusions?
I'll go first. I don't. We usually see a burnout Takayasu. At one point, we thought we may still have, syphilitic aortitis, but never been able to prove it. So I guess no. The answer to your question is not in my experience that I've seen active aortitis with Corey problem. I don't know whether the other panelists have seen it.
I have never seen too.
I haven't seen. Oh, yeah.
But the occlusion is down below at the descending aorta, so I can access the coronary using a radial approach. And I did a CTO LAD, and the patient presented with heart failure with impaired EF. But luckily, I can access it, coronary using radial approach.
I have one case also 4 years ago with the CTO RCA, but I can access the RCA without any problem. And she also have a bilateral renal stenosis, which was done renal stent. Okay. No problem with the access time.
Great case. I just wondered, in this case you used ECMO, which is a great life-saving mechanical support technique. Could impeller have been an alternative? Do you have access to impeller? Do you use it much? And it's potentially something that you could introduce more rapidly in the cath lab.
Yeah, absolutely. We are just in the process of getting impeller. It was supposed to have arrived. We were supposed to start an impeller program 2 years ago, but everything slowed down because of the pandemic. So we've been using ECMO. We should have impeller in the next couple of months, and I do believe that would have been quicker. Yes, but hopefully we'll have it in the next 2 months.
Okay, thank you. So Eric, you want to say a few words?
You can conclude the session, and I'll just have some housekeeping for after the break. Or you want to? Or I conclude also if you want. So I think I would like to ask all of you for being there, massively present. I also I would like to thank Malcolm for the lecture. I think this year we're doing well. We are more on time. That's great. Thanks to our great chairs. Thank you to all of you in Thailand. For those who know Thailand only about the beaches and the magnificent buildings, there are excellent cardiologists over there, and you have seen a very nice presentation from them. So a warm thank you and a warm applause for our colleagues from Thailand.
Thank you, Eric, and thank you, ECC.
We will have a break now, and I really invite you to be back at around 11. The first speaker is Marc Noppen. Marc Noppen, I have a bias there. We studied medicine together. We know each other for more than 30 years. He's a pneumologist. He's a professor of pneumology. And he became, about 15 years ago, the CEO of one of the biggest hospitals in Brussels. And he got very involved in the pandemic, and he had to steer his hospital, more than 1,000 beds hospital, through the pandemic. He was, all of a sudden, became very famous in Belgium. He was on television all the time. He wrote a book. And he will speak about, we will see. And then the second speaker is Mauricio Tamarasso. He's a brilliant surgeon, but he's a kind of interventional cardiologist. So he's going to convince you that you can do both. So 2 challenging lectures from 11 o'clock. You can ask questions, be polite, but don't hesitate to ask some nasty questions too. Okay, see you after the break.
Hey guys, nice meeting up. Thank you.
Yeah, I think we have both chairs here. Daniel Weinemann is currently the chair of the Swiss Interventional Cardiology Working Group. He's based in St. Gallen, which is, I think, like a daytime trip. It's the other side of Switzerland. It's a very nice city, and he's mainly interested in the setting of CTO. And Daniel will also be chairing the Swiss session this afternoon. Chi Yang don't have to present anymore. He's not on mute. He's here. He's present. I'll hand over to you, but I'll introduce first the both speakers as I did before the break. Also, there will be, as said before, there is still ongoing a microcirculation session organized by Abbott in the other room with Bernard de Bruin. Bernard will join this afternoon here in a session, and I asked him, Bernard de Bruin, to talk about the perseverance and the difficulties he had to implement physiology into the cath lab. It's a story that has been taking, I would say, almost more than 25 years. So the first speaker is Marc Noppen, as I said before. Marc is we trained together. I'm basically Belgian from origin, and I came to Switzerland in '91. But Marc was, we studied medicine together, and then he went into pneumology, and I went into cardiology. And he was basically a little bit comparable to us in terms of interest. He was an interventional pneumologist, so he used to stent into this pulmonary system, so he knows what it's all about. And quite some years ago, he took the opportunity to become CEO of a large university hospital in Brussels. And as I said before, he was instrumental in managing a large hospital throughout the COVID crisis. Was very often in the media, on television, and even wrote a book about that. So I don't know if he can go. Oh, you're there, Marc. Yeah. So, Marc, I said a lot of good things about you. I'm sure you will not disagree. And you're in front of an audience that is very heterogeneous. We have people from everywhere in the world. We have the co-chair of this meeting, Marc Ambel from Mayo Clinic. We have Daniel Weinemann, who is the Swiss, actually president of the interventional cardiologists. We have Chi Yang from Singapore Heart Center. And then we have colleagues from everywhere, South Africa, India, Brunei, a lot of European people. I forget a lot of people, but I think it's time to give you the word. And you have plenty of time. We have scheduled a bit more than 1 hour for 2 lectures, so take your time. And we'll have also time for discussion and after your talk.
Okay, thank you very much, Eric. It's good to see you back. We indeed have a long history together, and thank you very much for having me. And I would like to grab the opportunity to maybe give a little bit of philosophical point of view on serendipity, innovation, and management of hospitals. And maybe it can be inspiring, can be of some inspiration to some of you. I will now share my presentation, if I'm allowed to, and I hope that this is visible to everybody. I guess it is, because I don't have any reaction here, so I think I can go on. So the title of my presentation is Serendipity, Connecting the Dots, and the subtitle might be See Bridges Where Others See Holes. I'll start my story with Alexander Fleming, whom you all know. He was the discoverer of penicillin. But actually, the discovery of penicillin is one of the typical examples of the role of serendipity in medicine, because he was not looking for an antibiotic. He was a physician who was involved in the development of antiseptic products to treat wounds in soldiers at World War I. And one morning he discovered this on his desk, namely his Petri plates with normal bacterial colonies. And actually there was an accidental infection of these plates with a mold. And normally he would have thrown this away like everybody else would have done probably, because he couldn't use it anymore. But then he remarked that in the area just below the mold, there was no bacterial growth. And he found that particular, and then he isolated the mold. And of course, at the end, it turned out to be penicillin. So this is a very nice example of a solution of a problem where he was not looking for. And this is actually the definition of serendipity. And many of the major breakthroughs in medicine or discoveries in medicine were made thanks to serendipity. The invention and development of X-rays by William Röntgen is a nice example. The accidental finding that washing your hands prior to delivering babies from mothers reduces the number of infections and deaths in that period of time due to perinatal infection by Semmelweis, and many other innovations in medicine. And not only in medicine, I'll come back to that, are made thanks to this attitude, actually, or this propensity of serendipity. And maybe in industry, one of the nicest examples is the invention of the Post-it that we all use every day. It was an accidental finding by Spencer Silver, who you see here was a chemist at the 3M company, and he was looking for super glue. And then he developed a number of glues, and he found one glue that would stick paper to surfaces and could be very unsticky when you removed it again. And he had no use for that until many years later, another collaborator of 3M, Richard Frey, he was a singer in the church, and he was looking for something to put into his Bible and in Psalm book, and to find the right pages. He was looking for something, and he remembered the discovery of this very odd paper, and then he used it as a bookmark. And so suddenly they saw the light and said, there might be a market for this. And actually the Post-it market is more than $1 billion per year, thanks to a stupid, between brackets, discovery that was first considered useless and then found a very large use in the world. Now, as Erik said, I'm a pulmonologist by training. And I was very interested in interventional pulmonology, as he mentioned, and meaning interventional bronchoscopy, but also thoracoscopy and pleural disease. And one of my nice examples of serendipity in my career is the problem of the primary spontaneous pneumothorax occurring typically in young women or young men. And it's the sudden collapse of one lung. And the standard treatment at that time, when I was a pulmonologist, which is a long time ago, the standard treatment was inserting a chest tube via a very small surgical procedure, or often performed also by pulmonologists. But it's quite a large tube to put in, and it's very painful in young people to have this tube in place for 1, 2, 3 days. And when I saw this, I was wondering, why are we using these garden hoses, these very large tubes, to evacuate air? Because air is, you don't need a big tube to evacuate air. And I was doing some research on how does this happen? Why do we always everybody in the world use these large bore tubes to evacuate air? And then I found that actually this was developed by military surgeons on the battlefield in the Korean War, where they had a number of young people who, by the way, also have spontaneous pneumothorax, but they had pneumothoraces because of shrapnel and explosions, etc. And so they had air in their pleural space, but also blood and metal and dirt, etc. And so they had to put in large tubes to evacuate all of this. But the act of putting chest tubes and evacuating debris eventually was used as a standard treatment to evacuate simple air in simple pneumothoraces. And I was discussing that with my friends surgeons and pulmonologists at the bar of the conference and zipping at the mojito with a straw. And I had the idea, why don't we use a straw to evacuate the air of the pleural space? And we tried it out in a few patients, just a very, very, very small intravenous catheter that we used to aspirate air. And with some crazy friends in Belgium, in the very young Interventional Pulmonology Society, we performed a prospective trial because we were an academic hospital. And we did the first series of about 60 patients, which were randomized with a typical large bore surgical tube evacuation and the small catheter aspiration. And actually, the small catheter aspiration worked at least as good as the big tube, didn't cause any pain, and the 2/3 of the patients could go home the same day. So this was a big improvement. And one of the things I'm proud of is that this discovery, which was made actually by serendipity, led to the change in the international guidelines of the management of spontaneous pneumothorax. And I have another example. Since I was an interventional pulmonologist, I followed a training in Marseille with Professor Boutin, who unfortunately has passed away already, but he organized hands-on courses in thoracoscopy in Marseille. And I was there to learn the technique. And I saw him perform a cauterization of the sympathetic nerve, which was actually good visible during thoracoscopy. And I asked him, why do you do this? And what indications? Well, he said, there is an indication of essential hyperhidrosis. There's people that have very sweaty hands and are very uncomfortable and sometimes even very severe psychological problems. And if you coagulate or cut the sympathetic nerve at the T3 level, for instance, then your hands are dry. And if you have armpits that are sweating like hell, if you cut it at level 4, then etc., etc. So I saw this. And then one day in Brussels, I had a friend who was a thoracic surgeon, a neurosurgeon, and he said, I have here a patient with hyperhidrosis and I would like to perform a thoracoscopic sympathectomy, but I cannot do thoracoscopy. Do you know anybody who can do it? He said, I know this, I've seen it in Marseille. We developed a new technique. And actually in 1996, as you can see here on the bottom, I published my first paper on this because the first patient that we did, and this is again serendipity, he was a journalist of the largest newspaper in Belgium. And so in the weekend paper of his journal, he published Miracle in Brussels, and he showed his hands before and after. And then I had many requests of patients coming in. And I was a young pulmonologist at that time, so very quickly, it became the subject of my PhD, etc. So everything developed out of these coincidental facts. And actually, I'm now a CEO since 16 years, but all my scientific activity was actually due to or fueled by serendipitous innovation. And even a few months ago, I'm now out of the clinic for 16 years. I had a young patient. He was the son of a minister in Belgium, and he suffered from a congenital recurrent VT, cardiac VTs. And we performed a left-sided cardiac sympathectomy because I have also a series of patients that we have treated like this. So I was very happy to be again at the intervention table and to do what I like to do most when I was a young pulmonologist. So this is serendipity. And I've mentioned this, that not only in medicine, but all over the, let's say, the innovation sphere, probably about 90% of the radical breakthrough inventions have a serendipitous origin. And this is very little known. And I'll come back to that. Now, where comes the word serendipity from? It comes from the myth of the three princes of Serendip. Serendip is the old name of Sri Lanka, the island. And the myth says that there was a dragon swimming around the island, and the king of Serendip sent his three sons, his three princes, to get rid of the dragon. And they made a big journey on the island, and they made a lot of discoveries and found a lot of solutions by accident and wisdom. It's not without importance, by accident and wisdom, for things they were not looking for. And that is exactly the definition of serendipity. You find solutions for problems where you are actually not looking for. You find them by coincidence or just by an idea. So serendipitous innovations, they have one important characteristic. They are usually made by individuals who see these bridges between facts that they see in the world, and then they connect this. And actually, if you look at Steve Jobs from Apple, one of his baselines is, he calls it creativity. It's just connecting things, connecting the dots, seeing bridges between things that at first sight have nothing to do with each other. And it's not chance. It's not like Louis Pasteur said, la chance ne sourit qu'aux esprits bien préparés. You have to be prepared in your brain to see these connections. So chance is just an event that happens, but serendipity is the capacity to use this in the solution of problems, and most often problems that you're not actively looking for a solution for. That is serendipity. And how it works is that in step one, your mind is busy with tackling the knowledge that you have and trying to solve a problem, and your subconscious is looking for these bridges. And then something happens, an external stimulus happens, and then it strikes you. It's like the aha erlebnis, or when Archimedes was in his bathtub, the eureka moment, or when the apple fell on Newton's head, when he saw the link with gravity, and then your brain comes with a solution of a problem. And that is how serendipity works in an individual. And there has been some scientific research on this. So who are these people that make these discoveries or use this capacity? In general, it's motivated people who are not risk averse, and I like to make assumptions, open-minded and curious, so good observers, and always prepared, always ready, always alert. That is a typical personality trait of people who are open for serendipitous solutions for problems. And that is the point where I'm going to. I'm now CEO of a university hospital. We do a lot of academic research, but academic research, there are actually two types. There is the formal academic research where you write grants and you almost foresee what you will discover and you ask grant for this. And then there is the serendipitous or the breakthrough inventions. And what I would like to do in my hospital, and I will go more in detail, is to use this capacity, this propensity of serendipity in finding innovative solutions. And that is my job as a CEO to allow this to happen in my organization. And actually 3M has organized this for the first time when they had this sticky note post-it concept. So they organize these coincidental encounters, like the one between Spencer Silver and Art Fry within the company. They organize it. They make time and place where people from other silos and departments can meet. And that is the evolution in managerial thinking throughout the industries during the last 50 or 70 years or so. And we had the typical corporations like the early industrial age, like Ford and so on. And then, of course, the typical vertical hierarchical leadership, Jack Welch and GE and businesses like that. And then came the new IT companies, and then came the GAFAs, the big new companies. And so what we see here is a trend towards another type of management and another type of leadership. And actually, there's a shift in the organizations that we see from a strict vertical hierarchical organization towards a more network organization, from controlling to empowering, from planning to experimentation. And that is the most important word here. You must allow, as a chief or as a leader in your department, as a cardiologist, for instance, allow for this experimentation and these encounters to happen. And actually, it's changing the glue that holds people together in organizations. The typical glue in a big organization, like a big hospital or a big department, is this typical organigram. But of course, that doesn't work, because organigrams are filled with people and they have relationships between each other, and they can be good or they can be bad, etc. So this is not how an hospital works. And I always like to show this slide, because on the left upper corner, when I did my first 100 days in this function as a CEO, I had to report to the board of directors. This is one of the slides. And I remember my president at the time when I began, he said, what this hospital needs, Mark, is a good organigram. And then I drew him an organigram in 5 minutes. And I said, here is your organigram, but this is not how a hospital works. A hospital works like the right lower corner. It's a social network. And actually these dots and hubs should move and become bigger and smaller, etc. And this is how a hospital works. So you need both. You need the structure and you need a metabolism. You need the skeleton and you need the organs and the metabolism to make the medical image clear. And so what we try to do in our hospital is to combine the vertical silo and hierarchy, because it's by law, we have to be organized like this. But in practice, we very often move towards a flat organization, which is called holacracy. And we make what we call pizzas with pepperonis in it, in function of the problem that has to be solved. And we have to do this because innovation is one of the key engines, especially for university hospitals. And I'm talking to an innovative audience, so I think you would all agree, in order to survive and grow and thrive, you need to be innovative. And then you have to define what you mean by innovation. There is this continuous incremental innovation, which is needed to just stay in the business. These are the management tools that you learn in management schools, and it's necessary. And probably in healthcare, about 30% of your improvement is due to these process improvements, etc. And you have all these management school solutions. I won't go into detail on this, but you need this, by the way, to be very clear. But there is more. There is more. There's also a need for disruptive innovation, which is needed for the long-term survival. And one of the elements in red here is serendipity. And as I told you, the majority of the major breakthroughs are made thanks to serendipity. And I think it's my task as a CEO of an academic hospital to organize creativity and to organize serendipity. And it might be at first sight some kind of paradox and some kind of contradictio in terminis. How can you organize creativity? Well, you can allow it to happen, and that is my responsibility. And to make a nice image out of the automotive industry, you know that Toyota manufacturing system were the first in Japan to really introduce these management techniques. And you know the term Kaizen, which is the continuous incremental improvement, which should be done. And then you find a radical new thing, a breakthrough, and this is called kaikaku. This is the moment of illumination. You find another way to make cars by figure of speech, or you go to electric cars, whatever. And then again is the cycle of Kaizen. And this is the two types of incremental and radical innovation and improvement that you might look for in any organization. And a nice metaphor is that the electric light didn't come from the continuous improvement of candles. Candles were continuously improved, and then Thomas Edison came with the light bulb. And then, of course, the paradigm of lighting changed. And there's a lot of abundant literature on this. And actually, for instance, for organizations, the time spent in continuous improvement in the core business is about 70% of resources. About 20% of resources is spent in just improving a little bit more beyond, but still the core business. And then 10% probably of your time and energy and resources are spent on radical transformation. Radical transformation. And in a conservative world, as the medical world, and come back to that, it's not that easy. So how do you organize it? One of the words that very often comes in the literature and in the examples is interdisciplinarity, multi-interdisciplinarity. And there are nice examples of, and you can do it as an organization to separate people into a different business unit, for instance. But you have to watch out, because a nice example is Xerox You know, Xerox, they made copy machines, and then the headquarters was in New Jersey on the east coast of the States, but their lab, their R&D lab, their innovation lab was in Palo Alto, in Silicon Valley. The distance was a bit too far because in New Jersey, they didn't know what they were making in Palo Alto, and smart people like Bill Gates and especially Steve Jobs, they went to Xerox Park in Palo Alto and they saw, for instance, a graphic user interface and a mouse. So they didn't invent that, Xerox had it, but they didn't know it. And they had no idea on what a gold mine they were sitting. And actually Steve Jobs especially, and Bill Gates a little bit less, they just stole the idea and made the beautiful graphic interfaces that we see now on Microsoft and Apple computers, and the mouse, the use of the mouse that I'm using now to scroll through this presentation. Why is this difficult in hospitals? Well, there is always trouble about the definition of innovation. Are they talking about incremental innovation and improvement or disruptive? It's not very clear. The culture of hospitals is very conservative. As Mintzberg, who is one of the big guys in management, says, hospitals are more often innovation adopters instead of innovation generators. They are inwardly oriented bureaucracies designed for stability. You have to think about that. It's the mirror that people from management and industry holds in front of our industry. And if you read something, James Solwitz, who is a doctor, has written beautiful papers about why it is so difficult to adapt change or to introduce change into the hospitals. For instance, the introduction of the small catheter aspiration for the treatment of spontaneous pneumothorax, which I published in 2002, is still not utilized in every hospital in Belgium. It's 20 years later, and it is proven better, cheaper, better for the patient, etc. We still have surgeons putting in large chest tubes to treat a simple spontaneous pneumothorax. So it's and it takes a generation very often to change that. I once asked the surgeon, why are you still doing that? And he said, well, because I was trained like this. And I said, yeah, okay, but, you know, so why are you still doing it? Well, I had a big surgeon, big name who trained him. And I said, I've done it for 20 years. I will keep on doing it. And so this is something that we have to take into account, and also especially in innovative fields like interventional cardiology. You guys are on the forefront of things, but remember that you have to be followed by others. So I think it all starts at the top also. The C-suite should allow for these transformations to happen. And there are nice examples. For instance, that I see in London, Imperial College, they have a very nice interdisciplinary co-creation space. Mayo Clinic has it. There are various models. We are building it now for the moment. So this splendid isolation environment where you put people together and allow them to experiment is very important. So is it about continuous improvement? Is it about radical transformation? You need both. You need both in an organization. You should spend resources on continuous improvement, but also on radical breakthroughs. And to finalize my talk, I had half an hour. To really good understand the concept of serendipity is this image. If you're looking for a needle in a haystack and you fall out of the haystack with a farmer's daughter, you have another solution for another problem that you were trying to solve. With this image, dear colleagues, I would like to end my talk and open for questions or remarks, of course. Thank you very much.
Thank you very much, Professor Noppen. That was a very insightful, I would say, talk. Just one quick question from me. You mentioned a lot about serendipity and the characteristics of individuals who, perhaps have the ability to capitalize on things that come to them by chance. Do you think these are traits that are inborn, or do you think that we can train ourselves to be more prepared to see these opportunities?
That's a very good Darwinistic question. Is it nature or nurture? Huh? I think it's both. I think some people are more open or apt to the world around them than others. I think that's a personality trait. But what we are trying to establish in the hospital is, and we are seeing it, that if you allow it to happen and organize it, there are many more people than you think in your hospital who have this capacity and now can express it. I'll give you one example. When a few years ago, pre-COVID, we were discussing our new strategy map of the hospital, and we had a program which was called CARE 2030. And I was asking to my colleagues and co-workers to think about our hospital in 2030, which was then 12 years away or so. And while we were doing that exercise, it came to my mind that in 2030, I will be on a pension and all my C-suite colleagues almost will be retired. So we were designing the future of our hospital towards a point at the horizon where we wouldn't no longer be in charge and probably be patients in our hospital. So I then I selected a group of about 50 people between 30 and 35 of my hospital, you know, the high potentials in medical, but also in nursing, in IT, in pharmacists, you know, all over the hospital. And I invited them on a Saturday to come to the hospital and to think with us about the future of the hospital. Well, they were all there. And this is my main group of the future. And there, if you allow this to happen and invite them, and that's the only thing I did. And then, you know, the mayonnaise starts developing. Yeah? They found each other, they talk to each other, they come with ideas. And every now and then I invite them to come with an idea to the C-suite and see, okay, we will do that. And so the best way to predict the future is to create it, said Peter Drucker. And so I think, to come back to the final answer to your question, it is both. It is a capacity of people, and some have it more than others, but I think that you can help to develop it in your organization.
Thank you. There's a question from the floor.
Excellent talk and very thought-provoking. As a CEO, how have you got any tips or clues? How do you distinguish between things which may be leading to fruitful productivity and other things which may not be so useful? And how do you try to sieve the wheat from the chaff, as it were? I mean, I think we all broadly know the story of angioplasty and some of the struggles that undertook in the early phases of the development of that. But it really took someone to see the potential for it to develop.
Yeah, excellent question. What we do is, in this group of about 50 people, they have subdivided in groups with their own interests, of course, because they're not working on one project. So they are within their fields of expertise. They are working together. And what I have asked them to do is to kill their babies, to kill their darlings, because they come up with a zillion ideas. And I first asked them to make the first selection. And there is nothing more, how would I say, rigorous than peer control and peer discussion. So if you create an atmosphere where you can say, I think this is rubbish because of this and this and this, or I think this is excellent because of that, if you allow that to happen, then you have this first natural selection, I would say, of ideas. And then between the groups, I invite the groups one time every quarter to come with one idea to the executive suite. So it must be that they have already thought about it, they have already separated the wheat from the chaff, if you want, and then they come with a project which might succeed and might not succeed, but that is the experimentation that we allow to happen. So we have isolated a budget, a small budget, to allow for this experimentation. So it's, again, it's a long road, because of course you never know in advance which idea will be. That's the same with the venture capitalists from the private equity funds who see a zillion of pitches of new ideas, and you have to select which one might be successful, etc. Here we have a process of what I would call internal natural selection.
Thank you for this nice presentation. We are here in Switzerland. The first man who tried to do first angioplasty, Andreas Grunzig. He came from Dresden. He tried to do this innovation in Germany. His professor told him he should work in a circus. It's not allowed to work in hospital. That's why he migrated to Switzerland and did angioplasty by himself.
Mm-hmm.
Thank you.
Thank
you. A good example.
Thank you for this talk. Here's Daniel speaking. I really love this talk, and I heard once a talk from the group of Maisano, of the innovation group, and they were talking about innovation ideas. So I think we should have teams where you can come in with ideas, and the first answer is not, no, this is a bad idea. And then they think about 3 days, so this is a small circle, think about the idea, then they do a research on internet. Is there already a solution on that? And when you think after 1 week, 2 weeks or 3 weeks, you didn't find anything and you still adhere to the idea, then you can go for it. Just one question back to you. How many ideas do you need to have one idea that will go through?
Yeah. If by chance your first idea is the best one, you only need one. But the experience, what I've seen now happening is that thanks to this interdisciplinary discussion, you see a lot of ideas bubbling up, but they very quickly go away also, because they are often too blind-sided, too myopic, and then now once in a while you have these ideas that come up, and yeah. So how many do you need to kill? How many darlings do you need to kill to find the beautiful baby? I have no idea. I would guess it is a number of ideas. It's very exceptional that your first idea, buff, it hits the rose, you know. So it's a process. It's more of a process than of let's say a predictable outcome game or so. And it's not every 3 months that I get proposals on my desk. So they are very critical about what they're suggesting. So, but I think it's more of the process that is important than the actual numbers, I would say.
This is Malcolm Bell from Mayo Clinic. I really enjoyed your talk, and I think there's some provocative points there. You made the point about the resistance to change, among doctors in a hospital. And I just want to go back to the Alexander Fleming discovery of penicillin, and it's just really a comment, but after he so-called discovered this, it took about another 12, 13 years or so before it actually was produced, because no one would believe him. And my recollection is, because I've actually heard one of my colleagues give a similar talk, and we talked about this at some length, but he presented it to a few societies in England, and no one really believed it, didn't really accept it. And so it wasn't until Howard Florey then worked out how to purify it and then produce it, and then it was just in time for the Second World War. But it just makes you think of how many millions of lives were lost because no one believed it and didn't think that it had a future in medicine. So, but again, thank you for the talk, but it's, as I said, it really raises more questions for us to think about.
But that's good that we have questions and then we look for solutions. Yes, Eric? Mark, just for your information, you are also streamed. So you're not only an audience, but this whole meeting is streamed and we have people watching. I have a personal question for you, a question I would like to ask. But first, I throw up the question from the streaming audience. So I just read what the colleague wrote here. Medicine is a conservative profession. How do you balance between financial charges and innovation investment? Also, intervention will involve risk and how to balance between the risk of this and the potential success.
Yeah, these are the holy grail questions, of course. Since in Belgium, at least, healthcare is a non-for-profit or social profit thing. So we don't have, almost have no private activities. So it's all with public money. So the margins, the financial or the business margins of the hospitals are very, very low. And especially now in these times, post-COVID, energy prices, wages going up. To give you an idea, our hospital has a budget of 550 million euros per year. And our business margin is at best 2% of 10 million after investment. So that is almost break even. So we don't have a lot of money to spend, but that is not the most important, I think. We do invest about 50 million euros per year in the hospital, in new equipment, etc. But that is what I would say daily operations or business as usual. Really invention, we only have maybe, if I would add them up, we probably have a million euros or so that we spend every year on innovative things. And that is a lot of money, but it's also not a lot of money. So, but it's more, in my opinion, it's more the fact that we allow this to happen and we endorse and we stimulate this to happen. Every 3 times per year, we see every medical department, and we have this balanced scorecard and these KPIs that we follow. And one of them is their activity in new things, innovation, and that can be the typical formal innovative scientific processes to attract funds by the scientific communities, etc. But that is very predictable. That's only exceptionally disruptive. But the funds that we spend is on trying to find or to develop more radical innovations, and in a number of fields we are succeeding in that. So yeah, it's a good question. It's a difficult question. I think it might be different from country to country in terms of how the healthcare system is funded. I think that is a major element in how much money you can spend on these issues.
I have one last question, if you allow me. It is said, and it even seems to be proven, that the best CEOs of hospitals are physicians rather than administrators. You will maybe comment on that. So if you decide at your point in your career, if your academic profile suits, you can go for head of department, which is already quite radical change. But I imagine that moving up to the CEO, then you really completely disconnect from medicine and you become somebody else. So can you comment on that? And can you maybe, if you look back after all these years, did you make the right choice? This must be a tough life, no?
Yeah. Well, it's at least a very different life. I've tried to combine clinical medicine and let's say senior management, but I've done it for 2 years, and for me it's impossible. And I know very few people who actually can do both at the best possible level. But actually, you are right. I'm kind of fan of evidence-based medicine, but also evidence-based management. And there's a very nice paper which was published in HBR and Harvard Business Review a few years ago on a comparison of a number of outcomes of hospitals, and it was a very large study. And it was statistically significant that hospitals who were run by an MD CEO were doing better, between brackets, than hospitals who were run by economists or other people. But that's a statistical truth. But yeah, I know there was a big overlap, let's say. So of course I'm a fan of that idea in my situation, but no kidding. In our hospital, it's our internal rules and regulations, our bylaws, that say that the CEO of our university hospital has to be an academic doctor. I think well, I think that is that's a good thing because the biggest stakeholder group in your hospital are your doctors, and when I discuss with them, I have the advantage of having been one of them, talking the language. They don't have, they cannot come with blah blah in my office because I've been there. So that's a big advantage. So yes, I think that hospitals who are run by doctors have this advantage over other hospitals. Now, did I make the right choice, and am I happy with it? Yes, I'm very happy with the choice I've made, which was also a serendipitous choice in the fact that if my predecessor would not have passed away at very young age, I would never have had the opportunity or never have thought of it to do this. So this came by chance, between brackets, but then you look at that and you say, this might also be a solution for other problems, because I was already thinking on solutions for hospitals, etc. So no, I have no regrets. What I do miss is of course, the gratitude of having meant something in the life of an individual person with a name and a face. And I still got phones and emails from patients that I treated 15, 20 years ago at my anniversary, etc. So that is, yes, that is something that I miss. And like the kid I operated on a few months ago, together with another colleague, that sense of gratitude, and that is something I miss. But I would like to end with the concept maybe that you have heard of Ikigai. Ikigai is a Japanese term where there's the crossing of 4 Venn diagrams, and the idea is that every person should try to find his own Ikigai, and the 4 Venn diagrams that are made of what is that? That is the capacity of the knowledge of the things you do, so your mastery of your job, for instance, the fact that this job has a purpose, 3, that you are paid for it, and 4, that you love it. And if you find this, then you have your Ikigai. And actually, it's not a word for happiness. I had it when I was a pulmonologist, and I have it now being a CEO. So yes, I'm looking back, I'm happy with the choice I've made.
Okay, thank you, Marc, for this great lecture and great discussion. I think it was very stimulating. There are still many challenges in organizing and managing hospitals in the future. Thank you. We have another talk from Maurizio Taramasso, a good friend from Zurich, who will talk about how can we connect interventional cardiologists and cardiac surgeons. Maurizio is a cardiac surgeon at the base, but I think he's the model for the future. So this is an open-minded guy that entered into the structural heart interventions, coming from the surgical sides, and I think we can also have great inputs from the cardiac surgeon, because they have another view at the heart than we have. So Maurizio, thank you for being here, and we're looking forward to your talk.
Thanks, Daniel. Really nice to have this kind of introduction. After such an inspiring lecture, I feel quite embarrassed, but I will try to do my best. It will be more basic, more technical, but I think there will be room for discussion at the end. And I will try to give you some, I hope you can see my screen now, some insight on what is my opinion, at least, regarding how the two, let's say, the two words, the two philosophies can interact with the interest of the patient. And actually, at the end, this could be already the last slide. At the end, we are already trying to bring the best of the two worlds together during the heart team. The heart team, I would say that it was at the beginning a need, it was mandatory. Now could be perceived not anymore as a need, because let's say that the cross-fertilization between the two worlds made that every single specialty probably has all the most important competence to offer the treatment, but still I think, even if it is not anymore really a perceived need due to lack of knowledge, I think this is the only way to offer the best of the both worlds to the patient in an unbiased way. Let's start talking about the aortic stenosis first, which is the first field where cardiac surgery and structural interventional cardiology met. Nowadays, we are in a phase where we are trying to move the indication toward low-risk patient, independently from the age. The risk profile of the patient that we are moving towards, it's low. And despite some issues that we can discuss at the end, but in general, this is the tendency. So patients with severe aortic stenosis at low risk at the moment can be treated with both surgery or TAVR according to, let's say, anatomical profile, according to some characteristics, but both of the treatment have been proved to be safe and effective. In the short term, probably TAVI seems to be better than surgery, even better. In the long run, we don't know. But for sure, there is a movement of the indication towards this direction. And I think if we move toward this direction, we should somehow bring the same philosophy of valve disease that many surgeons has, which is the concept of neutralization of the disease. Obviously, neutralization of the disease is somehow provocative for aortic stenosis. We cannot neutralize aortic stenosis. We will talk later on about mitral. We can neutralize the disease with surgery in some mitral patients. But neutralization of the disease is the aim of the surgeon. That means treat the problem without mortality and without morbidity, ideally, obviously, without leaving any consequence. So any permanent footprint on the heart or on the patient, like hypertrophy or like fibrosis or in aortic stenosis. So this assume an early indication, so we should intervene before that consequence already happened. We should not have any pacemaker left, obviously, no paravalvular leak, anything that can remember the patient that he had an intervention. And then on the long term, we should have no structural valve deterioration, no infection, no thrombosis, so ideally no need for medication. If the patient is left lifelong with oral anticoagulation, obviously we do not neutralize the disease. We should have no gradient, and we should not preclude access to the coronary in the future. So minimize the impact of the treatment on the patient. There are several aspects that are depending on the operator, but also the technology that we use to at least, obviously, is not, for aortic stenosis, we implant a prosthesis, so by definition, we cannot achieve this target, but we can at least try to get as close as possible. There are some new techniques that are now pretty much popular to reduce the risk of pacemaker implantation. So now we tend to implant with this cusp overlap technique, which actually is just a different projection of implantation that allow us to implant in a, let's say, more relaxed way, slightly higher, because obviously the depth of the implantation is the most important procedural related features with pacemaker implantation. This relates not only to the risk of AV block. To implant higher allows also better hemodynamic and therefore most likely also better durability. So this has an impact also on the long-term run for the patient. There are many studies now coming out to reduce the pharmacological burden after valve disease, valve replacement, not only in TAVI, but also in surgery. A few years ago, we were giving anticoagulation to all the patients. In TAVI, we started giving double antiplatelet therapy. Now, standard of care is to give only aspirin. And most likely, we can try to gain more data in reducing the pharmacological impact after the treatment of the patient. We are now trying, for the same reason why we try to implant higher, also to align the prosthesis to the native anatomy in order not to preclude the coronary access in the future, if the patient is young especially, but also to ensure better hemodynamic. If we respect the commissural alignment, there is better flushing of the sinuses, and this should translate in better durability. We can do commissural alignment with different devices. There are different techniques to do it. And nowadays, if we treat a patient with TAVI, I think it's mandatory at least to try to offer him patient-specific commissural alignment. We have now devices to reduce the risk of morbidity, like cerebral protection device. In our practice, is standard of care, despite the absence of solid evidence to use cerebral protection device. And again, this is a concept coming from surgery. The first cerebral protection device were developed in cardiac surgery. Then there was not a huge market for them, but the Embolex device was a device actually to deflect the debris during open heart surgery far from the supraortic vessel. So again, the cross-fertilization and the inspiration between the two specialties bring toward this kind of philosophy of neutralization of the disease. These are just some debris that we have been capturing in our everyday practice. So these are not high-risk patients. These are patients with normal anatomy that have been prevented most likely to having a stroke, or at least this is what we have been captured in the filter. To reduce morbidity and mortality now, we are also using something that is improving the safety of some specific high-risk population, like patients having involved with high risk of coronary occlusion. So again, the field is moving forward. We have now this technique of basilica that is becoming more standardized, and we will have soon dedicated device to do it, to split the leaflet in front of the coronary to avoid risk of coronary occlusion. This is just an example of a case that we did. We can, with an electrified wire, puncture the leaflet and then split the leaflet and open the surgical leaflet in front of the coronary ostium in order to reduce the risk of coronary occlusion. And again, this kind of sub-speciality of structural cardiology, it's called electrosurgery. So the one who invented, who is an interventional cardiologist, called it electrosurgery. And this reminds me that at the end, when we do like this, we are almost like surgeon using catheter. You can be a cardiologist using a scalpel, you can be a surgeon using a catheter, but at the end, the philosophy is the same. And then last but not least, new material will ensure most likely better durability in absence of any need for pharmacological therapy. Let's move now to mitral. I like to talk a bit about mitral because in mitral, actually, we can neutralize the disease in selected cases. So surgery in patients with degenerative mitral regurgitation who are eligible for repair, in experienced end, can neutralize the disease. And neutralize the disease in mitral regurgitation imply this kind of aspect. So obviously no morbidity, no mortality. The patient should leave the hospital with no MR and obviously no TR. There should be no gradient. There should be no scar. That's why it's important, the minimal invasive approach, because if you do a perfect repair, but there is a big scar, then the patient will remember as a consequence of the intervention, the scar of the access. So it's really important also to address this if we want to aim to the neutralization of the disease. There should be no atrial fibrillation, no irreversible pulmonary hypertension. The patient should be left without any medication. The repair should be durable, and there should be no consequence on the heart. So normal left ventricle, but also normal left atrium, no fibrosis. Obviously, this implies an early indication and an experienced operator. So we should combine an early indication to offer the patient a treatment before, sorry, the helicopter is coming, before any irreversible consequence like pulmonary hypertension or secondary TR is coming. And we should be able to offer a perfect repair with no gradient and no residual MR. So not only the indication is important, but also the operator and the team experience is important, as well as the anatomy. So the degenerative MR suitable for repair. Can we reproduce this? Can we export this philosophy also in a structural intervention? Well, the attempt is to do exactly this. In surgery, we have different tools with different techniques to address the anatomy. We have different tools now coming out also in structural intervention to address all the components of the disease. We have leaflet device, not only edge-to-edge, but also chordal device, who are coming also in a fully percutaneous way. We have an annuloplasty device. So the tendency most likely is to go towards this direction, to neutralize the disease in a complete way with no scar and with no consequence on the heart, with a perfect durable result also with transcatheter technique. But obviously the way is still really far. This is just an example of combined leaflet and annuloplasty. So we can combine treatment also in structural intervention somehow to mimicking the philosophy of surgery of addressing all the components of the valve to somehow aim to the neutralization of the disease. And now is as we are now, we have different tools. We are learning how to use them singularly, obviously, but we will learn more and more how to apply them in combination in order to address all the components of the valve. And then last but not least, in surgery, we can also replace the valve. Replacement is now reality also with a transcatheter approach, but let's remember that if we have more than 150,000 repair with the catheter-based method, we have only about 5,000 or maybe a bit more of replacement. So we are still far to have the same experience. There are a lot of concern, sealing, fixation, patient selection, durability as well. So it's not as easy as it could seem. The main drawback for patient selection, but also for postoperative morbidity, is the risk of LVOT obstruction. We know this also from surgery. There are some anatomical related and some device related factor to predict risk of LVOT obstruction. We can really plan well the procedure so the patients at high risk are excluded, and this is a limit because many patients are still excluded from TMVI, but we can really predict the neo-LVOT after the implantation. In selected cases, we can even cut with an electrosurgical approach the anterior leaflet with an electrified wire with this technique, which is called lampoon. It is technically demanding, but is feasible and safe in experienced hand. So again, we can really tailor the treatment to the anatomy of the patient. And so far, the only device which is available in commercial setting is the Tendyne, which is apically delivered. So it's a hybrid device delivered through a surgical approach, but with a catheter method. And it is really promising, even if still many patients do not qualify because the dimension of the annulus or the dimension of the ventricle do not fit with the dimension of the valve. And then let's not forget, and this is also coming from the surgical arena, that a good replacement is better than bad repair, obviously. So we should not accept bad repair as we don't accept in surgery. In that case, it's better to go for a replacement. But a good repair is better than a replacement for several reasons, especially if we refer again to this concept of neutralization of the disease. If we leave a prosthesis in position, the disease is not neutralized, and then the physiology is not respected. Obviously, also the fluid dynamic is different if we respect the anatomy and the physiology with a repair rather than if we put a prosthesis. So this will be the main challenge for the next few years, how to select the patient for the best treatment, because more and more devices are coming, and actually we really should be able, together surgeon and cardiologist and imager, to tailor the procedure to the patient. So which patient could be a good candidate for repair, and I would favor always repair first. But if the patient is not a good candidate for repair, then replacement should be considered if anatomically feasible. Few words regarding the tricuspid. The tricuspid, the last valve who came to the interventional arena. Let's say there are now different devices already available to address different aspects of the valve, leaflet device, annuloplasty device. Some of them already disappear, some of them will move forward, some of them will come and probably will replace the one that we use now. There are also replacement approach. We are still at the beginning of the journey, but we have many patients that could profit. And we know from the surgical experience that surgery is not a great option for most of those patients. That's why, based on the surgical knowledge, we have been developing annuloplasty device, edge-to-edge device in order to address tricuspid regurgitation in a less invasive way. We are still learning which is the anatomical algorithm for patients with tricuspid regurgitation. As for the mitral, with the mitral we are a bit more forward. Obviously with tricuspid we are really at the beginning. At the end, most of the time we use the device that we have in-house, but still we will learn in the next future which device will fit with which anatomy. And this will also have obviously a relation with the stage of the disease. Again, if we want to neutralize the disease, we have to intervene a bit earlier, even if neutralize the disease in tricuspid is impossible, I would say, most likely, because most of the time it's secondary, so it's already a consequence itself. But the concept is that the earlier we intervene, the less are the consequences which are irreversible on the heart. And we know this from surgical arena. And this is a bit the conclusion. I think the future of valve intervention will combine the best of both worlds, not only from a knowledge standpoint, so not only in the heart team discussion to provide an individualized treatment to each patient, but also the technological improvement of surgery will improve the device in interventional cardiologists, and the opposite. We will have, for example, more suture-led device also in surgery, as we have in interventional cardiologists, and we will have, for example, better leaflet tissue for what I've been learning from surgery to improve durability also in interventional cardiologists. Here are just some examples. The CORNOT is a device to fix suture in surgery. There are some devices that are using CORNOT also in interventional cardiologists. We use interventional prosthesis in some cases, like Sapien in MAC with open access in some selected. So the hybrid utilization of the technology is already a reality and will become more and more, as well as adjustable prosthesis in interventional cardiologies. We have adjustable annuloplasty. This is a reality also in surgery sometimes. So the technology of one aspect will improve also the device and the effectiveness also of the other devices. And this is the last slide, a bit the prediction of the future. I think, and I hope we will be able to diagnose heart valve disease earlier before irreversible consequence appears. So we will be able to treat early in order to have a better impact on the prognosis. We will be able to perform surgical-like intervention through catheter, and surgical procedure will be better because we'll be inspired from a better technology coming from transcatheter therapy. And hopefully, this is the most important, we will have enough scientific evidences to support early indication, timing, and to tailor the treatment to each patient. Thank you for the attention.
Well, Maurizio, thank you very much for this outlook also to the future, not also what is the present. So when I listen to you, we are moving toward a more percutaneous solution for valves. Perhaps for the mitral valve it's different when you say if you can repair it, yes, repair it. What we encounter in many countries, I think also here in Switzerland, is that when you compare in the low-risk patient group surgery to TAVI, the price of the prosthesis is much higher than surgery. So that's why the government in Switzerland decided to not reimburse it. I think in other countries perhaps you have the same problem, even so that the guidelines indicate TAVI in low-risk patients. So I think this is also a hint to the industry. I think health systems are expensive, and having treatments that are at a much higher price, but perhaps at the benefit for the patient, this is very provocative what I'm saying now, is limiting us in treating these patients with the best option. What is your experience about that?
Absolutely. It is absolutely like this. Politics and health politics obviously is important, but should not have such a big impact on the best treatment for the patient. Probably the solution will be that in the next future, the prices of the transcatheter prosthesis will go down, and this obviously will solve the problem. But obviously, the effort to develop this prosthesis in the years at a big cost, and now I think many companies are still in the retirement or investment phase. That's why the prices are still high. On the other hand, we cannot, I think, influence our decision as a physician too much related to health politics. Also because on the long run, if you put all together all the costs, not only the cost of the index hospitalization, but also the cost of the rehospitalization, the cost of the rehabilitation, at the end, there are many studies showing that TAVI is a cost-effective option also in terms of economic return. Obviously, we try as a physician to give the most appropriate treatment, and we sign every time we do an heart team discussion that the indication is given by a multidisciplinary team. But still, this is sometimes not enough, and sometimes we get a letter from the insurance company to saying that they don't want to reimburse the treatment, even if maybe the initial Kostengusprache was approved. So it's an issue, is differentiating Switzerland to the rest of Europe, because this is specifically an issue in Switzerland at the moment. That's why I think it's going to change, but we have to deal with this issue for the next month, absolutely.
Yes, Eric. Mauricio, I have a question concerning the special job of being a cardiac surgeon. You're a little bit hybrid, as we all know. How much of an issue is it today to train cardiac surgeons? Diving numbers are high. You know, the cases you get are complex in the terms of the coronary, and you see that the whole chain is suffering. That means that often senior cardiac surgeons still are quite involved in the whole process of the surgery, and that the transmission of knowledge seems to be a real issue. So how do you see that? What can be done? Or is it an issue? Maybe I'm wrong.
No, is it an issue? And it will be probably more and more an issue, because once this patient with TAVI will come back, maybe with endocarditis or with leak. So we will face more and more with more complicated surgery, also in coronary surgery. Let's say that now the patients that got bypass surgery are the ones that are not suitable for stenting most of the time. So with the most complicated anatomy, sometimes they come with already a lot of stent inside. So the complexity of surgery will become more and more, will increase more and more. And as a consequence, the training of the new generation will be more challenging. We have to say that probably also there are less people attracted by surgery over the last few years. Also in the common trunk, there are less and less people interested in which is a demanding career and long-lasting training, with the difficulties that the exposure, at least at the beginning of the training, could be low, as you said, because there are no really a lot of teaching cases. So it takes time, and most likely we should think somehow how to change the training process. I see cardiac surgery closer to a cardiological specialty rather than a surgical specialty. So somehow the common trunk should be more cardiological than general surgery, in my opinion. And most likely we will need also to somehow not only change the training, but also to try to, I mean, we need to somehow find a way to maybe to motivate the young people to go in that direction, not only letting them doing in primary person when they are after, I don't know, 6 or 5 years or training. It should become a bit earlier. US is moving in this direction since many years, and in US they don't have this issue. But the complexity is increasing, and it will require for sure a change in the education. Also, subspecialty is a solution. I think we will go more and more in the direction of surgery, surgeon dedicated to coronary, surgeon dedicated to complex aortic, surgeon dedicated to, which I don't like, because I don't like super specialization, but with the increase of complexity will become more and more probably like this.
I have a question. I think the heart surgeon should change their title from heart surgeon to interventional surgeon. Is that correct or not?
Obviously, is a bit provocative, but probably this is the way to go, yes. And most likely this interventional surgeon will be, in few years, somehow a specific specialist in between the two, and will be a dedicated person. I don't think there will be space in the future for a surgeon doing transplant, LVAD, TAVI, mitral clip, as there will be no space for an interventional cardiologist doing really complex coronary, CTO, complex imaging and complex TAVI, mitral. I think, unfortunately, but this is what the specialty requires. We will go more and more in the direction of subspecialty with focused people doing maybe less procedure, but doing only that procedure.
Well, perhaps another provocative idea could be that we do not have cardiac surgeons and cardiologists. We have cardiovascular doctors, so they have the same branch at the beginning, and then they go to what you said, to subspecialties. And so we are a team. We do not fight, this patient has to be amended to surgery, and this patient is for a percutaneous thing. I think this is very provocative today, but I think that's something where we have to go. I can learn from peripheral guys, I can learn from neurology guys, so I think there should be a more concentric evolution that we treat cardiovascular patients in a unit, and then we have specialists in it. And this will also change the geography of hospitals and of clinics.
Absolutely. Totally agree, yeah.
We'll take one last comment from the...
Excellent talk. As an established physician or surgeon in both surgery and interventional cardiology, do you see challenges in maintaining your skill sets in two, broadly speaking, evolving and, as per your talk, and ever-increasing complexity areas? How, for example, would you feel about dealing with a complex redo surgery at the same time keeping those complex skill sets as doing the latest, greatest mitral intervention?
Absolutely. I think this is exactly what I was meaning, talking about the subspecialty. I don't think, I'm honest, I don't think this is really feasible and in the interest of the patient, at least on a large scale. Then obviously there are some exceptional physicians that can do everything. I'm not one of them. I focus more on valve intervention, surgery and intervention, mostly intervention. And as you said, I'm not confident in doing a complex redo aortic arch replacement. This is not my focus anymore, and I would never go to a patient selling myself as an expert of aortic surgery because I'm not. My focus is this one and I totally agree that you cannot keep high skill, high level in all the field. You have to take decision, or you will be on average in everything and without being exceptional, let's say. Personal opinion.
Okay, thank you very much, Maurizio. We've got to bring this session to a close. Thank you for your insights into work and life as a cardiac surgeon. And of course, thank you to our first speaker as well for the talk on serendipity and managing a hospital. So it's now time for another break. And then we will come back at what time?
Yeah, there is a break satellite organized by Beltronic here in this room that will start in about 10 minutes, something like that.
Okay.
Hello, everybody. Welcome back again after coffee. So now we're going to move for the Biotronic Symposium, and we will discuss about complex PCI. And before to discuss a real complex PCI, we discuss with Thomas Pilgrim. I don't know whether he's online. We have maybe to check the connection. Hello, Thomas, do you hear us?
Yes, hello, Olivier. Hello, Eric. I'm online, yes. I'm sorry
Excellent.
for not being on site, yes.
The connection is perfect, and I think there is Goran Oliver Kroner.
Hello, Olivier and Eric. Thank you for the invitation. It was fantastic to be here. I've always wanted to go to the ECC meeting. Hopefully I will be there in person next time.
Excellent. So the connection is perfect. We're going to start with you, Thomas, and I think you're going to discuss about not the ultra thin, but the ultra thin strut. There's a mistake in the title. Ultra thin strut is the best choice for STEMI patients, and we're looking forward to see whether you have any data regarding this topic.
Yes, perfect. So thanks a lot, Olivier, for the invitation to the meeting. Can you see my slides all right?
That's perfect.
Okay, very good. So my conflicts of interest are displayed on this slide. So I have received research support and speaker fees from Biotronic. So the examination trial was actually the first and the only randomized control trial showing superiority of drug-eluting stents over bare metal stents in patients presenting with ST segment elevation and myocardial infarction. Before, so 10-15 years ago, there was a huge discussion going on whether you should implant first-generation drug-eluting stents in patients with acute myocardial infarction because of an increased risk of very late stent thrombosis. So with newer generation drug-eluting stents, there was a benefit for DES as compared to BMS, even in patients with ST elevation myocardial infarction. And as we can see, the difference was not limited to device-oriented clinical endpoints, but also to patient-oriented clinical endpoints, such as low rates of mortality and borderline lower rates of revascularization at 5 years after ST segment elevation myocardial infarction. So there have been plenty of non-inferiority trials comparing different newer generation drug-eluting stents. So we did the Bioscience trial, which was also one of the non-inferiority trials comparing the Orsiro stent, the ultra-thin strut biodegradable polymer drug-eluting stent, compared to the Xience stent, so to the stent that has been used in the examination trial. And as said, this was a non-inferiority trial in 2,100 patients. The trial was performed in Switzerland, and the primary endpoint was published in 2014. So what we have found in this trial, that non-inferiority was established for Orsiro as compared to Xience at 1 year with regards to a composite clinical endpoint, target lesion failure, a composite of cardiac death, clinically indicated target lesion revascularization, and target vessel myocardial infarction. A little bit to our surprise, in a stratified analysis of this primary endpoint at 1 year, we found a signal towards a potential benefit of the Orsiro stent as compared to the Xience stent in patients presenting with ST segment elevation myocardial infarction. This was not something that we had expected, but we thought maybe it would be interesting to dig deeper and see whether there could really be a difference, because obviously the Bioscience trial was not powered to show differences in this subpopulation of patients with ST segment elevation myocardial infarction. Nevertheless, the trial was randomization was stratified according to presence or absence of STEMI. So we thought that improvements in stent design may maybe mitigate arterial injury, facilitate endothelialization, and reduce neointimal hyperplasia. And in acute myocardial infarction, acute MI confers actually an increased risk of stent-related adverse event, exactly due to this exacerbated inflammatory response and delayed arterial healing. So we decided to go ahead with the BioSTEMI trial, which was a dedicated randomized clinical trial comparing the Orsira ultra-thin strut biodegradable polymer sirolimus-eluting stent versus the Xian stent, a durable polymer drug-eluting stent. The BioSTEMI trial was actually a superiority trial, so not a non-inferiority trial, but the hypothesis was that we can reduce target lesion failure in patients with ST segmental elevation myocardial infarction by using Orsiro instead of Xians. So I'm sure you're aware of the principal features of the Orsiro stent and the Xian stent. So if you look at the stent platform, the Orsiro stent has an ultra-thin strut stent platform with a strut thickness of only 60 microns for small stent diameters. In all stent diameters larger than 3 millimeters, the strut thickness is 80 microns, very comparable to patients to the Xian stent. As a polymer, the Orsiro stent has a biodegradable polymer that degrades more than 1 year after implantation. The Xian stent has a durable polymer, and as a drug, both of these stents use limus analogues. So let's take a look at the study design of the BioSTEMI trial. So the trial was performed at 10 sites in Switzerland. Patients were randomized in a 1-to-1 ratio to either Orsiro or Xians. We used a Bayesian analysis for this trial, meaning that patients presenting with STEMI that already had been included in the bioscience trial were included in this analysis as a historical prior. And this historical information was actually updated with the BioSTEMI trial. The primary endpoint was target lesion failure as assessed at 1 year, and we're going to see today the 2-year final clinical outcomes. So 1,300 patients were randomly allocated to Orsiro or Xians. All of these patients had ST segmental elevation myocardial infarction and were presenting for primary PCI within 24 hours of symptom onset. In addition, the 407 patients from bioscience were included as a historical prior. At 2 years, follow-up was complete in approximately 95% of patients with no differences between the 2 treatment arms. This slide shows the baseline characteristics of patients included into the BioSTEMI trial. So age was 62 to 63 years. The majority of patients were male. You can see the risk profile of the patients included. This slide shows the primary endpoint results as assessed at 1 year. So we can see the posterior distribution of the risk ratio of the primary endpoint target lesion failure here. So target lesion failure occurred in 4% of patients treated with Orsiro as compared to 6% of patients treated with Xians. And we can see the superiority margin here, and a posterior probability of more than 0.975 was considered statistically significant. And what you can see that we have a posterior probability of superiority of 0.986. So the Orsiro stent proved superior to the Xian stent with regards to target lesion failure at 1 year in patients presenting with STEMI. But let's take a look at the 2-year results of this trial. Of course, there are differences with regards to adherence to dual antiplatelet treatment between 1 year and 2 years. You can see that adherence to DAPT was very high within the first year after stent implantation and dropped to below 10% at 2 years after stent implantation. This slide summarizes target lesion failure at 2 years. And what you can see here is the Xian stent in red and the Orsiro stent in blue. So target lesion failure occurred in 8.1% of patients treated with Xians as compared to 5.1% of patients treated with Orsiro, with a rate ratio of 0.58 and a statistically significant difference that was maintained at 2 years. But this analysis included the historical prior from bioscience. But let's just assume that we look at the BioSTEMI trial as a standalone trial. So just the 1,300 patients that have been recruited in the setting of the BioSTEMI trial. And even if we exclude the historical prior, we see that this difference between the Orsairo and the Xayen stent is maintained and pretty much the same, with a significant difference in the occurrence of target lesion failure between Xayens and Orsairo at 2 years. Let's take a look at the individual components of the primary endpoint. So cardiac death showed no difference between the two treatment arms, nor at 1 year, nor at 2 years. Target vessel myocardial infarction did not show a difference between the two treatment arms. You may have suspected that there could have been a difference because if you look at the BioFlow 5 trial, for example, also a trial comparing Orsairo versus Xayens, the difference between the two treatment arms was actually driven by lower rates of target vessel myocardial infarction in patients treated with Orsairo as compared to Xayens, but this is not something that we have seen in BioSTEMI. The reason for this could be that all of these patients already presented with myocardial infarction, and in this patient subset, it is particularly challenging to see differences in periprocedural myocardial infarction, as you can understand. Let's take a look at clinically indicated target lesion revascularization at 2 years. We see that there were higher rates of TLR in patients treated with Xayent as compared to Orsairo at 2 years. And again, this difference was not only observed in the entire cohort, including historical data from bioscience, but also in BioSTEMI as a standalone trial only, with a significant reduction of TLR in favor of the Orsairo as compared to the Xayen stent. And this was actually the driver for lower rates of target lesion failure in this trial. If we look into timing of the occurrence of target lesion failure or clinically indicated target lesion revascularization, we can see that this effect was actually consistent between the first and the second year. So it was not limited to the first year, but it was consistent and maintained throughout 2 years of follow-up. However, we have seen that the examination trial showed a reduction in patient-oriented clinical outcomes in favor of drug-eluting stents as compared to bare metal stents. And obviously, we were interested to see whether on top of the difference in a device-oriented clinical endpoint, there would also be a difference in patient-oriented clinical endpoints. But there was no significant difference between the two treatment arms. So similar rates of death, similar rates of overall myocardial infarction, and maybe a trend towards low rates of repeat revascularization, however, without reaching conventional levels of statistical significance. If we look into rates of stent thrombosis, you may be aware that in long-term follow-up of the BioFlow 5 trial, patients treated with Orsairo tended to have lower rates of late and very late stent thrombosis as compared to patients treated with Xayens. This is not something that we have observed in the BioSTEMI trial. However, as you are aware of, follow-up was limited to 2 years after stent implantation, but throughout 2 years we observed comparable rates of definite and definite or probable stent thrombosis between the two treatment arms. So in conclusion, the final 2-year outcomes of the BioSTEMI trial demonstrate superiority of biodegradable polymer sirolimus-eluting stents versus durable polymer everolimus-eluting stents with respect to target lesion failure in patients with STEMI. And this observed difference remains robust even after exclusion of the historical information from the bioscience trial. And this difference was driven by lower rates of clinically indicated target lesion revascularization in patients treated with ultra-thin strut stents. There were, however, no differences in patient-oriented clinical outcomes between the two treatment arms. So thanks a lot. This brings me to an end. I'm open for questions.
Thank you very much, Thomas, for this brilliant presentation regarding the Orsairo versus the Xayens. Any question? I will start with one question. how can we explain these results? And this is all about so the strut. As you know, more than 3 millimeter stents are the same in terms of size. So do you have any data for this subgroup of patients with more than 3 millimeter stent, and whether we can compare same struts but with different polymer, and whether we can say something on the causality of this result, if it's the polymer or not?
Yes, that's actually a very good question, Olivier. And I think the short answer is that we don't exactly know the difference that could explain the differences in clinical outcomes. In a subgroup analysis of patients that were really treated with ultra-thin strut stents, so smaller stents with a strut thickness of 60 micrometers, if we compare Orsiro versus Science in this patient subset, we don't see a difference between the two treatment arms. And actually, the difference between the two treatment arms was substantiated only in patients treated with larger stents. So actually, in a group of patients in which the strut thickness of the individual stents are very much comparable. So at this point in time, we don't know whether it's really the ultra-thin struts that made the difference, and we think it's maybe rather a combination of different factors. We usually try to simplify things and try to reduce and categorize drug-eluting stents into certain categories. So we have biodegradable polymer drug-eluting stents, we have ultra-thin strut stents, but you know, I think differences are much more subtle. So even if we look at the family of biodegradable polymer drug-eluting stents, there are so many differences with regards to the distribution of the polymer, thickness of the polymer, release kinetics of the polymer of the anti-proliferative drug. So there are so many subtle differences, and it's maybe a simplification to just reduce the stents to categories. But the short answer, as I said, is we don't know exactly what makes the difference. It may be a combination of different factors.
It's very honest of you, Thomas, to give this answer, because it's clear that everybody was extremely surprised too when this data came out, and I still remember when the principle was set up for BioSTEMI, which was like a Swiss project with the support of Biotronic Switzerland mainly. We were all quite surprised, and only congratulate you afterwards on the result. Daniel, you want to make a short comment?
Well, yes. Hi, Thomas. Great presentation.
Hello, Daniel. Hello.
My question is, I have learned from the syntax trial that when you have a look in the depths of the study and you look to the centers, there were differences in outcome of centers, so that we can assume there is also other influences like operators that have different techniques of implantation of stents. Did you do analysis of the centers, and did you find differences between the centers? It's very provocative, I know that, but I know it from the syntax trial, and we base on the syntax trial. The guidelines are based on the syntax trial, so I think we have confounders that go not just though on thickness of struts and polymers.
Yes, I mean that's a good question. There are two issues to it. So first, randomization in this trial was stratified towards the different treatment centers. So it was not possible that one center would treat all their patients with Orsiro and another center would treat all the patients with Science, but this was equally distributed. So whenever there would have been differences in individual operators between centers, the number of patients treated with Orsiro and Science per center were actually balanced. So you shouldn't see a difference because of differences in operator skills. And the second issue is we didn't perform a subgroup analysis because the majority of patients have been recruited in Bern, and then there was Lausanne was a very high volume center, and most of the other centers didn't recruit too many patients, and we wouldn't have had the power to show differences in outcomes between individual centers.
Okay, thank you very much, Thomas. And we will move on with the program. Daniel, I don't know whether it's time for you, but we'll go for the next presentation, the right tools for complex intervention. And Daniel is the most experienced cardiologist here in Switzerland. Your time is dedicated for complex PCI, especially CTO, where you are one of the leaders in the world and especially in Switzerland. So thank you very much for coming here to talk about complex PCI.
Thank you, Oliver, for the kind introduction. So this is my enthusiasm I developed many, many years ago. And there was a comeback. When you go into the field of CTO operations, you also learn for complex PCI. That was my learning. So it will be a more practical lecture. Can I have the next slide? Do I have something? Agreement. Voilà. So these are my conflict of interest. So when you go through the steps of PCI, I think we have no time to go through all these steps, but I think we have many, many steps we should follow and we have learned. And it's not only about the experience of the operators, it's also the material you use. And I think the anatomy will dictate your strategy, and then you have to go through that flow sheet and think about what would you need from access, mostly radial today. I think we have enough data that supports that. Also for complex PCI. I just want to go through wires, guiding extensions, microcatheters, trapping devices. I think these are tools that we need not only in CTO PCI, but in complex PCI today. So I think the essential is the wire. The wire you will choose for the anatomy you are in front of is essential finally. And you should know the wires, how they feel in your hand. But above that, I think it's a definition of what is the task you have and what are the wire properties, and then you will understand in which situation you will take which wire. And this will enhance your success rate. So when I come from CTO lesions, we have definitions of complexity. Do you have a tapered stump? Do you have a blunt stump? Do you have calcification? Or do you just wire a channel? In subtotal occlusion, sometimes you need CTO techniques. And in fact, based on these anatomic features, you will choose your wires. So this is just a short overview how you can classify your wires. You have polymeric jacket and hydrophilic wires. You can divide them in soft tapered, medium non-tapered. Then you have the non-jacketed wires where you have also soft, medium, and hard wires. So you have a lot of choice. I think this depends on the availability you have in your region. Not all the wires will be available. You should not have all these wires, but one of a class you should have. So this is the toolbox for wire selection for CTOs. Depends on what you want to do. Do you want to pass a microchannel? Do you want to penetrate direct, like the Gaia family, where you have a lot of control of the wires? Do you want to knuckle, dissection reentry? You can take the Stingray, or today in a modern approach, more often use the Hornet or the Conquest Pro. And for collateral channels, these are the wire we use. When you go to the microcatheters, I think what is important is the torque transmission. How can you torque this micro? So we have two classes. We have the non-torqueable, the braided ones, that you can follow small channels. But if you have a challenging passage, then probably you will need more torqueable microcatheter with maximal torque transition like Corsair, Mamba, Turnpike, Teleport. So you also can classify them in catheters for channel use that have perhaps less performance Then the channel dilators you find in the middle. So depending on the anatomy that you find, you will choose your micro. You have specific micro catheters for passage of calcified lesion. One of the special is the turnpike spiral, which you can screw in, or the turnpike gold. So we have a large spectrum of microcatheters. I will not go into detail of that. But I think one microcatheter that is of more and more use, but you have to understand it, are special micros like the dual lumen or the triple exit microcatheter. So these micros we use a lot in complex PCI, not only in CTO PCI. So you have a huge choice. There is one micro that has a difference from others. This is the enhancer dual lumen. And as you can see on the right side, he has a stylet, a removable stylet. So this gives you more pushability. So when you have a lesion where you have difficulty to cross, I think this stylet can give you more support to cross the lesion. So I just show you one case. So this is a very calcified subocclusion of the LAD. The angle is perhaps not very defined how you pass in the LAD. The first wire we used passed subintimally, as you can see on the right side. So we are not in the true lumen. So we are just around the structure in the subintimal space, extra plaque. So unfortunately, we just could wire the septal branch, but nothing passed. No micropass, so we had to dilate it with a small balloon. Once you are there, you have other options. So what we did, we used this enhancer dual lumen, which gives a lot of support, and we were able to cross in the septal and then cross in the true lumen of the LAD, dilate it, put the stent in. I think this is a nice result of this ugly LAD. So I think this is a unique and new device because it's not just the dual lumen micros, it's the recross. You have two lumens, you have also the stylet, but you have 3 exit points. Oh, sorry, it's here. So you have 3 exit points, one at the tip, one on the side, and one on the proximal part. So the white lumen is connected to this exit and to the distal exit. And the blue lumen just has one exit. So you have exits on the opposite side. So you have many possibilities. And what is also unique, it's a dual lumen OTV. So it's not rapid exchange and OTV. So I just show you a case. So this was a proctored case. This is Joe Ricker, who is doing CTOs more and more also in our hospital. So you see the occlusion of this marginal branch. You can easily see that the wire is subintimal. It's not in the lumen. So you have many options. So one thing that has been adopted in the last years is the parallel wire technique, came back with these dual lumen micros. And what is good with the recross, you have an OTV. You do not have to exchange once you are in the other lumen. So the second attempt, this was a Gaia 3, was also subintimal. So what you can do, you come back, redirect, and you see the wire, and then at a certain moment you have a loss of resistance, a pop, and then you see the wire pops in the true lumen. So very elegantly, Joe did this case. And what is the versatility of this recross? You can do things you cannot do with other dual lumen microcatheters. Well, parallel wire technique you can do with every dual lumen, side branch access also. I think what is important when you have a distal bifurcation, important distal bifurcation, and you have crossed it and you have one wire in a branch, do not cross with the second wire through the CTO lesion. Take a dual lumen, you are sure you're in the same lumen, and then you go back to the side branch. So you will preserve the side branch. If not, if you get in the subintimal space to the side branch, then you will lose one of the 2 branches. Special indications for the recross is that you can try to repuncture back and use it like a form of modified ADR. It's not as specific as the Stingray system, but some people try to do that also. And what is good when you have, and when you do a dissection reentry technique, you have two ports here. One where you have your wire in, one where you have your wire in, and the second one you can use to aspirate the hematoma that you have created in the subintimal space. That makes it more probable that you can repuncture in the true lumen, because the true lumen that has been compressed by the hematoma will open up again, and then you can recross with the second puncture wire. One thing that we use a lot are trapping balloons. The advantage of trapping balloons is that they have a smaller diameter, so you can trap also in 6 French. And what is the specificity of this wire is that you have an auto stop here. You see that here. So it will stop before you exit the guiding catheter. And then you can trap your gears and take out the microcatheters. So another tool we use extensively today in complex PCI are guide extensions. And they have many indications. So one of these guide extensions is the Gideon, who has a hydrophilic arthromotic tip. And it's at the tip, so you will see it, so you can identify it. And one of the indications where we use it today more and more is in the reverse card. So you have an antegrade wire or retrograde wire, they are not in the same space. What you do is you just balloon at the site of the occlusion, and then you follow with your wire into this space, hoping that you will get in the same space as your antegrade wire. And then you will get into, you see here the tip of the guide extension, and then you enter, and then you have connected the proximal true lumen to the distal true lumen. They have many indications. They enhance support for balloon, stent passage. One thing that I do more and more is when we have very calcified lesions, I do not cross with the stent through the lesion, because sometimes you have to apply a lot of forces. And what has been described, that you have on the abdominal side of the polymer of the stent, you can destroy the polymer just by crossing the calcium. So what we do, we go down with the guide extension, we pass with the stent, retrieve the guide extension, and then put the stent in. As I said, the reverse card. And one thing I sometimes did is, this is an Italian publication, so you can do rota through a guide extension while leaving a side wire in the side branch if you think that you can risk to lose the side branch. This is feasible, we did it also. And perhaps a last comment is, we have learned that image-guided complex PCI is better than angiographic guided. This is true, but the problem is image guiding does not guarantee a good result. So when you look at the sub-analysis of the ultimate trial that compared ultrasound to angiographic guided PCI, you see, and this has been looked at in the core lab, if the result that you obtain is not controlled by the IVUS or by the OCT, the result is not as good as if you achieve a really optimal result. So these are both IVUS-guided PCIs, but this is an optimal result, and this is a suboptimal result with dissections or stents that are not deployed. So in summary, I think success depends a lot on material, on techniques, on algorithms you have to use, on your mindset and on your hands that you will train. Thank you very much.
Could we call this the device you saw the recross as a poor man's Stingray or a crossbus technology, or is it that one bridge too far?
That's not an easy question. I think you have to be exposed to ADR. If you know the technique, perhaps you will be able to do that. But even experienced operators are still learning to do that. So I think in the first phase, the success rate is not as high as in the Stingray group. But I think that depends on the anatomy. The risk what you have is if you extensively wire, you will grow your subintimal hematoma, and then you will finally lose the option of ADR. So I think in the first place, I would say it's parallel wire technique. So the recross is really a good tool for parallel wire technique. And the huge advantage is that you have two OTV ports. That makes it very different from other dual lumen micros.
The principle of trying to evacuate the hematoma by aspiration, I saw it, I don't know, many years ago, shown by a guy from Hong Kong. I apologize, forgot his name. He used it on a dual lumen catheter in ostial RCA dissections. I have no experience, Olivier, I don't know, but I have no experience, but have you really think it works? I've seen it happen. It really works? Or?
Yes, it works. We do it sometimes when we have loss of visualization of the distal target. You can aspirate, you inject from retrograde, and you see that the lumen grows again. So it works. What I did not mention here, what you have to do is you have to stop the inflow. So you can put a balloon in the guide extension, or there are specific devices for that. You have to stop the inflow. If you put the guide extension into the CTO, you will stop the inflow because you can aspirate. But if the hematoma if the entry is open, it will fill up again. But it works. If you close the entry and you aspirate, it works.
Just a comment, the people in the back, there are still places here up front if you want to. You can stay there, I'm not sure. But if you want, you can come down, have a more comfortable place to sit. Olivier?
Yes, I think we have to move on. Thank you very much, Daniel, for your brilliant talk, for complex PCI, and especially the tools that we have available for that kind of procedure. So we have to move on with Goran. Are you still here?
I am still here, and thank you for the kind invitation.
The word is yours.
So I'm just going to see if I can start sharing my slides with you.
Okay, the title of your presentation is the Tools Required When the Worst Happens, Coronary Artery Perforation Case. It's a fear title.
Thank you, and thank you once again for the invitation and for the organizers. It's a brilliant meeting that you have in Switzerland, Lausanne. I'm going to be talking then about a coronary artery perforation case, mainly focusing on the case and how to deal with a disastrous case. So these are my financial state or disclosures. So this is your basic sort of patient that we see in the cath lab, 86-year-old male, previous PCI with LAD, hypertension, had normal ejection fraction afterwards, and now he's now hospitalized with an N-STEMI, but fairly stable, and still normal EF on echo. And about 8 hours after their admittance, he is taken to the cath lab. So this is what his left cornea looks like, and he's got significant coronary disease in his circumflex. LAD looks pretty okay. And then you have the right coronary artery where we think the main problem is located. It's a highly calcified artery, and it's tortuous, and this is what we're going to be focusing on. This is what it looks like. So, heavily calcified, we may have to use rotablator, shockwave, cutting balloons. Following PCI of the right coronary artery, you would probably need to treat your circumflex. One thing of note is that it's Friday afternoon at 3 p.m. So it's a fellow in our cath lab who's doing the case, and I am helping him. And the wire goes subintimal here. So it's quite a challenging case just to get the wire through. It goes even more subintimal here. And now you can see that there's a problem developing mid-right coronary. It adds a microcatheter, changes wires, and the wire is still subintimal, and then he loses his wire position and guide, and the vessel is starting to close up. So he gets some help, and using a Fielder XT wire and of course our catheter, the lesion can be traversed, and then we can switch out to the Corsair to Stein Blue. So then we have sort of basic setup here where we need the guide liner to facilitate also, and we can get balloons down, and luckily we don't get any dog bones. So it doesn't look like we need any use of rotoblader or shockwave, anything like that. So post-ballooning, this is what we have. Everything's looking good so far. And we put in 2 stents, 3.0, 3.5. We probably need to post-dilate the 3.5 stent. And we have something that looks like this. And then the question is, should we put another proximal stent? And the obvious kind of answer is that yes, we do need to put in a proximal stent. So a 4.026 stent is placed here in the proximal right. And this is what happens. So this is a very, very large perforation, Ellis type 3, and the immediate reaction from the patient is that he goes into cardiac arrest within 30 seconds, pulseless electrical activity. And this sort of shocks the whole cath lab, it shocks the fellow, and this is the time where you need to know, have an algorithm exactly, everybody needs to know what needs to be done. So the first thing to do is to seal the perforation. And this is done then fairly quickly with a stent balloon. Patient is in cardiac arrest, anesthesia is called down, patient is intubated. We maintain circulation with manual compressions quite well. And then I tell the fellow, this is time to relax. Put the drain in, and after that, the situation will stabilize. So during apnea and no compressions, the drain is placed. And for the audience, I could also say that don't use small drains. I would say minimum 8 French drains. And don't give protamine in a situation like that because it will only clog up the drain and cause problems in the coronaries. What happens then is that he has immediate ROSC after placement of the drain. 500 milliliters of blood is withdrawn. Circulation is now intact, and it's the time to plan the strategy. And in this case, in this scenario, I think the best way to solve it is to use the ping-pong guide technique. So you need to have another access, and this is usually then a new ephemeral access. And there's really no reason to rush here. The patient has circulation on his own now. There's no bleeding going on through the perforation because you have a balloon inflated. And you can inform this cath lab staff what is going to happen and anesthesia so that everybody is aboard. And this is just for showing the coronary Ellis perforation classification, where you have a type 1, which is local, type 2, which is a little bit of myocardial blush, and you have a type 3, which is a large contrast jet to 1 millimeter exit hole. So this is definitely type 3. But the ping-pong guide technique is very simple, and it can really solve or help you in a very disastrous situation like this with a massive perforation. And basically all you do is that you go back with your balloon to the perforation and stop the bleeding. And after that, you back up your catheter a little bit outside of the ostium of the coronary artery that you're in, and then you get a second access. And using this second access is when you then keep the balloon inflated till you have the new guide in situ, and then you can deflate the balloon and then move your guide wire through this from the second guide down distally. Then you can inflate your balloon and then get your covered stent close to where you want to bring it. And at that point, you can then remove the previous guide, deflate that balloon, and then inflate your covered stent. And and hopefully you've sealed your perforation. So, as you all know, we've seen people in the audience who have been in PCR for a long time. We used to have the traditional double layer sandwich design stent, graft master stents, but we now have the single layer covered stent design with excellent trackability that will fit into 5 French guides. It's so much simpler to use these types of stents today. So this is what's happened now. In our case, situation's been stabilized. Patient's got circulation on his own. Balloon is still inflated here in the right coronary. And we have a second guide now getting close to right coronary artery. It's the drain there also. And we're getting ready to catheterize the right coronary with the new guide. And with the second guide in place, that's the time then to deflate the balloon and wire the vessel from the new guide, and then reinflate the balloon again. Vessel is now wired through a second guide, so you have 2 guide wires distally on the right. We have our new guide here. We still have the original balloon inflated, and then it's time to put our papyrus stent in place. And here we used the 3.526 papyrus after we've, of course, withdrawn the first balloon wire. I tend to, maybe it's a little bit from the graft master days, but keep the covered stent inflated for a long time, up to maybe 2 minutes, and at fairly high pressures, in this case 20 atmospheres. And this is then the immediate result afterwards. So we still have a distal underexpanded stent, but we've sort of rescued the whole situation in the case. So we discussed very briefly whether we should post-dilate or not, and we decided not to. So this is then the final result, which patient is very, very stable. So I think follow-up after this was then he had cardiac arrest for 7 minutes, but was circulated well with the compressions, extubated after 2 hours and then fully awake, and an uneventful hospital course except some rib fractures and pneumonia, discharged after 6 days. He's 86 years old, mind you. We were still debating, I don't know what happened afterwards, if we ever did bring him back for the circumflex or not, but at the time we discussed it. In conclusions, I think modern low-profile covered stents are essential to have on the shelf in every cath lab that performs PCI. Operators should need to be trained in techniques such as the ping-pong guide techniques during perforations. It's also recommended to have modern externally released coils, neurocoils, for the smaller types of perforations, usually in distal branches. And these modern neurocoils can pass through the regular series of 14 compatible microcatheters, as we saw Daniel present just previously. And I also perform team trainings at regular intervals so that the cath lab team knows the routine and where the equipment is located, such as pericardial drains, covered stents, and coils, and so on. And especially in disastrous situations like this when patients just quickly go into cardiac arrest. So with that, I thank you for your attention, and I'm open to questions.
Thank you very much for this excellent talk regarding a type 3 perforation treated with the cover stent. I think you described nicely the ping-pong technique, but I wish we can go back in the history of your case and see how we can prevent actually this perforation. That would be easier way to treat it actually. You had this dissection created of this mid-right, and then you implanted a stent, and then you injected through an extension catheter. Do you think that injecting through an extension catheter in a fragile wall would be the cause, or what do you think? If you go back, what would you do different in order to avoid that?
I think that you're very right in what you ask. I think one of the quintessential questions is, if you have a calcified artery like this, I think IVUS should be done for OCT to see actually what does the vessel look like. how big can you make the stents? Was the stent too large for that vessel? That's one of the key things, I think. I think also what actually happened was that the patient completely crashed after he released the stent balloon. So the angio shot there was to check if he could see what had happened. So I think the perforation was there. But I think your point is very well taken, that be very careful about injecting through guide liners or guide extensions in these types of vessels.
Thank you. I think we had a great session. Maybe one of the issues, we're a little bit behind schedule, but maybe there are two issues I think we've covered. Stan, the great news we have Papyrus, we have two other companies that make this low profile. Please come. There's a lot of space here down on the right side that provide really excellent low profile covered stents. There are maybe two issues you can comment on that, Goran, that you put in the cover stent and it's still bleeding. So what are the issues? And then the second point, we may need cover stent of larger sizes because we are limited to this 4 millimeter, and we have occasionally used peripheral covered stent in some situations which we really shouldn't probably do. So I don't know if you have any comments on that before we conclude this session.
Exactly. I think that the ongoing bleeding after you put your first covered stent is very common, and you need to be able to continue to go distally or proximally. I think it's very rare that we just use one covered stent to solve the problem. The other issue, like you said, we do need to have bigger diameter stents. There are within the peripheral field, but I think it's always an issue of trying to get a hold of those. So yes, there's still room for improvements within the covered stent field.
Yeah. You have a question? Then you need to take a microphone. A short question.
As a just short comment or question, I'm Kamal Khan, fellow interventional cardiology from Queen Elizabeth Hospital, Birmingham, UK. Regarding the perforation, recently, honestly, we had a similar case of perforation. I presented a similar case in a conference, and Prof. Curtin and Iulian had a point. Why ping pong? I mean, they say, and I studied back, Papyrus, they claim it is compatible even with 5 French guide. Once we have 6 French guide, unless we have guide extension, then it's okay. Otherwise, with the same guide, we can rewire with partial deflation of the blocking balloon. And we did this last week. We rewired and we took Papyrus on the same 6 French guide and then deployed it, taking out the blocking balloon and the wire. And regarding your question of of persistent leak despite deployment of, again, we had honestly last week the same problem. With struggle, we deployed another DES. It was still leaking. It was a large size OM. Then another consultant gave a point. It's endo leak. It's probably you need to pop another proximal covered stent with high pressure and larger size, and that worked. Thanks.
There are two main reasons why patients still bleed after a covered stent. That's one, you haven't identified the right spot of the bleeding, and so you need more stents, or you have undersized, or you're not completely opposed to the vessel wall. So the two main reasons, because that's what the point we made this morning on the perforation we saw. You have to be absolutely sure where it's bleeding, because you have to pinpoint your device at the right spot.
Thanks.
Goran, you agree?
Yes, I mean, that's the classic thing that you put your first stent in there, and then you think that you are covering the area, so you usually need quite long stents, fairly long stents. And most of the time, the ones that I've put in, I need to extend either proximally or distally or both, and also possibly then go to larger size in the proximal part and expanding them at high pressures.
Thank you. I think this concludes this session. We, with all our respect, we can discuss during the break. We would like to thank all the speakers, the panelists, the chairs. Go back to the cat lab. And we would like to thank Biotronic. We're happy to see so many people in the audience. That's really heartwarming for Olivier and me. We appreciate you being there. On top of that, we are going to change now chairs. This is going to be the Swiss session. So the Swiss working group is going to be here and chair this session. And that's the occasion maybe from the people in the back to find a nice spot to sit. So we'd like to ask Gregor and Daniel to take over.
Okay, thank you very much, Eric, for the possibility and the opportunity to be here and present on behalf of the Swiss Working Group on interventional cardiology. We in Switzerland have a long-standing tradition of a winter meeting that is basically a presentation of cases with complications, discussions with experienced operators, and just gathering ideas how we could do better if we have this same complication next time. I think this is very good. So the cases that will be presented today come from the winter meeting, and the third three cases were elected to be presented here, and one will be presented by you. One last. Okay. I hand over to my great friend Gregor, who has organized the winter meeting. So he was the president of the winter meeting to invite the first presenter.
Yes, thank you very much. Nothing to add. I'm just not the person that was winning anything. So I was the person organizing it, and that's why I'm allowed to present the case. Hopefully it's also an interesting case. Now it's my duty or my honor to introduce Nathalie Noirclair as winner of this year's Swiss complication meeting. There are all over 16 cases presented, structural and coronary cases, and then through a very complicated voting, we elected Nathalie to win the case, and I invite her to present it here.
Thank you, Gregor, for the introduction. I'm interventional cardiologist here at the CHUV in Lausanne, and I'm presenting the case on behalf of all the team. And this case was handled by Eric Eckhout. So, about the clinical case, it's about a 79-year-old woman. Her past medical history was that she had an aortic valve replacement as a trifecta 23 millimeters in 2015. She had also a complex orthopedic treatment, and that really matters, you will see later. The current story is that she was admitted in January 2021 for investigating angina persistence, and the electrocardiogram show a left bundle brush, that was new. She first underwent a CT scan because they suspected an aortic dissection, which was negative. And then she came in the cath lab because the STEMI network was activated. Here you can see the coronary angiograms in really small, but trust me, there is no culprit lesion, no critical lesion. And you can see the hemodynamic curves. If we go retrospectively, you can see that the diastolic pressure, aortic diastolic pressure, is almost equal to the left ventricle diastolic pressure. And this matters, you will see next. But that day, the evolution is that she went hypertensive. She had a pulmonary edema post-angio that was treated, and she was taken care in the intensive care unit by our colleagues. When she arrived there, the echo showed an aortic regurgitation, but it was difficult to quantify how intense it was, and the day ends. The next day, it was a special day because it was a live case day with a transmission to Singapore. And there was a first AV at 9 a.m., a second scheduled for 11 a.m. in case the first didn't show up. But our patient, how was she? She had still a pulmonary edema. She was intubated, and she finally got her transesophageal echo that showed a massive aortic regurgitation. There were no arguments for any endocarditis. And here you can see the images. So the massive regurgitation with the prolapse of a leaflet. And you can also see that there is a little hypokinesia of the left ventricle. At this time, so it's 3 in the afternoon, she's in profound shock with an acute renal failure. And so the surgeons don't want to touch her. And she would be the third TAVI of the day. Third TAVI, yes, but it's at high risk for any complication because, first of all, there was no dedicated TAVI CT scan available. Second, we didn't know about her vascular status. And third, she was in profound shock with acute kidney failure. Fortunately, because she had the CT for the suspicion of the aortic dissection, they could make a reconstruction. They could see that the left main was taking off at 12 millimeter. There was an acceptable sinus size, and the RCA takeoff was at 3 millimeters, so pretty low. She had also an echo of the vascular axis, which showed acceptable femoral sizes and no other abnormality. Another thing to remember is that she has a trifecta valve, so we presume that we cannot do any valve fracture. Now you can understand why this case was pretty difficult, because you see that all the materials from her back, which is pretty annoying to find a good view. So how was the intervention performed? There was a double femoral access, an external pacing ready. And finally, he could find the right view to implant the valve. For choosing the valve, it was made according to the app VIV. It was an Edwards 23. And the implantation is okay because it's as the recommendation. So we can see that the bottom of the small cells are just below the margin of the stent of the trifecta. And also what happened is that while putting on the Safari wire, the pressure dropped down at 30 millimeter of systolic pressure, and so they didn't even need any rapid pacing. They also did a protection of the RCA with a stent in place, but when they inflated the valve, the stent went off. So here is the result after the valve implantation. I'll let you have a look, and then you tell me what you think. So what happened just after that is that she had a cardiac arrest. And what would you presume which complication do you think that happens? So first of all, an aortic root rupture. Second, there is a massive aortic regurgitation because the valve is too low, or a coronary obstruction, or any other possibility. So who voted for A? 1, okay. For B? Okay. C? Okay, so half B, half C. Can you just put on the video, please? So here you can see that the implantation is correct. There is indeed a regurgitation, but which is increased by the wire. But if you look at the coronary arteries, there is no left main, no RCA. So what happened is that the leaflet of the surgical valve was obstructing the left main. Something that should have been done before, but that couldn't be made, is the measurement of the distance between the valve and the ostium of the left main. That would have helped knowing that the left main should have been protected also. But what now? What do we do now with this patient? Cardiac arrest, no left main. Do you propose ECMO and try to open the left main? Do you propose something else and try to open the left main? An ECMO and a new valve? ECMO and convert to surgery? Tough decision. Who votes for A? Okay. B? No one? C? And 4, sorry, it's numbers. Okay, so the idea was this. So he asked for a Lucas and did the procedure on the Lucas, so it's quite moving. He took a guiding catheter. He could cross the valve with a wire dedicated normally to CTO, so it was a Confianza 12. He could pass into the LAD, make an exchange with a microcatheter. Here to the left, he inflated the balloon to open the valve, implanted a stent from the left main to the LAD. And here is the result. So the left main is open, the artery is open, and you also can see that there is sometimes when the Lucas stops and it takes back afterwards because she kept doing cardiac arrest, ROSC, cardiac arrest, ROSC. So the immediate outcome is that she recovered her hemodynamic status. And here is the echo after all this. You can see that there she recovered her left ejection function and that there is a good result of the TAVI. But she went again in shock on Lucas again, and after 2 hours of on and off, because also of the severe acidosis, she finally died. Here is the last, before she died, the last TEO. Sorry, I was too quick. So what we learned is that despite the awareness of the risk of a left main obstruction, this fatal complication occurred. Also, what we can think is that she was already, it was already too late. Maybe if she was taken care of before, the issue would have been different. And so this is a typical example of a Swiss twist model complication. Thank you.
Thank you, Natalie. Even the second time I see the case, I'm afraid. I think must have been a nightmare, but thank you for presenting these cases. So it's open for discussion. Are there comments?
Maybe it's easier for me to give some insight. I'm sitting here. So it was indeed the case we did after our live cases for Sing Life. And I was involved together with Marion. It was late in the afternoon. And the reason why Natalie presented the case at the Swiss winter meeting was that we were in the cath lab. So you were so kind to take over and to present the case on our behalf, not having been involved. So I would like to thank you for that. And I would also to thank the Swiss working group to find our case one of the most interesting. It was for the team, for the nurses, for me, for Marion and me, quite tough moment because we saw the immediate recovery of LV function, and we struggled for 2 hours up and down on Lucas, and we realized that we lost the patient. It was even so strange that we stopped everything after 2 hours, and then the patient recovered pressure. We could put the patient in the bed, and the patient was pulled out of the cath lab into the outside the cath lab, and it was there where she finally arrested. But it was quite a tough case, and you know, we know all that. We know that we probably should have put the stent in the left main instead of in the right, but it still happened. So you know, I think it shows human nature and errors that we all make.
Given the really impaired visibility initially due to these osteo surgeries, what was your decision to go with even more reduced visibility with the Lucas and not trying to get Impella or ECMO in this patient?
The point is she was basically dead. so we had to resuscitate. So the only thing that would immediately restore hemodynamics and pressure was Lucas. And we were basically very alone. The surgeons was just watching us. They were there watching the case and said, oh, you have a complication. Say, you want to convert to ECMO, you want to take it to the OR? No, we said no before, we say even more no now. So the other mistake, this was potentially a surgical case. She's 78, she had no more comorbidities. She should have gone for surgery probably.
Maybe also we can think that it's a valve involved with a new valve, and so putting an impeller into this, maybe not feeling comfortable with it?
No. It took you 2 hours to get into the left main?
No, left main was very quick. No, very quick. We put on Lucas, and we opened the left main after a few minutes. Oh. The reason why we lost this patient is our hypothesis. This is a myocardium that is suffering for more than 24 hours. And we know how acute massive aortic regurgitation is very badly tolerated by the LV. So I think that there was a combination of very bad metabolic status and a suffering myocardium that could not just sustain this second event, I think. I don't know, Malcolm, what do you think?
Well, it just looks like a nightmare of a case, but there are so many things and leading up to it. So I think that 24 hours or so before, but you know, I don't think you'll ever know. But this was not that just an emergency just came into the lab. I mean, she was anuric, she had metabolic acidosis, she was in shock. I just have a question here, and I was actually going to bring it up this morning in my talk. When you have a complication like this that results, you know, whether it's a fatality or not, but you know, it could be a near miss, but a fatality like this, and we see this in our own lab. I have moved now in the last few years that if something like this happens at the end of the case, when everything's cooled down a little bit, we'll bring everyone back into the room and do a debriefing. Because this is, you know, takes a huge emotional toll on everyone around. And you had a very busy day. You're doing live cases, as understood. You've got techs, you've got nurses, you've got fellows, and you know, someone just died. And I think many people have unanswered questions, and they go on and do the next case, or they go home. And I think that it's really important to bring everyone together and let everyone speak. And I think that this can be very, very helpful. Also, sometimes you find that someone was trying to tell you something and no one was listening because there was too much noise in the room. I'm just talking generally, not about this case. So I just wonder if others have taken this approach of doing a debriefing after really serious complications, and particularly a fatality. The first time I saw it in action actually was a patient in our emergency department many years ago that we could not salvage. We were waiting to bring it up to the cath lab. And I was really impressed with the way the emergency department brought everyone into the room. And I was standing there as a witness to this, and just seeing the toll on, you know, people's faces that they just lost this patient, and everyone worked so hard for 2 or 3 hours to resuscitate a patient. But Eric, do you do any debriefing here, or is that something that is done elsewhere? Is that common or not common?
There is a kind of legal obligation to have morbidity mortality conferences, so these kind of cases are discussed rather within the department than into the team. It was late that Friday. We debriefed shortly with the whole team, but basically we left it there. We didn't go further. I think everybody was exhausted. Everyone wanted to go home, and then next week I discussed individually to the people if they wanted to sit down, but basically everything was quite clear in their mindset. But it's true that we tend to do it, yeah.
Well, I think this is a very important input. We always do it, and we do it immediately after. So I think you cannot let people go home with something they would, even in terrible cases like that. When it's a good outcome, then the debriefing is easier. But in these cases, it can be much more difficult. So I think we are used to that. We do it immediately after things happened. And as Eric said, we have the obligation to do M&M. And then we go a little bit more in details, learning points, key points, what would we do differently next day. And you can train it, so you can simulate in a room where you are filmed by experienced people, so they get you in a situation, and they will do things like let them struggle, just to see how you react. And what you said is, he wanted to tell me something, but I didn't hear it. So, and when you see yourself in the camera acting, then you are, why didn't I hear it? Didn't I want to hear it? So I think that's very important that we also train it, not only when it happens, but we train in when we are relaxed. And it's very stressful afterwards when you go to the debriefing of a simulated reanimation. And I think that's very helpful. Okay, thank you. Thanks. Great case. I think also it is important to show these cases. So we move on to the next case. I think it's also a structural case. It's not Philip Hagers here, but Oliver Schmiadi. But you were in the case. So thank you for presenting the case that won the second prize at the Swiss Winter Meeting.
Yeah, dear chairs, dear colleagues, thanks a lot for this kind invitation here and for giving me the opportunity to present here on behalf of the whole team our case. My name is Martin Schmiadi and I'm a cardiac surgeon at the University Hospital in Zurich. And we have a very strong collaboration with our cardiology colleagues from the Kantonsspital St. Gallen. Once a week we meet up for a real heart team meeting where we are discussing upcoming cases and also do maybe debriefings as discussed just now, yeah. And another day in the week we have our common day in the operation suite where we are performing together structural heart interventions. And the case I'm bringing today, as discussed, was already presented here on the Swiss winter meeting of the Swiss working group. And as we are here a really mixed group from people all over the country, I really just can recommend to have this kind of small meetings also back in your countries. It's really always very stimulating to have discussion on things which also maybe didn't went so well. The case I'm bringing here with me is a case of a 79-year-old lady who was admitted in our emergency department with acute dyspnea and severe angina pectoris symptomatic. As it was also the corona time 1 year ago, she just had her second shot of the COVID vaccination 2 days ago. We see it's a more or less small lady with a body mass index of 29, so was quite obese patient. From the hemodynamic you can see at the moment in the emergency department she was quite stable. We had even a little bit hypertensive blood pressure, but she was needing a little bit O2. So we performed the X-ray. Here you can see already on both sides the pulmonary edema, and those who are looking maybe a little bit more in detail, you can see there already the sternal cyclages. Yes, so you can think about that maybe this woman had already a sternotomy and maybe a cardiac surgery in the past. So of course also a 12-lead ECG was written where we didn't find really significant changes of the ST segments. As I told you, it's always good to also have the medical history of your patient in mind. In this case, this patient underwent 10 years ago already a cardiac surgery. There she got a coronary bypass operation due to a non-ST segment elevation myocardial infarction, and they revascularized with a Lima to LAD graft and with a vein from the aorta to the first and second marginal branch of the circumflex. Somehow, unfortunately, already after half a year, the vein graft was occluded and the patient underwent stenting of the left main and the circumflex. So far, this went well for nearly 8 years, but then the patient presents again with chest pain and progredient dyspnea. And in the cath lab, they found that we had a re-instant stenose of this stents, and she got a PCI with a drug-coated balloon. And more or less a few months before we then performed the TAVI procedure, she was again admitted to the hospital under resuscitation due to ventricular fibrillation. Also that time she underwent again a cath examination, but there no progredients of the coronary artery disease could be found, but we saw now a really progression of the already known aortic stenosis, and she had now a moderate to severe aortic stenosis. And looking to the other organs, she also had a chronic kidney disease with a clearance from 46 milliliters. And the echocardiography you can see is quite an eccentric hypertrophic ventricle. We also had a moderate mitral regurg. You can see that the left atrium is already dilated. However, the myocardial function with an ejection fraction from around 50 to 55 was quite well in this patient. Of course, also we done again a coronary angiography. Here you can see the Lima to LRD graft is running quite well. And here also you see the shots into the right coronary, which is not having significant stenosis. And also on the left side, you see quite a good result of the circumflex system after these multiple inventions. In the CT scan done for the scheduled TAVI operation, you can see more or less a normal shape of the annulus, a little bit more elliptic from the size in the middle range. Also, as discussed before in the picture, we also measured the highness of the coronary arteries. There you can see that especially maybe the left main coronaria is a little bit low. Also the sinus is measured with around 27, which is not so large, but we from time to time see this kind of anatomy, especially in the smaller, older ladies. Of course, also nowadays, as most of the procedures are performed from the peripheral vessels, important to have a well imaging of your exercise. But here you can see that especially down in the femoral side on the level of the hip bone where we want to puncture, these vessels are having quite a good diameter and are not very much calcified. So the next step now to discuss in the heart team how to treat this patient, this aortic stenosis. I think if we calculate here everything, we have quite a high Euro score. For a surgical patient would be a redo operation with a quite well-functioning Lima graft, which is always under risk in a reopen procedure. So also according to the age of the patient, I think nowadays most of the people also would agree that this is a quite good case for interventional aortic valve replacement. The next question, of course, nowadays we always have to discuss which valve we want to discuss implant in our patient. And the University Hospital of Zurich, we have at the moment this 5 valves available where we can choose. And I think keeping in mind that this is a patient with a coronary artery disease where we maybe have to do re-interventions, I think it's clever to have a valve which maybe don't go so high that the coronary arteries may be covered. So we can think about to have a balloon expandable valve, or we also can have a valve with large struts maybe, which are easily or more easily to pass with a catheter later. So our approach, I want to present you here now in this slide. So standard procedure by us is that we are performing the peripheral puncture under ultrasound guidance, to make sure that we really are above the bifurcation of the femoral vessels in order, if you have the excess complications and you have to implant, for example, a stent, that you have enough distance from your bifurcation in order to do their safe stenting. And in this case, we decided for closure of the large bore access with a MANTA device. On the left side, we had our 6 French sheaths for the pigtail catheter. From the right side, we were implanting the valve, and from the right radial artery, we had also a 5 French sheaths for our Sentinel protection system, which we are also using in all cases where it's feasibility from the anatomy. For the implantation, we are using the pre-shaped safari wire, and in this case, we decided at this time it still was a portico. Now we have the Navitor available, but a self-expanding valve. Predilatation was done with a 20mm Zipka balloon, and here you see the implantation of the valve. We were starting in a 3-cusp view, and then also in order to achieve a commissural alignment, the end was implanted in cusp overlap view. We had a quite good result after the implantation. We removed the Sentinel device, we removed the catheters, and we closed the large bore access on the right femoral side. And as you can see on the outer slide, we had there bleeding. Yeah? This was also the moment where the anesthesiologists were telling us that the patient from the hemodynamic is not stable anymore. Yeah? So we decided to perform, as you can see in the middle, a stenting with a Viabahn self-expandable prosthesis. And after this final result, you can see on the picture on the right. So we thought we had closed and treated this very well. Also at this moment, the patient stabilized here. Yeah? Here we had the bleeding, then we closed it. We were for a short time in stable situation, but then the hemodynamic decreases again. And maybe I go back. And of course, we have to think now about what could be the problem for this deterioration. Yeah? Of course, maybe we had overlooked annular rupture, yeah? That we have maybe now a pericardial effusion. Also, coronary obstruction could be an issue whenever you have wires in your aorta. I mean, on the first pictures you saw that we had quite a calcificated arch. Yes, you also have to think about iatrogenic type A dissection. Yeah. Also, due to the bleeding, we gave protamine, so also keep in mind maybe allergic reaction. Or, of course, could be also that we have maybe a retroperitoneal bleeding, which we didn't saw so far, and that the patient is in a hypovolemic shock due to bleeding. So we went back, we performed again a root shot. There we could not see anything, any hint for annular rupture or perforation or dissection. Then, of course, we performed emergency echocardiography. We also could not see a huge pericardial effusion. The function of the heart was quite normal. And so we decided to go down and make a angio-CT. And there you could see that we saw there a little bit contrast aging, the small nose. And we discussed it with the radiologist, and of course it was not possible to rule out the active bleeding. And due to the still depressed hemodynamics, we went back to our hybrid suite. We gave, as you can see, again a shot of contrast agent, but we could not see any active bleeding. However, as we were in the operation room, we decided to post-dilatate the stents there, as you can see in the middle with the 5mm Mustang balloon. And on the outer slide, you can see then the final result again. We bring the patient then to our to our intermediate care unit. So overnight, more or less, she was stable. Also in the ECG, we didn't saw any new abnormalities compared to the preoperative ECG. And of course, we had a drop in the hemoglobin. She also received 2 packages of red blood cells. But more or less, during the first day, she really was quite stable. And in the morning of the second day, we saw her in her bed. She also was doing quite well, and we were thinking to put her on the normal ward on this day. But 2 hours later, she complained about chest pain, and we saw now newly this ST segment elevations, which clearly were not there before. Yeah? So due to this coronary artery disease, we went back to the catheter lab, because we were afraid that maybe due to the protamine and all the blood products, maybe we have a stent thrombosis or something like this. But as you can see here, in the circumflex and in the main, the stents are open. I have to mention here that we were not able to selective intubate the right coronary artery, but we gave a shot here into the root, and also there you can see more or less that the contrast in the right coronary artery is running quite well. Also, the echo still was unchanged. We didn't saw new wall motion abnormalities or something else. However, in the further course, the patient deteriorates more. She was getting hypotensive, she was needing more vasopressors, she was going back to the intensive care unit, and in the echocardiography we saw now that the pump function is more and more reduced. The mitral regurgitation is now severe and not anymore moderate, and also the right heart function was more and more severe depressed. And when we look retrospective here to the enzymes, you can really see now also that not only the proBNP but also the troponin more and more is rising. Of course, she had a kidney disease, but however, I think it's significant moving upwards. So in further course, as I told you, the patient more or less was in shock, was needing higher doses of vasopressors. Differential diagnosis we were thinking about could be that she's maybe having somewhere septic focus, which we were not aware of it. And of course, we maybe also had to rule out again that really this vascular complications which we had is not bleeding. So we decided again to go back to the CT. We ran an angio-CT again. We could not find any focus. There was no bleeding. And however, then in the morning of the 4th day, the patient also died. What was very interesting then, after talking with the relatives, we done an autopsy. And you can see in these images that we could, when we were taking out the heart, we could very nice from outside put a probe into the left main, but there's a video here. Maybe you can try to run the video on the right side from the RCR if it's possible. Because there, what you could see there is we also were trying to put a probe inside, but the probe was coming out exactly under the stent strut of this prosthesis. So we had a partial occlusion maybe of this ostium, and also going back then and looking retrospective to the CT scan, you also can see that we had here a rim of calcification over the right coronary ostium, which also could have been pushed a little bit down and lead there to a partial occlusion of the right coronary artery. So this is an official statement from the pathologist. I mean, of course, the first things we were knowing, we have, of course, a concentric hypertrophic myocardium. And I think the most interesting is that they are describing here in the inferior area more or less subacute infarction, which maybe fits to the time interval of the intervention. I think what we can learn and discuss from this case is which device we should use. As I discussed in the beginning, retrospectively maybe would be also approached to take a balloon expandable valve, which maybe would have kept the coronary ostia more free in this case. And I also wanted to point out again really that we should really give a thought for this commissural alignment in order to make sure that we don't have the neocommissural posts above our coronary ostia. Another complication side we had was this bleeding from the artery. In this case, we use the manta closing device. I think there also two pitfalls can happen. One problem may be here your anchor. Yeah? If you have a small calcified vessel, this anchor maybe can stuck on a plug so that it will not occlude nice your large bore access. And another thing is that you really have to make sure that you press the collagen well to the anchor in order to don't have here side bleeding in the end. And I think especially in this obese patient like we had here, maybe with the pressure we stuck somewhere here in the fatty tissue and we didn't bring our collagen probably down. Alternative would have been maybe this technique here described by Co and colleagues, that we would have done a closure with a ProGlide in combination with the 8 French Angio-Seal. And more or less here are the conclusions of this case. I already stressed the topic with a valve choice and with a commissural alignment, but I think we also have to take into consideration from the clinic, yeah, which I described you with more or less only this is hypertension, yeah. It can be really very challenging to make there the correct diagnosis for osteal impingement after TAVI. Yeah? And still, to us, it's not 100% clear what was the main problem. Yeah? If it was this calcium, which was maybe pushed to the osteum, or it was really maybe this stent strut from the commissures, which were in front of the right coronary ostium and making a dynamic inflow obstruction of the right coronary artery. But I think for the future, it's really a topic we have to work on all together, is to achieve commissural alignment whenever it is possible, and also maybe with the industry work more on delivery devices which can make this procedure more easily. Yeah? So with this, I want to thank you for giving the opportunity to present here and open for questions.
Yeah. We get the microphone.
I didn't understand why you decided to implant Portico, not a sapien from start. What is the logic? You have low take-off, RCA, and left main.
Yeah. One argument you could choose for the self-expanding valve is that we would have had the opportunity to resheath it. Yeah? So the plan was we implant it, we can look then during deployment how it's doing. We saw by the implantation we had a root shot where both coronary arteries had contrast. Yeah? So we were quite sure that it will work out. And also after releasing the valve, we didn't have immediately a problem. Yeah?
And I didn't understand what happened till now. I didn't understand.
The problem, this is quite funny because nothing was prepared here, but we see 2 times issues potentially of coronaries and valve interventions. And it's potentially compatible with suffering on the anterior wall, but the patient has a memory, if I get it right.
I mean, it is a problem somehow that the video here is not running,
yeah.
But I can try to explain it again. On this picture, we stuck from outside, or this catheter or this probe is going through the left coronary ostium, and you can see that it is not obstructed, or it's nice in the neosinus of the valve. The right coronary artery is really just behind here. You could see it if this video would run. I'm also stucking a probe from the right coronary, and it's just behind this struts from the neocommissures of the valves. Yeah? So like this, I think that this could have made an inflow occlusion, or because the ostium is directly behind.
On the right side, not...
Yeah, on the right side. The left side you see is completely free.
Did the aortic root angio show RC occlusion?
no. I mean, this is what we saw here. Oh, they were open. Also, when running in the only thing what we saw, if you look to the pictures, retrospective in the cath lab, you maybe, I have to go back here step by step, unfortunately. I mean, if this would run now. I mean, here you maybe can see that we have a little bit slitwise offspring of the right, which could be a hint. But it's also more, if you now know it retrospectively, or you can see that it's here a little bit more slitwise and maybe compressed. I think maybe this also could explain this dynamic of the case, yeah? Because maybe when always the patient was having a good blood pressure, of course the aortic root was a little bit more under pressure, pressurized, and like this dilated, and the blood flow could go behind the struts into the ostium. But whenever maybe the blood pressure was not so well, yeah, the root was collapsing a little bit, and like this struts from the commissures could go closer to the ostium and cause there maybe a flow distribution.
Hello, one question here.
Yeah.
Do you think it was a problem because you didn't manage to engage the right coronary artery after the implantation of the valve? It was a paraosteal injection in the root with the pigtail. I think the ostium, clearly we can see here it is affected, and the fact that you cannot engage the right coronary artery, it could have been a question in that moment.
Exactly. Retrospective, we really should have been more concerned when it was not possible to intubate it. Of course, we also discussed this finding with our cardiologist who didn't find anything suspicious on this right coronary, but this is what I wanted to show. If you go retrospectively back, I think really on the ostium you see that it is a little bit slit-wise compressed, and I guess that this was a pathomechanism.
Okay, thank you very much for the case presentation and the discussion. I think for the sake of time, we have to move on. It's my pleasure to introduce Daniel Weilemann, presenting the case on behalf of Marco Cederquist from Kantonsspital St. Gallen, who's unfortunately not able to present himself.
So back again. This is a case from Johannes Rico. He's in holidays, and the fellow, Marco, he could not do it to come here. So it's me to present the case. So inglorious left main treatment. So the patient is 73 years old, chest pain for 7 days before admission to the hospital. He was pain-free, but he had signs of heart failure and elevated cardiac markers. He has some comorbidities, and he was a smoker. So this was the electrocardiogram when he entered the hospital. The echo showed an anterior akinesia, myocardial thinning, so signs of an older infarction. LV function was slightly decreased. The MR scan showed an anterior scar, but viable myocardium in the right and in the circumflex. So the hypothesis was this is a superacute anterior myocardial infarction. Patient was in atrial fibrillation, heart failure. So they wanted just to treat the patient with medication to get out of the heart failure and then do an invasive evaluation of the patient. So this is the angiogram. As expected, the left anterior descending artery is closed. There is some disease in the circumflex, marginal branch, heavy calcification. And you can see the left main is also implicated. You have a distal left main, proximal LAD, and heavy calcification at the ostium of the circumflex. Then the right coronary artery, diffusely diseased, severe disease in the peripheral artery. So Joe decided to do a quick and dirty PCI of the right, then treat the patient, and then perhaps in a staged manner do a PCI of the left main circumflex, perhaps with hemodynamic support. So he did it, ballooned it. This was the final result. So we see there are some collaterals to the distal LAD. So we are done now. The patient was discharged, went to the geriatric department in a good condition. But 7 days later he came back, acute heart failure, tachycardic with atrial fibrillation, had dynamic ST changes and chest pain, and this is, despite optimal medical therapy. Can we make this run? Okay. So he decided to do a left main intervention mostly for the circumflex, because as we have seen, the ostial circumflex had a tight stenosis, and they presumed that this is causing ischemia, and during atrial fibrillation, he was not tolerating this. So the plan was PCI left main circumflex, no impeller, because they had limited peripheral access, and the patient was not in heart failure when he was on the table. So this is the setup. So he did cutting and scoring, 4.0, 20 atmospheres. Then he implanted the synergy, 4.0, 32, from the left main to the circumflex, post-dilatation 4.5, pot at high pressure. So they did it. Well, they thought, well, there is a slight under expansion of the stent, do a post-dilatation, and they did shockwave 3.5 balloon, 6 runs. Then they wired the LAD. They did also shockwave in the proximal LAD. I think that's what was very enthusiastic. When you look back to the images before the PCI. So well done, good expansion, job is done. Well, that's what happened. Horrible images. So a perforation in the LAD. So it's not easy to understand where the perforation is. And as Eric said, it is always very important. You have to understand where it is, because if you do not understand, you cannot seal it. So perforation, you still have a wire in. What to do? So stop the bleeding. First action you do is you put in a balloon. You want to stop the bleeding. I think that's the most important step at the beginning, but then you are not done. So femoral access for ping pong technique, as we have heard before. So that is standard for us. Gives you more option. If you just go with one catheter, you have not all the options. So ping pong, and then a B graft, and ongoing pericardial bleeding despite proper dilatation. Can we make this series run? Do they run? Well. So the bleeding was not yet stopped. There was still bleeding. So at that point, the question was, what can we do? Because we have a bleeding, perhaps also at the level of the left main or the ostium of the LAD. And then what was decided is to put in a B graft into the circumflex and exclude the LAD, because we thought LAD is scar in the MRI. So exclude just the LAD, and then you get rid of it. So that's what was done. And the bleeding was was stopped. Well, the problem is that the patient had still some viability in the territory of the LAD, so he had a ST elevation, he did some cardiac markers elevation, he went in anuric renal failure, pneumonia, and he deceased 5 days later. So what was the key points, learning points Joe took out of this procedure? Well, low pressure IVL is not harmless. I said, I don't think that it was IVL. It's not the technology who caused this perforation. It's the size of this balloon in an LED that was smaller. So that was my key point in this case. Keep it simple, yes. I asked him, why did you balloon the ostium? Because there was no need to do that. You were good with the stent in the left main. Perhaps just balloon it to get some flow, because it's not a viable LED. It's not a big territory. And finding the right balance between over and under treatment is not always easy to find. I think this is an important questions we always have to do. Better is the enemy of good. That was always my credo in doing PCIs. Don't touch a vessel you don't want to treat. So they didn't want to treat the LAD, but they touched it. So don't do that. Thank you very much.
Thank you, Daniel. I think special times need special measures, but and also it was kind of bold excluding LAD, because as you all know, there might be collaterals that still bring blood to the bleeding site from either the PDA or over a epicardial collateral, and then it keeps bleeding, but you have no access anymore. So I would probably rather try to coil it or just close it, but keep access to the bleeding site. Any questions from the audience?
First question: did you lithotripsy instant?
I didn't get
shockwave. You did shockwave instant?
Yes, instant.
It's off label.
Yes, it's off label use, but my good friend he showed me that you can do it. So you do not destroy the polymer.
Very dangerous.
No.
Why that?
Don't say that. You know,
why that?
Be careful. No dogmatic statement at this meeting. You can't say that.
It's okay.
What proof do you have to say that it's dangerous? No,
there is a case reports who demonstrated that's very dangerous to do that.
You know,
we don't understand the pathology, but it's dangerous.
Next week in Neurointervention, you will see a quick publication. So what we did is expose drug-eluting stent with fluoropolymer, with a durable polymer, the science, to IVL in a silicon model, all 80 shocks to the stent. We expose one stent to a very calcified lesion, going back and forth in an undilated lesion to show interactions with the polymer and the fresh stent. And we then investigated it in electron microscopy. So even with all 80 shocks to a stent, you have minuscule polymer damage, and usually you have enough polymer left to have no instant restenosis, and it does not do any damage to the metal.
It's okay.
However, there's also publication on underexpanded stent treated with IVL to post-expand them, and these results are not as good as you would hope. So, and if you have 2 layers of stent, it's even worse. So it looks like the cage of the metal absorbs some of the sonic energy, and you are less effective. So you should always predilate your lesion until they're perfect and then implant stents. But I think it's not dangerous to use IVL as a bailout in a massively underexpanded stent.
The second question: the patient presented with acute myocardial infarction of the anterior wall. You treated RCA. I can understand that, but I couldn't understand why you discharged the patient in the geriatry department without treating the subacute myocardial infarction?
Well, it's a scar on the MRI. We did an MRI, so it's a scar. It was not acute, it was subacute. It was 7 days old, so there was nothing to do on the LAD. We can discuss if we should have done the left main and the ostium of the circ, but I think it was not worth to invest on the LAD because it was mostly scar.
It's okay.
So let me introduce Gregor Leibundgut, who will present the fourth case, also a coronary case. We still have time. I think the next session is starting at 3:30. So I think discussions of these cases are very important. We should not stop them. So it's up to you. Next coronary case.
Yes, thank you very much. I hope I can present the happy end case of any complication, because that's the only patient that is still alive of all the four. So, but you can also see if you want to win at the Swiss complication meeting, you probably have to have a dead patient, unless you don't have any chance to win.
Certainly not true, because I'm many years now in this winter meeting, and I think it's a combination of the case, of the presentation, and of the key points you take out, the take-home messages. No, the patient doesn't have all this today.
Okay. So, presenting a coronary case, and it's called filaments in the septum. And I don't have any indication for the PCI, because otherwise I could not show you the complication. So, patient had the 3-vessel disease. Was actually from the anatomy a surgical case, but as often he completely refused it. He said, I'm not going to do anything unless you can do it percutaneously. So we put in the guide on the left system, and you can see already there is retrograde flow into the occluded right coronary artery. There were severe calcifications of the mid-LAD. Antegrade wire escalation strategy on the occluded RCA already failed previously. Retrograde septal access looks difficult. I mean, there's some nice straight proximal septals, but you cannot really appreciate a good takeoff into that PDA. And I'm not even sure if it also some collaterals go in the PL branch. This was the antegrade injection. You can see a long occlusion of the right coronary artery, an epicardial contralateral collateral from, I think, it's even ipsilateral. You take off the first branch from the right here, then goes all the way to the left, but it doesn't connect, and it comes back here, and you have antegrade flow here. So there somewhere the crux cordis, and you can see some islands here along something which is probably the original course of the right, and I would say it has an ambiguous proximal cap. You might think that there is a channel, but it looks a little bit that it goes out and could also be a bridging collateral. So after all, we don't really know if this is remaining vessel. The bilateral injection shows what I have said previously, the diseased left system, some nice collaterals, and here you can see that they actually connect to that PDA, which comes in a little bit later injection right here antegradally over this epicardial ipsilateral collateral. And what you see here is a little bit more illustrated on the right side, is actually that you don't really know which one is the crux and which one is the distal RCA. So I figured that the yellow dotted line would be the native right coronary artery with the PDA here, and the PL branch here, and the distal right. And then there is this epicardial ipsilateral long collateral entering into the PDA close to the crux, and gives you some difficulties maybe on the retrograde approach. So as always, I try antegrade approach with a Fiedler XTA. Sometimes there is a microchannel, and you're lucky you're within the distal target within a couple minutes. However, here you can see the Fiedler XTA exited the vessel course very early, And what you should always do in these situations is confirm from an orthogonal view, if possible. So I went to RAO, and you can appreciate here as well that there is some mid part of the right coronary artery still open, identifiable through this RV branch. So this part is open, but the wire is way off, and as we say, it is not dancing with the vessel, so it must be in another plane. And I gave up the antegrade approach. You can also see here redirection, which is called antegrade wire escalation. So I'll switch to a Gaia second, which is a very steerable and more penetrable wire than the fielder. And I also used a microcatheter and try to redirect it into the true lumen. Distal vessel exit again. You can see that either one, the distal right coronary artery, which is this between, and the upper epicardial collateral are way off. We might be through here, but it's difficult to see. And then I said before, I destroy the crux, which is no good if you enter subintimally towards a bifurcation. You can usually lose one of the branches, or both if you cannot enter at all. So I stopped there. You can see here that the Gaia is actually already over the crux, but in a different level. So I stopped here, left the wire in place, because you still need it for the reverse card maneuver or something else you want to do to exit the antegrade guide with the retrograde wire. And entered through the antegrade, through the retrograde guide into the LAD. What you do is you put a safety wire, usually a workhorse wire, into the LAD just to have access. And if anything happens to the donor vessel, you can still fix it. And then we did some septal surfing through these first septal branches. You can see here again with a microcatheter and cyan black polymer jacketed non-taper tip wire. We did some septal surfing. What is important here, if it doesn't work in a minute, it doesn't work in 10 minutes. So try a few septals, and if you're unsuccessful, go to another one. Unless you use them all up, then you can do a tip injection or always go back. That's what I did here. Was unsuccessful in the first one, so I went to the next more distal. The ones at the apex are not very promisable, and the first one usually also not, because it's going to the thickest part of the septum and the longest distance. So something in the mid LAD is the most promisable septal passages. You can see here I injected with a 3 cc syringe contrast media, and what you can appreciate is that there is a very nice interventional collateral going to the PDA. And then I entered again with the cyan black. You go forward, you turn, you go back, and once it goes the correct way, you just keep following the wire, and the wire usually shows you the way to go. What you do then is follow with the microcatheter. You keep your wire, you turn your microcatheter and advance it, and with every heartbeat it goes. And the toughest part is down in the septal when you have to turn into the PDA. And once it's turned, it's easy. Now you overcome all the resistance. You can appreciate how fast the microcatheter actually moves, because now you have enough push to get it forward. So now we're at distal at the crux. And here was the difficulty to delineate which one is the true vessel and which one is not. So I think you can appreciate this is the epicardial ipsilateral collateral coming in here, and the wire, the antegrade Gaia, now actually seems to be true. However, I could not enter here around this bend, either due to the Gaia, but what I thought at that point is that I'm subintimal and I don't want to try to re-enter and destroy the crux. But it was easier now to identify the true way, and I took workhorse wire again to get into the distal RCA and then move along with the microcatheter, and you can see it actually goes all the way up, which is usually the case because the distal cap is more soft. It was exposed to capillary pressure 50 millimeters of mercury whereas the proximal cap usually is hard because it's exposed to systemic pressure. So the wire goes in, goes all the way up, and typically exits the side branch, that RV branch, indicating that I'm true. And then you have enough support to bring up the microcatheter all the way up to that side branch, and you basically have a nice overlap of a long segment of antegrade and retrograde wire, perfect setup for reverse card. However, I could not enter this second or first distal cap, probably harder due to exposure to the higher pressure, and I had to eventually use a 12-gram penetration wire. This is where the complication starts. I hit the wall, the wire kinked, and then also got stuck in the calcium. And what you should not do then is what I did, and that's why it's a complication. I started twisting the wire and tried to get it free, but because it was broken in the core, it actually started twisting and forming a knot. And that's when you cannot retrieve it again into your microcatheter. You can do that to a fielder, polymer taper tip wires, because they kind of get back into the microcatheter, but these hard penetration wires, they are just stay bent and kinked, and I could not retrieve it. So now you have a nice cauliflower of wire, and you know that you were gone through very fine and delicate septals, and you somehow have to get back with that ugly piece of metal. Or what you actually could do, you can take an antegrade snare and try to snare out the wire antegradely. However, I was not able to reach that position. So I maneuvered a little bit, and then fortunately, I thought at that point, that tip broke off and lost it in the calcium, and I thought I'd just open it and stand it to the wall, and I'm fine, I can retrieve the MC. And I could actually take the MC back. I could also take the wire out of the MC because it was broken bluntly at the tip, and introduce a next wire, and you can see here that it went into this epicardial collateral. So I had to go back, delineate the anatomy, and then eventually find the way up to the antegrade guide. And I went all the way up with the retrograde wire into the antegrade guide, and you can see here that I retrieved the antegrade microcatheter and did the tip in. So the retrograde wire tipped into the antegrade microcatheter, a way to save externalization. And then I advanced the antegrade microcatheter through the retrograde wire, retrieved the retrograde wire, retrieved the caravel retrogradely, and finished the procedure antegradely. And this is the RCA, not the nicest vessel, but it's open, and the CTO body is stented with a 4.0 for good patency rate. What you can see is that there is still that tip of the wire left in the side branch of the PDA, and I thought, well, that's great, it's just a tip, leave it there. It's still outside of the big vessel, and I'm done. But then retrieving the workhorse wire, which was the safety wire in the LED, I felt some resistance, and then I saw that there is actually coil from the broken tip. So this is the tip, and it unraveled. No, sorry, this is the tip, and it unraveled the whole coil of the penetration wire within that septal, and unfortunately also around my workhorse wire here. So there is coils wrapped around, and you can't see. They're really fine, but they're very tough and very resistant, and thrombogenic as well. So here is a ClearSend Live image. You can appreciate that there is a lot of calcium on the inner curve of the bend. There is this coil, unraveled coil coming up, and it goes around here and makes some weird movements. And just by advancing the balloon here that I needed for the ClearSend Live, I pushed the whole rubbish down this vessel, and it got more and more difficult to move any gear. So here you can see I needed to advance a guide extension to get more push, and you can see all these coils around here. So I thought, okay, I'm going to pre-dilate all the coils, then put a stent to put them on the wall, and leave everything else here in the septum. It doesn't bother anybody, and hopefully I can retrieve that wire, and which then eventually happened. So you can see There's this dilated septal from the caravel, and there's some coils here, a little bit of extravasation, probably due to capillary damage by kinked wires, and here the tip of the CP12. Some coils wrapped around but stented to the wall, and I think there is a decent flow into the LAD. 3 months follow-up. The right coronary is still open. Everything looks good that we worked for. Even the PL branch got a little bit bigger, and hopefully this other side branch does also positively remodel within the next months. And interestingly here, first of all, the good thing, although there is a lot of coils in here and there's still flow in that septal, so probably endothelialized and there's still enough flow and will probably stay forever. Hope it doesn't interfere with the conduction system, but so far so good. But what you can see here is that the LAD was closed off. If you go back, you can actually appreciate that there was actually a dissection right here that I wasn't too worried about, and I also didn't actually realize because I was more focused with this part. So I think this dissection then closed, and also you can see a very bad flow in that diagonal, which was actually initially the case. So the dissection closed here, the diagonal, interestingly, almost a little bit better. Then we stented another part of the LAD, and also I decided to open up the side branch and put a small 8 stent there. So this is the final angiographic result after 3 months. Thank you very much.
Thank you, Gregor. Some ideas, comments on this case? Anybody experienced the same case?
People are a little bit speechless, of course. It's the technicity of the act is particular, but what you did, how long did it take you, the first intervention, the first time, yeah?
Well, I didn't have to do a lot with the complication, because at the time that the wire kinked, then I thought, okay, it either breaks off and I just leave it there in the RCA and I continue. Then I realized I cannot retract. And then after 2-3 minutes, it broke off. And I thought, okay, it's what I expected. And I finished and I could retrieve the wire. The cargo was actually still intact and I could advance and finish the CTO. But then I realized that there must be some unraveled coils all the way. And it probably broke much more up retrogradely in the microcatheter.
There's also the point that you were thinking about, Malcolm.
Yeah, no, I was just wondering where the break was approximately, but I think you've answered that and probably just do fine. I think the point you made about the dissection in the distal LAD is a good one, because you said you were very focused on the other, and it's easy to get distracted. And I mean, it's not a criticism at all, but it's, it happens to us all. You get focused on something and you don't realize that something else is going on, particularly in a very long case. But I hadn't seen this before.
Just a question there. Oops.
I just want to comment that I presented last time the torn wire that was also elongated and rested in the patient, and every time when the contrast part of the wire remains too short in the patient, you should think about that actually the wire can be much more longer than you see the contrast part, because you see that the contrast part that rested in the patient was not 3 centimeters here. And so was also the case that we had only small contrast part in the patient, and initially think this is too short stented, but it was actually long a long part of the wire which goes down to the descendant aorta. So it was the coil which was elongated, and we extracted the wire, but the contrast part which rested in the patient was only 2 millimeters. So every time the contrast part disappears and you have something in the patient, it could be much more longer that you see.
Yeah, and if you're not sure, then what always helps, get the very same wire from the shelf, put it on the bench, put your broken and extracted wire in parallel, and then you see how much material is actually missing. Even though it's only short piece missing, you remember it's a tapered core with the coil around, so if that coil gets stretched, 1 centimeter piece can get a meter, and this is what you're referring, and you don't see them anymore because they're so thin.
So one simple technique to really see how far your wire is going up is simply CT scan. CT scan, I asked my colleagues radiologists, the CT scan is basically shows you fantastically well if your coil is potentially going up into the ascending aorta or whatever. So it's a simple exam to really know what part of the wire is still within the patient.
Gregor, just one question. Do you think that initially, sometimes when you puncture in some calcium and you twist, then it gets stuck and you cannot get back? You remember the live case we did, Suicideo Connect, you called it then Lucky Me technique. So I ballooned from the antegrade position because I could not take back the conquest back into the micro at the tip. So I always deformed the tip, and if you insist then you break the wire. So we were struggling half an hour live. Everybody was saying, well, give up, take it back. And it took us, I think, 40 minutes to get the epicardial collateral, so I didn't want to give it up. And then I just did reverse card with a big balloon. I was just in front, it was Lucky Me technique. I just saw that the balloon was straightening the wire, and then it came back easily into the retrograde micro. So that's why you called it Lucky Me technique. Do you think this was the problem at the tip when you came back?
Yeah, it was the very same case, but in your case it was kinked, and then because it's a penetration wire, it usually so stiff that you cannot retrieve it because the microcatheter then starts bending and knuckles, and you just can't get it in. In my case, it was already far beyond that, so it was a kink, and then because the tip was stuck and I twisted around the kink, it formed a knot, and then I thought I cannot straighten it up again, and I could not get antegrade access with a snare to get it out.
Would it have been an option just when you feel it, you have this resistance, okay, you give up the position, you take the whole system back before you try to get back the wire?
I still think it's better to have these filaments in the septum than having taken this knot of hard metal just as it is through the septum, because that would have ruptured the whole septal, and then septal hematoma, dry tamponade, and worse thing.
I would
happens.
say before that happened.
Retrieve it. Yes, but it happened, and then I was stuck. Okay. That's the definition of complication cases.
Yes, exactly.
Okay.
Okay. So thank you very much for all the presenters to present these cases and to expose themselves to an audience. But I think these cases are here to discuss, to learn from other peers. And I myself, I learned a lot during complication sessions how to deal with complications, because you say, I never had this, go back to the cath lab and you will have it if you do enough. So thank you very much. Thank you to the audience. I think you have a break now.
Yeah, so I just would like to announce that we have Bernard de Bruin with us in the auditorium. Bernard, we asked him a difficult task to talk. In the next half an hour, he talked about the long and winding road of how he got, together with Nico, the coronary physiology on the roadmap of interventional cardiology. I really look forward to hearing from you, Bernard, and hope you all be back at 3:30.
Hello and welcome back to ECC 2022. We now change tack a little bit and moving away from cases, we will hear instead some inspirational speeches or talks by a couple of our famous faculty. So first up, we've got Dr. Bernard de Bruyne, who really needs hardly any introduction. And he's going to talk to us about his journey in physiology and the challenges that he has faced in his career. Thank you.
Thank you, Mr. Chairman. Thank you, Eric, also for the introduction. Do I have to take a microphone? Better? Yes. Okay. No, it's...
I apologize to give you some housekeeping rules. You're basically streamed over the world.
Okay.
So you will have to stand on top there because you're on... You're on Zoom.
That will be the most difficult part of my
so.
task, to stay here. Okay, good. Please tell me if I move too far. So the title was 30 Years of Applied Coronary Physiology. How did we overcome the challenges? I changed it a little bit and I put myself the question, did we overcome the challenges? And actually, Eric, you asked me to speak of the history of coronary physiology. I will keep it very, very short because history, let's face it, is a little bit boring very often. And I would like to come back to the fundamental question. Why the hell do we have to spend some time to investigate the physiology of the coronary circulation in the catheterization laboratory when we have a nice coronary angiogram on the screen, which is very often considered as the quintessence of the workup of patients with suspected coronary artery disease. Now, the basic reason is always the same. When we look at the diagnostic algorithm of patients with suspected stable coronary artery disease, and you recognize what has been proposed by the task force of the United States or the American Heart Association ACC guidelines, you see that whatever way we take, whether we choose to go first to non-invasive testing, which I call the slow pathway, like in electrophysiology, or whether we go almost straight to the cath lab with potentially a stop to the CT, which I call the fast pathway, whatever we do, we will still be confronted with many, many, many patients in whom we don't know what to do when we are in the cath lab. I'm sure we are not the only one in Aalst to have this problem. I suppose also in your practice, you encounter these patients with chest pain, mild stenosis, no stenosis, tight stenosis in one vessel but no stenosis in the other one, or even worse, who underwent the non-invasive pathway and have completely discordant and non-actionable non-invasive testing where you are completely in the mist. So that's the main reason why we have to get this information in the cath lab. Typical example, a gentleman of 84 years old. He was obese. He was obese and he had relatively atypical chest pain, a normal ECG, and a normal echo. What to do with these kind of patients? An obese 84-year-old gentleman with a couple of risk factors with, let's say, moderately typical chest pain. Of course, he ends up in the cath lab with this kind of coronary angiogram. You see that the quality is all but good, but you have a very strong suspicion at the level of the left main. So in these patients, if you don't do anything else, either you say, well, we are going to stent this left main or we are going to send this patient to surgery, but these are serious decisions, or you try to define whether this lesion is a problem for the patient, whether this fractional flow reserve is rather 0.94 or rather in the region of 0.66. And this is actionable. This, when you have acquired this information, you can take decent decision in these kind of patients about revascularization. That's the bottom line, I would say, of almost all the cases in whom we have to obtain physiological information. So, Eric, you all asked me a little bit of history. I will keep it brief. I would like to remember that the history of coronary physiology, applied coronary physiology, started long before fractional flow reserve, and actually was introduced by Lanes Gold, who described in animals, I have to say, the concept of coronary flow reserve. And you all know that coronary flow reserve, CFR, is defined as the ratio of hyperemic flow to resting flow. And I will quit my arrow here for a moment. So that's hyperemic flow, that is resting flow. So the CFR is the ratio of this flow divided by this one. This is in animals. And his main, let's say, finding was that this coronary flow reserve, the ratio of this divided by this, started to decline as soon as the lesion reached more than 50% diameter stenosis. That is the reason why we still today use this criteria of 50% diameter stenosis, even worse, by eyeballing the angiogram. But we also forget that there was a large scatter around this relationship, especially during maximal hyperemia, and that there was a wide range of stenosis where actually the flow reserve could still be normal, but could also still be pathological. So this is the reason why we are still using today the 50% diameter stenosis, and more recently with Gabor Todt, when he was working with us, we showed that indeed there is some relationship between what we see on the angiogram, the diameter stenosis, and what we measure in terms of physiology, namely the fractional flow reserve. There is some relationship, but for individual clinical decision making, we'd better have something else than simply the diameter stenosis. Doppler was introduced to measure coronary flow reserve. I will go over this slide. I will also mention that actually far before fractional flow reserve was even introduced, Andreas Grünzig, in his very first paper in the New England, had 4 out of the 5 illustrations which were actually alluding to pressure measurements in the coronary artery. At that time, the pressure, the distal coronary pressure, was measured through bulky catheters. There was no hyperemia, and he always described pressure gradient instead of pressure ratio. And this is one of the main reasons why there was still an unmet need, a persistent unmet need for many patients to make the correct diagnosis. This is a typical example. It's a retired nurse, 67-year-old. She had typical angina, and actually she had normal or nice coronary arteries except a tapering left main. This is exactly the kind of cases in whom we need to have more information. This is another example, and this is the illustration of our very first paper about pressure measurements in the coronary artery. You see this left main that nowadays we would be careful in considering as significant, but at that time, at that moment, I can tell you this kind of left main stenosis was sent right away to the surgeons. And by passing a pressure wire, we were very surprised. It was for us really a kind of eye-opener that at rest there was 0 millimeters of mercury pressure gradient, 0. This is the pressure recorded in the distal part of the coronary artery. You see it's very damped, but please remember that the very first pressure wires were fluid-filled pressure wires connected to the conventional pressure transducers. And to cite you a small anecdote, I got only 100 wires of these wires from a company named ACS, the predecessor from Abbott. And since we had only 100, I realized that I had to re-sterilize the wire to keep on doing research. So there have been patients in whom pressure was measured in the coronary arteries with a wire which was already used 10 times, for example. This is unbelievable nowadays. Now, when we were doing these kind of measurements in humans, my colleague and friend Nico Pence was working in animals and realized that actually there was a straight relationship between pressure and flow, provided we were working under maximal hyperemia. And this is the reason why we finally developed a whole set of equations. It was way too complicated, fully agree. It was really programmed to fail because it was too complex. And finally, we were able to simplify, almost comically simplify to PD divided by PA. But please remember that PD divided by PA, even if it is measured thanks to pressure measurements, it is actually a flow index. This PD divided by PA actually tells you to what extent a given stenosis is impeding the maximal hyperemic flow. Now, I would like to stop here for the history, and I would like to go through one small detail about fractional flow reserve precisely. I would like to ask you the question, do you know what exactly is fractional flow reserve when we do that in the cath lab? You recognize these kind of tracings. We have the pressure gradients at rest, a very small one. We induce hyperemia, and then the flow increases, and a flow which increases across the stenosis induces a gradient which increases. It's just like in aortic stenosis, by the way. And this is in steady state when hyperemia is maximal and steady state. This is where we calculate fractional flow reserve. In this case, it's 0.61. What does it mean exactly? It means that in this particular left main, the maximal hyperemic flow only reached 61% of what it should reach in case, in the hypothetical case, the left main were to be normal. That is the most pragmatic definition of fractional flow reserve. And I think it is worth to repeat this. It's very simple. Everybody should know that, but I think that very few people really understand what it is. And this is true. So this relation between pressures and flow holds true simply because this relationship, both in animals and in humans, is linear during maximal hyperemia. Now, a couple of years later, we were developing fractional flow reserve. Justin Davis had this idea, which was basically a very brilliant idea, to simplify things further and to say, well, why to induce hyperemia? In the mid of diastole, during diastole, we are hyperemic. So if we just focus on diastole, we are going to use a kind of pressure ratio, PD divided by PA, during a phase where we are theoretically hyperemic. So there is no need for pharmacological hyperemia because resistance, this was the terms or the sentence that he used in his paper Princeps, resistance is naturally minimized during the diastolic wave-free period. Actually, since then, we have shown himself has shown also that actually we are not at all hyperemic in diastole. And this is also the reason why the cut-off value of the non-hyperemic pressure ratios is strikingly different from the cut-off value of fractional flow reserve. So fractional flow reserve has a real physiologic meaning. IFR is very simple, is a pressure ratio, but has no meanings in terms of flow. Important to realize. And this is probably also the reason why, and this is published by the same group of Imperial in the Orbita, and they published that recently in the European Heart Journal, last week, I think. FFR, but not IFR, and not the dobutamine stress echo, by the way, has a significant relationship with peak oxygen consumptions in these patients in Orbita, one vessel disease with a significant lesion. So fractional flow reserve has a significant physiologic meaning, IFR, none, or at least to a lesser extent. Now to keep it even more simple, why to go to the cath lab or why to introduce a pressure wire? Well, several techniques, several companies, several groups have developed, let's say, FFR derived from the angiogram using either computational flow dynamics or even other, let's say, physical principle like CATWorks, but there is also Pi Medical, Medis, Siemens, you name them. There are many, many others. And this is fractional flow reserve as derived from the angiogram. Now, if you ask it to me, it's nice for those who do not like to work with pressure wires, who are actually a little bit scared of using pressure wires, for those who are scared to use pressure wires plus hyperemic agents, but this will not replace the quality, the accuracy, the reproducibility of invasively assessed fractional flow reserve. On the left part of the screen, you see something else. It is FFR derived from the CT, the FFR CT from heart flow. And also there are many other competitors coming. This is different. I think that the precision is probably in the same ballpark as angio-derived fractional flow reserve, but in the diagnostic pathway of the patient, in the patient's journey, the CT comes, of course, way before the angiogram. The FFR CT is something that we have already at the outpatient clinic that we can discuss with the patients and on which we can decide whether or not the patient has to go to the cath lab. So it's a totally different story. And if, again, you ask my advice, a little bit blunt, FFR CT, yes, definitely yes, that's a very useful tool. I do not say that it's 100% accurate, but it's very useful, very useful. Angio-derived FFR, yes, but only indeed you are really scared to use wires. Now, what you probably never heard are two things, and I will end with two, let's say, new concepts that we developed in our center. The first is what we called PPG, and PPG stands for pull-back pressure gradients, and is based on the fact that diffuse disease is a very, very, very common finding. We all know that coronary artery disease comes in two flavors, a focal one and a diffuse one. And of course, in most patients, it's a mix of both. Okay? But we are not good at all in quantifying what is diffuse, what is focal. And this is the reason why, together with my two younger colleagues, Carlos Collet and Jeroen Song, we introduced this concept of pull-back pressure gradient to quantify the diffuseness versus the focality of the lesion. These are two examples. It's very simple. This is a right coronary artery with a relatively focal lesion angiographically, even though I would say, well, it's relatively long and maybe a little bit diffuse. Now, when you induce hyperemia and that you pull back the pressure sensor, you have a very sharp step up of the pressure gradient, a sharp, let's say, localized disappearance of the pressure gradient. This is a focal stenosis, and look at the PPG. The PPG value is high. High, I mean close to 1. The higher the PPG, the more focal, the lower the PPG, the more diffuse. And this is a completely different example of a stenosis in the mid-LAD with, oh yeah, well, this looks like significant and focal. Well, it is significant. You have the fractional flow reserve here in the right upper corner, but it is extremely diffuse. So stenting just this part of the LAD will probably not help the patients. And you see that the PPG is very low. You will say, well, when we have these kind of tracings, do we need sophisticated calculation and PPG to see the difference? No, we can see that very easily. But in many, many patients, it is much more sophisticated than that, and it's much more difficult to determine by eyeballing, and we know how bad we are in eyeballing to determine whether we are dealing with a focal or diffuse disease. Now, the PPG index and the calculation, you can look it up in the GACC paper of 2 years ago. It is based on two terms, but I won't go into the details. But it tells you what is important again and again, at the risk of repeating myself, it tells you to what extent the resistance along the vessel is distributed diffusely or whether it is located at one given spot. And the higher the PPG, the more focal, and the lower the PPG, the more diffuse. Now, you're going to say, yeah, so what? Does it really help? Well, we have already data on over 500 patients, but these are the first 120 patients in the P3 population, which was published in GACC Intervention 2 weeks ago, where we showed that indeed there is a very clear correlation between the PPG, which is an index which can be obtained before even starting the PCI, and the gain in terms of fractional flow reserve that you will obtain after the PCI. And it really impacts clinical outcome, because when you look at this population, you split that into the focal lesion, high PPG, the diffuse coronary artery disease patients, the left one in red, low PPG. Well, these corresponds to two different proportions of residual angina. In focal lesions, when we put a stent, patients are usually free of angina. In diffuse disease, you put a stent, half of the patients will still complain of angina, some form of angina. And this is Seattle Angina questionnaires at 6 months. So the benefit achieved by revascularization was twice as high in patients with high PPG than in patients with low PPG. And then there is one thing I would like to drop, just food for thought, and very interesting. In all these 123 patients, we also had OCT. And we correlated simply the plaque features in these patients and look at these two columns. I will try to keep it simple. The blue bars are the focal lesions. The red bars are the diffuse lesions. And look more specifically in the lipid-rich plaque with 360-degree distribution of lipids, and the patients or the lesions with thick fat. This is exceptional in diffuse lesions, very frequent in focal stenosis. This was for us a complete surprise, which means that when we have focal stenosis, not only we help these patients, we preserve quite a lot, we improve their angina, but we are also probably targeting the vulnerable plaques, the plaques with features which evokes unstable plaques. Of course, this still has to be worked on, but this is extremely interesting. The only thing today you have to remember, when you do PPG, when it is focal, it will be close to 1. When it is close to 0, you have a diffuse disease, and you might really wonder, when you have patients like this with a PPG in this range, whether it is worth to even start with PCI, whether we are going to improve these patients. So let's go on, and as a summary for this PPG story, let's remember that FFR and PPG go really hand in hand to define what kind of coronary artery disease patients you have on the table. A second thing and last thing I would like to mention, and that you probably really never heard about this, is the MRR, or microvascular resistance reserve, derived from continuous thermodilution. No panic, I will try to simplify. And this was also published in GCC by the end of last year. So, we all know that the microvasculature is interesting a lot of people, especially those who want to publish, and you know, and you see that there is a kind of exponential increase in the number of publications, and nevertheless, I have the strong feeling that our knowledge remains minuscule in terms of microvascular disease. We don't understand what's going on, we don't even understand this organ. This organ is extremely smart, and is best characterized by the microvascular resistance. The microvascular resistance, that is the index by excellence that we would like to measure. Resistance is measured by the ratio of pressure divided by flow. Now, pressure, okay, we are good in that, but flow, that's very difficult. And it's really difficult. And not only it's difficult, but in addition, flow and mass and resistance depends on the mass of the myocardium. It makes it even more difficult. And then there is a third thing that I would like to explain. I hope you will understand, and I will do my best, is that this resistance here, RMU, this resistance at rest, is actually fluctuating continuously during our daily activities and according to the presence of epicardial stenosis. This is the organ, the microvasculature, which is responsible for the autoregulation, which also means that as soon as there is an epicardial resistance, even the slightest irregularities in the epicardial vessel, the microvascular resistance will adapt, will decrease a little bit. Why? To maintain flow constant. If the flow is not constant at rest, we are in trouble. We have very little reserve. If you have your resting flow, here, you sitting there, your resting flow decreases by more than 5%, you will have chest pain. And you will have a hypokinesia of the, let's say, a dysfunction of the contractility of the left ventricle. So the microvasculature is essential in maintaining this flow constant at rest. And of course, during exercise, it has to vasodilate a lot. But it also, it means, and this is the point I would like to make, is that when there is abnormal resistance in the epicardial vessel, the resistance in the microvasculature is no longer the normal one that was present when there was nothing wrong. And there are several indices which have been proposed, and we introduced ourselves a long time ago, in 2001, I see on my slide, the concept of bolus thermodilution. Bolus thermodilution is obtained, I don't know if I have a slide, no, by injecting a bolus of saline at room temperature, and then you create thermodilution curves, 3 at rest, 3 during hyperemia. You can calculate mean transit times, and from these mean transit times, which are surrogates of flow, you can calculate what Bill Fearon has called the IMR, the Index of Microvascular Resistance. That's bolus injection. But we have to admit, even though we have, let's say, conceived it ourselves, that this is very shaky and not very reproducible, and this is the reason why we introduced more recently the concept of continuous thermodilution. To perform continuous thermodilution, you also need a temperature wire, well, pressure/temperature wire from Abbott, but you need a special catheter with which you are going to infuse continuously 10 to 20 milliliter per minute of saline at room temperature. So it's not rocket science, it's relatively simple. And this is how it goes. You put your wire distal, here in the LED, and you advance the ray flow catheter, here, that's the marker of the ray flow catheter, in the very proximal part of the vessel that you want to measure. The holes, the 4 small holes, are located just distal to the marker, and that's it. And you start the infusion. You start the infusion there. You tell the computer, well, this is the 0 temperature, 0, go. That's actually the body, the temperature of the patient's body. And then you start infusing at, for example, 20 milliliter per minute, and immediately in the periphery, you get a decrease in temperature. And then the last thing you have to do, and this is after 1 minute, is to pull back the sensor in the tip of the ray flow catheter, this dedicated infusion catheter, to know what is the temperature when the saline enters the system. And when you have this, these 3 elements, you know that you are infusing at 20 milliliter per minute. You know that the temperature of the saline when it enters the system is minus 4.66 degrees in this patient. And you know that the temperature in the distal part of the LED is minus 0.68. Well, the computer will tell you immediately that the flow in this vessel is 148 milliliter per minute. Yes, not velocity, not mean transit times. That's an absolute calculation of the flow. And if you have the pressure and the flow, you can calculate the resistance in Woods units. I will not go into the details that I anticipated because we are running out of time. Just to mention that if you give only 10 milliliter per minute, you calculate the resting flow. Look, it is in this patient, I do not even remember who it was, 0.68, so 68 milliliter per minute, that's at rest. You induce hyperemia, 227 milliliter per minute, so the coronary flow reserve is 3 point and a bit. But this is not velocity, this is absolute flow. This is extremely precise, extremely reproducible. We can even do all these measurements in one go if you program the pump adequately. And here, for example, you have the, this is the publication of last year, but you have the flow at rest, then the pump suddenly switches to 20, then here you have to pull back the sensor. That's all you have to do. The remainder of the time you can have a quick coffee, and you have all the resting measurements, all the hyperemic measurements. You have FFR, you have CFR, and you have the famous MRR, which is a specific index of the microvasculature, which is independent of the epicardial resistance, which is independent of the myocardial mass, and which is operator independent. That's very important. You don't have to inject something, you just have to stay, to push on the button of the pump. You can have a chat with the nurses, you come back 3 minutes later, you have everything on the screen. And that is the equation of this microvascular resistance reserve. Again, for the sake of time, I won't go into the details. Now, this continuous thermodilution in blue here is roughly 3 times less variable, which means more reproducible, than what we are used to with bolus thermodilution. This is now under review. But this is a huge difference, a huge difference. It's always the same value, a little bit like fractional flow reserve. So, by way of conclusion, I would simply state that in this area of precision medicine, everyone speaks of precision medicine. Actually, we are highly imprecise, but okay. The coronary angiogram as the basis of the coronary workout in patients with suspected ischemic heart disease should really belong to the past. I would say that measurements, let's say physiologic measurements, should be a kind of natural prolongation of the diagnostic angiogram in many, many patients, roughly 30% of the patients. PPG and fractional flow reserve are companion indices to characterize the epicardial vessel. And finally, microvascular resistance reserve, as derived from continuous thermodilution, should become for the microcirculation what FFR has been for the epicardial arteries. Thank you very much.
Maybe just before we go on any further, could we bring Dr. Kern up on the screen here to join us? I don't know if you were aware, but he's been listening in, and probably on a beach in Southern California. Well, that just looks like a virtual background there, Mort, so don't fool us. I'm sure you're there to see the sunrise this morning.
Yes.
But
yes.
So good that you're able to join us. And for those of you who don't know Dr. Kern, I've not met him before. He's one of really the co-founders of this meeting. And it's really wonderful to see you, but it would have been better, of course, to be here. We understand why you're still there.
Yes. So, good morning. I mean, my morning, your afternoon. So, a wonderful talk from Bernard. Nobody can beat that. The developers of these technologies have kept me in business for many years just as a commentator. I wish I had done some of the original research, but the work in Doppler flow ended as soon as that pressure wire showed up. So quite remarkable. Really enjoyed it. So I had a question for Bernard, because we're doing our measurements now in almost every day. And how do I reconcile my CFR, IMR, and MMR? Because yesterday we had a coronary flow reserve of 1.8, a high resting flow, a normal hyperemic flow, a low index of microvascular resistance. And of course, trying to explain all this makes for a long discussion with the patient. Was his flow normal, or was his resistance normal and his flow abnormal? So it's a wonderful tool. I'm dying to see how this will come out.
Okay, thank you for this comment, Mort. Do you hear me, by the way? Yes. Okay.
I do.
So you are starting with a very complex example of a patient with probably a very high resting flow, like unfortunately we see quite often in the catheterization laboratory, because in the catheterization laboratory, by definition, we are not at rest. That's one of the main problems of the catheterization laboratory and all the measurements that we perform there. But if indeed the coronary flow reserve is low, that the IMR is low also, that's what you mentioned, I strongly believe that the microvascular resistance reserve will be low as well. So the MRR goes along with the CFR, except that it is corrected for the fractional flow reserve. I know it is a little bit difficult to follow, especially without the support of a slide, but MRR, as you understood, is nothing else than CFR, your CFR, I would say, as the founder of the Doppler CFR, CFR corrected for fractional flow reserve. In other words, divided by fractional flow reserve to take into account the epicardial resistance. So I think, honestly, Maud, that we should abandon the bolus thermodilution-derived CFR. It's a blunt statement, but this is really too imprecise. The CFR, as derived from Doppler, is difficult to measure for the moment, simply because we have no Doppler wires anymore. And therefore, we are left with this third possibility of having a grip on the microcirculation with this, which is continuous thermodilution-derived MRR, microvascular resistance reserve.
I like the concept. I think it's a challenge to get them to put a wire in, and now you're going to ask them to put a catheter with an infusion system and a pump. But I think the value is true. It would be really great if there was a way to make a bolus a little longer and a little constant so that you could give two rates of bolus. But it's just all conversation to get us on the right path.
Well, Maud, your point is well taken. You're actually alluding to the fact that this technology is a little bit cumbersome, is a little bit complex. You need a wire, you need a dedicated catheter, and you need a pump. But this combination, doesn't it ring a bell? OCT is also a wire, a dedicated catheter, and an injector to inject contrast. And everyone does it. Why not to obtain this information with simple saline? It's really not rocket science. The only hurdle is the catheter, which is a dedicated catheter, and the fact that you have to program the pump. But in the pump, there is only saline. So there is no shortage in saline, to the best of my knowledge.
Yes. Well, Bernard, I enjoyed hearing your description of how FFR came to be and how it evolved into what it is today. What an honor and a privilege to be associated with this.
I think that everyone should recognize that this is a privilege to really have two of the giants in coronary physiology talking to each other thousands of miles away in front of us. So, I mean, truly, and if some of you didn't catch it, I mean, there was reference to Dr. Kern's early work with the Doppler wire. And Bernard, you know, the way you explain things, you know, with the slides, I was actually thinking as you explain that, I know you want to have a slide to explain that that last part, but you really do a very good job there. And I think we have time for some questions here. I mean, we don't have a lot of time, but if there's a burning question.
A very short one.
Could we get the microphone to this gentleman here, please?
It's really a great pleasure to attend the lecture by you. Actually, in practice, I think we face this scenario a lot, like a patient coming with angina, like stable patient, and you do FFR and it's like 80, 81, something like that. And what do you do in such a case?
Well, clinical aspects. So the clinical detail, the anamnesis, and the clinical panorama, I would say, always prevails. If you as clinicians, as experienced clinician, are persuaded, convinced that this is typical angina, exercise-induced angina, and that your FFR value across the stenosis, which you see on the angiogram, is 0.81, go ahead. Okay? Go ahead and please stand it. Paradoxical vasoconstriction in these patients do exist. Okay, that is not an illusion, and there is always a kind of gray zone even around this 0.80 value. But don't have the same reasoning if your value is 0.88, for example. Okay.
Actually, I have a case like that recently, but I did imaging. Actually, the MLA was really small in approximate LED, like 2.58, something like that. So I didn't hesitate to stent in such a case. One more question, if you allow me.
Well, I look to the chairman.
Okay.
Yeah.
We'll make it a short one.
Yeah, it's a short one. Okay, what is the acceptable FFR like after stenting in LED?
That's a very good question. Well, currently 0.9 is the threshold that we consider as acceptable. Yes. I won't go into the details, but look in the literature. We have a big, very thorough meta-analysis which is under review. And actually there is a difference between the right-hand circumflex and the LED. So LED vessels, non-LED vessels. And one of the main reasons why the LED is very often disappointing in terms of post-PCI FFR is that there is a hydrostatic pressure which is different, which plays a different role in the LED, which is higher than in the right and the circumflex, which are lower. So the maximum, the best post-PCI FFR that you can reach is 0.96, 95, 96, 97. So you start already from something which is a little bit lower than 1. But we are not going to dwell into the details because we are running late.
Well, thank you very much. And also, I think you were very diplomatic in when you were talking about CT FFR earlier, or FFR CT. You restrained yourself admirably. But I know you wanted to say yes to that, but I think everyone should just remember that the so-called precision of that depends very much on the image quality, because it's got nothing to do with hyperemia or flow. It's all fluid dynamics, AI, and so I think we have to be very, very careful. And we see a lot of overcalls there, and I certainly have a very low threshold for remeasuring FFR and IFR in the lab when those patients come, if it's not a clear-cut lesion. I'll pass the microphone to my co-chair to introduce our next speaker again.
Okay, so we've heard one fantastic talk. We'll move on to the next one, which will be from Dr. Kern, and his title will be My View of Interventional Career Traits That Make for Long-Term Success. Please, Dr. Kern.
Okay, can you see my screen? Am I good?
Yes, we can.
Okay, very good. So I just wanted to give you an answer to that question that the colleague of ours asked a moment ago. When your value is borderline, you already know what to do. I doubt anybody out there does not drive a car. You don't know, you know exactly what to do if you hit a green light. You know exactly what to do if you hit a red light. And when you hit that borderline value, you're driving in the yellow light. So you have to make a very concerted decision about what the right thing to do is. Okay, now, unlike Dr. De Bruyn, I will give you no science, no techniques, no criteria for determining physiology, but I am going to talk to you a little bit about what I think makes for a successful interventional career, especially for those of you who are going into both practice and or academics. So I'm just going to try and get my slides to advance. There always is some delay. Come on, little slides. All right, I keep trying. So this information really is intended for our graduating cardiology fellows, and for some reason I cannot get my slides to advance. There we go. And you know, success and traits that make you successful in life are almost always a matter of your own perception of what's happening around you. And I just want to remind you that not everything is always as it appears to be. So that's an important starting point to remember where you are. And you know, there are certain needs that all of us must have, and then there are certain traits that people need to apply to become even more successful. Some of our highly successful people, it's obvious some of these may be present, sometimes they're missing. And just to give you Maslow's hierarchy, of course, we all need these lower three conditions for success. We need to be able to live, to be safe, to have a loving and hopefully intimate and wonderful family relationship. Without that, those three base findings, you're going to have some trouble going forward. Then in your own life, your personal life, you need to have confidence, self-esteem, and of course, keep an eye on the ability of others and how they respond to you. There are many people around you who may not appreciate what you're doing, and it may be a function of you're not seeing exactly what they are. This term is called reading the room. Obviously, that means that you have to say the right things to the right people at the right time. Otherwise, you're going to miss it. You have misread the room. And then on the top here, I think these are the highest values. And if you can bring these to bear in your practice, in your life, you will find success and a wonderfully satisfying career. Okay, so I'm sure there's some out there who must be asking, does money bring happiness? And here's a wonderful little graph years ago that showed that on the horizontal, the very happy people here on the bottom, it doesn't really matter about their income as much. And so as your average income increases, it doesn't mean you are becoming more happy. Now, money does solve a lot of problems, so there's always that. But I think that cardiologists, interventional cardiologists in the modern world here will do fine financially, but it is not a function of dollars that will make you more happy. Okay, so what is it you really want to do? And part of traits that will make you successful is identifying exactly the goals of your career. Do I want to be in academics? Do I want to be in clinical practice? Do I want to establish a hybrid model? How do I want to relate to my patients? How do I want to relate to research? What are my opportunities to come to meetings and participate or contribute, be on the panel, and so on? So part of this is you deciding what it is you want to do. So let's just take a look in what I think are the three major traits you need to be successful in academic cardiology. Well, you need to be able to ask a question and pursue an answer. They call that research, but it's really just being a curious cardiologist who uses techniques to gather information, assemble questions, analyze the information, and then provide an answer to the question you just asked. So I think research is key to success in academic cardiology. And part of research involves both teaching and writing. That is, you cannot really succeed in research without writing about it, without sharing your knowledge, even in the most basic forms. So abstracts, little papers, case reports, things that you do should be shared with others. This is a form of both research conveyance, but also of teaching information. And the more you teach, the more you know, and not know, but the more you solidify your knowledge. And so teaching is part of this. And this is another way to share what your research says, advance the field, and gain those personal traits I just spoke about a minute ago for your self-actualization. So research and teaching and writing are keys to successful academic cardiology. These don't mean you can't be in clinical practice. You can do the same things. So let's look at what I think are the keys to success in clinical practice. And first of all, on the left here, you have to have good clinical sense, good clinical acumen. It's hard to tell somebody you're not a great doctor, but you should think for yourself, what are the limits of my knowledge? When do I need to ask for some help? When is this situation more complex than I can manage? People will respect you for doing that. They don't expect you to know everything in medicine. It's not possible, but they will expect you to elicit help to get the clinical keys that you need to take good care of this person. Now, in the middle, cultivate a good personality. I can't help you. This is something you're going to have to do all by yourself, but it's part of a number of different traits, right? Being affable, being available, wanting to be present. I'll touch on those in just a minute, but cultivate a personality that makes people want to be with you and ask you things and have you help them. And then lastly, success in clinical practice. And I think this extends beyond clinical practice. Time management is really key. You're only on the planet for so long. You only have so many hours in a day. You only have so many days. And managing your time is the most valuable aspect of success, in my opinion. Many can't do it. I don't do it well all the time, but I try. So manage your time. Now, there's some personal traits that people want, right? So I'm just going to move this little thing off my screen. So traits that make for family life satisfaction are presented here. So the family wants quantity. I know this concept of quality time has been put out there. I'm going to give them quality time. No, they want as much time as they can get. They want every day, all day. They want you. They want quantity over quality. But if you're going to have to shave one thing, give them the best when you're there. Now, your job and work-life satisfaction will come from financial success. That's a given. Peer recognition will be achieved. Hopefully, you'll have some intellectual stimulation that'll keep you going in this thing. And eventually, in your job and your life and your hospital, leadership and innovation will provide a great deal of satisfaction. Okay. Now, I think my slide's stuck. Let me see if I can get it going here. Okay. So other thoughts to make life a little better, especially around the house, is, you're not in this by yourself. Most of you are not in this by yourself. So I like to say, if you have a happy wife, you're going to have a happy life. A corollary will be home by 6, be there for dinner, go back later if you have to, but provide your exposure to your family and your children. Be there. Now, this is a simple statement that means when you're talking to somebody, be engaged, be present. When you're talking to your family, your wife, be there. When you're home, be there, not somewhere else. Don't be absent-minded. One of the things that really is disturbing, maybe not so much where you are, but if I'm in conversation with somebody and their phone rings and they answer their phone in my face, our conversation is over and your stature with me is down. So be present. If you have to answer the phone, do what polite people do, is excuse yourself, step away and come back. That's normal, but just don't pop the phone up. Communicate clearly. Remember, your family unit is a business. Your spouse is your business partner. Engage her in your activities. And of course, if you don't take vacations and you're only working, you're going to have some very severe and harsh life. Okay, so here's the question. Are you a time waster? And the answer is mostly yes, I am. I'm one of those, but by estimates, people waste about 2 hours every day. Signs of time wasting. You've probably seen these. Messy desk. Malcolm, I'm talking about you. Cluttered, no files, can't find things, missed appointments, need to reschedule, unprepared for meetings. You volunteer to do things other people should be doing for you and wasting your own time. And then finally, are you tired and unable to concentrate? Now, I took these from Dr. Randy Pausch, who gave a wonderful talk about organization, but you're probably a time waster. Now, one of the things to help you would be to be a little more organized in your life. And here was my office before I decided to get organized. And then here's my office now. Everything is organized and I can find things and I quit wasting a lot of time. Now, Dwight Eisenhower broke his time management into a 4-box grid. And he had a lot of things to do. Remember, World War II was a complicated process of getting things done. And it was a matter of life and death. So there are things that are urgent, but not important. And there are things that are important, but they're not urgent. Important things are never urgent. So he had this little grid, important and urgent, do those now. Important, but not urgent, you can plan to do those. Not important and urgent, delegate that to somebody to take care of. And not important, not urgent, get rid of those. And so here's some examples. He did those personally. He had crisis and deadlines. Here he got an end date. He planned it and often did it personally. This was involving prevention, relationships, recognizing opportunities. Down here on the delegate, you know, get this work done. Don't let it interrupt your meetings and activities. And then lastly, get rid of some of this stuff you don't need. Okay. And I want you to notice email is on the bottom two boxes of both of these. I'll bet some of you, like myself, often get deep in the weeds with emails, which is a method of wasting a lot of time with no yield. So think about that. Okay. Personal traits for success. Be there. I mentioned available. That is, actually be physically available and mentally available. Be affable. I know this is obvious, but some people are not as nice as they could be. And of course, there's no such thing as a bad consult. Don't ever put your referring physician in an uncomfortable place and think of him as less than a smart guy. Make him feel good about what he's asking. Be effective, get it done, preferably today. Be dependable, that is, don't talk about it without doing it. You've heard the expression talk is cheap, meaning the guy who talks about it and doesn't do it is worse than the guy who doesn't talk. Be honest and timely. If you can't do it, learn to say no nicely. This is a challenge because it's often a word that nobody wants to hear. But what you can do is say, look, I can't do it today, but I will do it. Or I can't do it and I'll find somebody to help you. But there is a way to say no. Okay. I don't want to counteract my own major 3 words of wisdom that I'm going to give you in just a moment. So here are a few extra words of wisdom for cardiologists on their path. Brevity, clarity, and wit. I think I tell this to my fellows maybe every month. I could tell them every day sometimes, but when you communicate, people want you to tell them what they need to know right away. Brief, be clear, and if you can do it with humor and wit, it's even more appreciated. So I tell my fellows, when you're presenting, be brief. When I ask you, does the guy have heart failure? The answer is yes, no, or I don't know. The rest is commentary. So I like to get to the money. I like them to be clear. And if they tell me a joke, that'll be good too. So the fellows who are off in their pathway now, because it's the end of our academic year, I want the people who they encounter to come back and say, that's the guy I want to work with. That's the fellow who's smart. That's the fellow who's clear. That's the fellow who's around. And so I tell them, be the one they want. Okay, now, I don't know if you guys have met my dog, Chip. Riley died a couple of years ago. I was heartbroken, but Chip's been here. He's a COVID dog. He's 2 years old. He likes champagne. And he talks, and I'll tell you the talking dog story in just a minute if I have a moment. But right now, things I learned from my dog Chip are things that you could learn and share as well. So he says, thrive on attention and let people touch you. I think this is good advice. He says, avoid biting when a simple growl will do. I think this is a good method. Don't go crazy and bite somebody when all you have to do is just say, hey, I'm not sure that's the right thing. This is a good piece of advice. Take naps and stretch before rising. I'm practicing yoga. Eat with gusto and enthusiasm. I didn't need any encouragement for this, but you should think about it as well because my dog loves that. Be loyal. You should be part of your team. And in a moment, you're going to bond with your pack. Never pretend to be something you're not. This is a problem because if you pretend to be that and people find out, your credibility is gone. And as a physician, and an interventionalist, you will lose everything if you lose credibility. People will not want to work with you. If what you want lies buried, dig until you find it. That's what he does. And this means pursue your goal with enthusiasm and dedication and get in there and get the answer that you want to get and take care of that patient. And lastly, I think as a team member, you need to bond with your pack. So Chip gives us those words of wisdom. And here's the second thing that bothers me the most about our professional interactions. And the question is, do you live in Tardyville? Now, you probably don't know where Tardyville is, but tardy means late in English. So Tardyville is the place you don't want to be late. So habitual lateness tells others they're not important. It tells your spouses, your co-workers, they're not important, and your bosses and your friends and your colleagues don't like it. They may never say this to your face, but it's true. And I think this is very important. Just because you're a doctor doesn't mean you're entitled to be late. Now, I have this card for my fellows. When they're late, they get a red card. I don't even have my yellow card anymore. Red card, boom. Okay. The next best piece of advice I can give to the career traits for my colleagues is, in arguments with your spouse, ask yourself, you want to be right or do you want to be happy? This is not an easy question to answer, but I think it's evident. You'd rather be right. Sorry. You'd rather be happy than right in these cases. Okay. Years ago, I knew this was true. If you want to go fast, you go by yourself. If you want to go far, and that means far in life, far in your career, far in success, you have to go with others. Be the one they want. Wow, I saw that one. Okay. Fellows, as a corollary to the being brief, when we have rounds and you're asking questions, I want you to make it on point, right? So if you can't state your question in Twitter format, I know it's more characters now, it's not a question, it's a speech. Okay, so let's just close this discussion. I know this was freewheeling. I would have rather give some science, but Eric, I can't thank you enough for the opportunity to have worked with you these many years in the Lausanne meetings. This was my ultimately favorite meeting of all meetings. I think we learned more from this meeting than I learned from any other over the year, because it was focused on our failings and how to improve rather than on showing off our successes and patting ourselves on the back. I think this is something that cannot be duplicated. So for all of you interventionalists there in the audience, there's really no such thing as failure. You guys will not fail. The question is, how successful will you be? And that will be determined by your use of the traits of success I hope I touched on. So I'm going to say thank you very much. I hope I didn't go too far over my time. And I look forward to hearing this. Now, I'm going to have to go to work in a little while because I'm just beginning my workday. And my partner is on vacation. I'm the only one in the lab today. So thanks again.
Mort, that was perfect, and I really hope that when you get to work, there won't be multiple red cards there waiting for you.
That's right. I hope I don't get a red card. But
it's a great talk to have at this time of the day, as you know, and you know that we've been reviewing some amazing cases, complications that we've never seen before, and some that we've seen too often. But I think you've really hit, sort of complements what I was talking about this morning. And I guess Roosevelt did not have email, did he? In that the urgent,
no.
Put off.
No.
But the email thing is really important. And I just want to make a comment because back at Mayo, I've actually had to try to encourage so many of our junior faculty to get control of their email. You do not want your inbox to rule your life. And for
Correct.
those of you who are really struggling with email, there's two things to remember. One is work out actually how to use Outlook. There are multiple tools there that you just need to invest maybe 1 hour and you can just clean that up, and a lot of stuff just gets taken care of automatically. Number two, missing an email is not a sentinel event. Would you agree, Mort?
I would. In fact, I tell my colleagues, I said, if you want to talk to me, don't do it by email. I got a phone. It works well.
Yeah.
And I'll get right back to you. But if you send me a note, I'll get to it when I get to it.
Yeah. Only older people use email, as we know, Mort. But, Mort, could you just maybe make maybe sort of, what do you look for in terms of a leader? Because in the cath lab, you really are the team leader. You've got nurses, you've got fellows, technicians, you might even have a CV surgeon in the room, but you're still the leader. What are the traits that are really important? I mean, some of them you've already outlined there, but could you just maybe just tell us what do you think really makes up a good leader?
That's a good question. So if we just look at in a little microcosm inside the cath lab, it's pretty concentrated in one person. The trait there is somebody who is aware of his surroundings, his team, and the situation. And so you have to be on top of all those things and command with knowledge the steps that you need to go through to get that done. Now that's a very specific leader in a cath lab, but let's take the chief of medicine, for example. That's a bigger job. So that individual has to have good rapport, knowledge, command of the structure, and then a clear idea of the goals that that leader wants to accomplish. And then communicate it well. Again, brevity, clarity, and wit always works no matter where you are. And then sharing responsibility and delegating where it's important. You know, you've had leaders who become selfish. You've had leaders who don't think beyond their own needs. You've had leaders who can't figure out what it is they're trying to do. You've had leaders that actually don't have enough of a knowledge base to make things happen. So the good leaders would be the opposite of some of those traits I just mentioned, and I think that it's situational often, and it's quite a matter of good personality as well.
You know, I think it may be a bold assumption, but you know, the average IQ among us is pretty high, but the emotional quotient, the EQ, is very variable, isn't it? But
yes. So
go ahead. My 140 characters are used up there. Go ahead, Mort.
Yeah, no, I said part of it is being EQ, your emotional quotient is part of being able to read a person and read the room in which you're talking and make it important that you sort of link in. I heard a story the other day about how one of these very competent, high-level intellectual interventional cardiologists could not give a lecture to a room because he didn't connect with the room. He didn't connect with the people he was talking to. He was talking at them, not with them or to them. And it was a very unfortunate circumstance that he would not have been a good leader because he could not make that connection with the people he was talking with. It doesn't happen here.
Of course not. Eric, do you want to say something there? But
yeah, and indeed, Morta, I think at least I need to say something to you, and thank you for all these years together. You know, you were here the first time in 1998. You remember? That's 24 years ago. So and all over these years, you have been part of this meeting, and also today. You basically made a connection with the people from Mayo, and you made the meeting happen and stand where it is now. And even in this, you know, you don't see me, we all see you, you don't see us. Everybody was very impressed by what you told us. There's so much humanity in so much truth in what you say, and so much things that people don't like to talk about. We have a tough job, and the job of a physician in terms of medical care and taking care of our patients is fantastic, because we get so much in return, much more than what we give. The other issue, and what you mentioned also, is the environment we're working in, and it's not always easy. And I think you know that. I think you also experienced that during your career, and we can sometimes be extremely disappointed by the way we handle our career, by what happens over time. But I think if everybody would follow the points that you made up there, we would be all working better and more nicely together. So that's all I wanted to say. And I take the opportunity to really thank you for these almost 25 years of friendship, because I remember you showed some slides when you were here physically in 2019 about ECC meeting, but without you, this meeting would not have been where it is today. Thank you for all.
Oh,
yeah, thank you very much, both.
Thank you, Eric. Thank you, all Malcolm and colleagues. Thank you, audience.
Yeah, and like you, this has become my favorite meeting as well. And we miss you here, and I have no one to smoke cigars with here. So
I too miss you all.
okay, you better get off to work there. Thank you so much. And I think we should just hand off to the next chair people so that I know we're a little bit behind, but Eric, will be housekeeping there?
It's you, basically, if you
Oh, okay, I thought it was the panel.
Let me check. So you're supposed to chair together with our colleague from South Africa.
Okay. So bring on South Africa then. Is Olivier joining us here? Maybe not. So welcome to the last session of today. It's entitled South Africa and the ECC session. And the South African chairs are Dr. David Kettles and Arthur, and I hope I'm pronouncing this correctly, Mutiyaba. But please correct me if I'm wrong there. And it looks as though we have some additional people on the panel there. And David, maybe I'll just have you introduce the panel there, and then we can get started. Yes. I'm sorry that you've been kept waiting on hold there.
We enjoyed listening. Thank you very much for having us. Eric, are we coming through clearly? Can I carry on?
Yeah. Well, let's. So why don't we just start with the first case here from Krugersdorp, and looks like Mafundo Mathanjawa is going to present the first case.
Can you hear me at all? No? We
can hear you.
Okay. So
if that's what the question was.
Yeah. Firstly, just thanks for letting us have this session. It's a wonderful privilege to join you guys. Thank you, Eric, especially to you and your team. And I just wanted to introduce Dr. Arthur Mutiyaba. He's a consultant at Charlotte Maxeke. And perhaps because we're struggling a little bit with who's speaking and who's not, I will also introduce you to our first speaker, Dr. Mfundo Mathanjawa. He's a private cardiologist in practice in Netcare Krugersdorp. And we've got three lovely, I believe, complications cases that some of my young colleagues have brought to show and share. And I'm sure we'll be able to learn something from them. So Mfundo, I see you sharing your screen. Please go ahead. Make sure you're unmuted.
Good evening, colleagues. I am presenting from Netcare Krugersdorp in Johannesburg. Just the first picture there is people who are out of time running away from the wave of the tsunami, 2004. I'm discussing an 86-year-old female, non-hypertensive diabetic with osteoarthritis as well, or non-hypertensive, diagnosed at MR, metformin, and analgesics. She presented with a 2-month history of typical chest pain, which had recently worsened over the past 2 weeks, associated with dyspnea and easy fatigability. So on clinical examination, she was an elderly lady who looked good for her age, not frail at all, not in heart failure with normal heart sounds and osteoarthritic changes in the hands. The ECG was basically normal. The echocardiogram had no regional wall motion abnormalities, and she had good left ventricular contractility with an ejection fraction of 75%. The troponin was normal, and an assessment of unstable angina was made. We took her to the cardiac catheterization laboratory. So I went via right radial artery approach with a 6-French TIG catheter. And as you can see here, the right coronary artery has a sharp bend at the junction of the proximal RCA and the mid RCA. but the significant disease in the mid to distal RCA. The left system has mild disease of the distal left main artery and the mid LAD, plus the circumflex, mid circumflex also has mild coronary artery disease. So this is my guy, Muhammad Ali. I decided to go with an AL1 guide catheter to the RCA. I gave enoxaparin IV, and I used the Sion blue wire. I pre-dilated the distal RCA with a 2 × 15 millimeter balloon. And I decided to stent first the distal segment with a 2.5 × 28 millimeter stent, and I took it to about 2.8 millimeters. So I was happy with that outcome distally. So then I decided to cover the long mid RCA disease. So as you can see, there's a long stent here, which is a 3 × 40 millimeter drug-eluting stent. Good inflation there. But what happened was, I think I was a bit too rapid in removing the stent balloon before complete deflation of the stent balloon. And the vessel was quite calcified with a sharp bend at the junction of the proximal and mid RCA. So what happened was the stent balloon was partially deflated and I couldn't withdraw it. So in that process, as I was pulling back, the proximal shaft of the stent balloon broke off. So the distal shaft with the balloon was left inside the artery, partially deflated. So I was really disheartened by what happened. So in that process, I lost the wire position and the AL1 catheter also disengaged. So what do I do next? I'd lost the wire, I'd lost the guide catheter. So I thought of a person who could rescue me at that time, and that was a young surgeon who said he was willing to operate the following day to remove this balloon which was entrapped in the right coronary artery. So he suggested we discontinue the acrostate infusion and clopidogrel, and he ordered that we start a heparin infusion. But he changed his mind as soon as he got to the cath lab and had a look at the images. He said, this is a porcelain aorta. The patient is very old, she's 86, and he was a young surgeon as well. So he felt uncomfortable doing this case. So what do I do next? I thought of a friend who was an hour away. He said he could come up to my hospital in about 2 hours. At that time, the patient was stabilized on a dobutamine infusion and intravenous normal saline. So she went to the coronary care unit. She was feeling better at this time, and she started to eat to make up for the NPO status throughout the day. By mistake, the sister removed the radial artery sheath in the right forearm. So my colleague from the other city arrived about two hours later, and we started to review the images. So this is what we can see here. There's a partially deflated stent balloon in the proximal to mid RCA, and it's trapped in the band and the calcium. So what do we do next? We decided to follow. We knew that the distal half of the shaft was somewhere in the brachial artery, as the proximal half had been snapped off. So as you can see here, it's in the brachial artery. And our thought process at this stage was we were going to make a puncture in the right femoral artery and go in with a guide catheter. And this is the scenario we're having at this point. There's a stent balloon in the proximal to mid right coronary artery. The shaft is in the ascending aorta all the way to the right brachial artery, as this was done by right radial artery approach. So we wanted to go through the right femoral artery with a guide catheter, and we wanted to snare this distal shaft into the guide catheter and pull it back all the way to the aorta so that we don't traumatize the brachial artery. But unfortunately, we couldn't advance this guide catheter through this ascending aorta and the right brachiocephalic trunk. So we had to try another approach. At this point, this is how the vessel looked. It was almost completely thrombosed, and the patient was hemodynamically unstable. The systolic blood pressure was 70 millimeters of mercury. So we wanted to go through the right radial artery, but the sheath had just been removed. So we had to go through the right brachial artery. This was the aim at this time, to introduce a guide catheter into the right brachial artery and to use a snare to snare the shaft of the stent balloon into the guide catheter and to advance the guide catheter over the shaft as a unit to the ascending aorta so we don't traumatize the right brachial artery and subclavian artery. We were worried that if we snare from here, from the right brachial artery, we would traumatize the vessel because that shaft is actually hard and can injure the vessel. There was no snare available, so we decided to make our own. So we did this using a BMW guide wire, inserted in a balloon, and we used a guide liner as well, so a guide extension. So we inflated this balloon, 3 millimeter balloon, against the wire and the guide extension, and this was used as a snare. So this is our snare. There's a guide catheter, there's a guide line or guide extension in there, that wire. And in the right brachial artery, we also have that shaft of the stent balloon, which was trapped there. So there's our snare. We're snaring in that shaft of the stent balloon. So now we started snaring the balloon out. As you can see, we're starting to pull it back into that catheter, which is in the ascending aorta. But in that process of snaring it back, we also lost it when it was halfway into the guide catheter. So now, because we had half of that stent balloon in the guide catheter, we decided to use a trap balloon and inflate it against the guide catheter. And we withdrew the whole unit through the right brachial artery. And after snaring and removing everything, we used the JR4 guide catheter, and this is how the artery looked afterwards. Thank you.
Thank you, Mfundo. That's a fantastic case. Maybe our in-house chairs would like to comment, or there's so many learning points in a case like this. I'd love to hear your responses, maybe initially to Mfundo.
David, when you said in-house, in your house or our house?
I think your house, maybe.
Okay. So I do have a question. First of all, it's a wonderful case to share, because I think that it's interesting. We've been seeing a lot of patients today who are octogenarians, and these people have a lot of tortuosity and so in their great vessels. And so I think we're going to see more and more catheters that get trapped there, and you need to know how to use snares, and congratulations on making your own snare there. But so I think that with increasingly older patients, the tortuosity, the complexity of what you're dealing with, it's really important to understand how to use a snare. And I'm curious, so you went through the brachial artery. What size catheter did you use? Because typically once you start putting snares in, you want to have as big a catheter as possible. And of course the brachial, that's what Mason Sones used. That's how I was trained early on. We used 8 French catheters routinely. But I think it's important that whenever you're trying to retrieve something, you put a catheter that's as big as possibly you can. So what size did you use there?
We used a 7 French guide catheter.
Okay, that's good. And then, of course, we have sheathless guides, 7.5 French, if you want to use those from the radial. Any questions or any comments about what we've just seen?
I think, Arthur, maybe you'd like to comment?
Yeah.
Please go ahead,
Sorry.
Dave.
Thank you. Thanks. Mfundo, thanks. That's a very a good presentation with a lot to learn from. Just a question that I have. So you think that it was perhaps that you pulled on the balloon before you pulled the stent balloon before it had completely deflated, and that's why the shaft broke. Is that what you think went on?
Yeah, I think partially because this is quite a long stent, so I should have been more patient, and it's a calcified vessel and there's a sharp bend. So I think it's a combination of factors. Yeah.
Okay. No, I only asked because I've had a similar complication which I was able to get out of. But in hindsight, to me, it's sometimes when you're forcing, not forcing, but advancing your stent through the core pilot or the Y connector, the shaft could bend. Could bend if you're, say, in a hurry. And in those circumstances, one is always advised to be careful with that stent, with going up to high pressures or trying to deliver that stent in a very calcified and tortuous vessel, because you've then created a weak point which you might not be able to you make it worse by trying to force it through a very calcified and tortuous vessel or going up to very high pressures when you deploy it. So I think that's another point to consider as one of the reasons that you could end up with a shaft breaking off the stent balloon. I'm not sure what the rest of the panelists think.
Yeah, I mean, Eric?
Yeah, I think the comments are well taken. What I take back from this case just reflects what Morten Kern just told us in his previous speech. So in his previous talk. So I think you did the right thing. I saw that the environment is not easy in your situation, but you called for help and somebody came all the way and helped you out, and you did the job together. And I think that's probably for me the most important take-home message from this case, and that you solved with the material you had on board. You were able to solve the problem. There is a hand raise from one of the colleagues from South Africa, but then we need to go on to the second case. Maybe you want to comment?
Okay, Eric, maybe I can't see the hand. Maybe I'll just make a comment. And just to say, the stents that we're using are getting longer and longer, and withdrawing long balloons always presents an opportunity for a complication. So it is a time when we need a lot of patience, to avoid deep catheter, guide catheter, deep seating, vessel injury, and fracture. And the one other comment I'd make is when something breaks, I think this case is a beautiful illustration of try to keep your guide catheter in position. There may be an opportunity to use a trapping balloon with the original guide catheter right at the beginning. If you're fortunate enough to get a catheter fracture which is quite deep inside the guiding, and a balloon trap here could have averted a lot of trouble if it had happened right at the beginning. So I think a great case. Thank you very much, Mfundo.
Yeah, and in fact, I think the other point that was made is, as you're going through the co-pilots, I think you ought to be very, very careful. If you have a stent balloon and you've kinked the catheter, you have to be very, very careful. And if you can afford it, you should probably just throw that away, because one of the things that can happen, you may be able to inflate the balloon, but you may not be able to deflate the balloon. And that applies just to balloon angioplasty as well. But I think that when you have such a complication, the importance of just getting the other person to help, even though this was 2 hours away, and being patient. But that's so important, because if you rush into it, you may actually end up getting into more trouble than you had initially. So you've got to think about all the different options. Yeah, yep. Don't pretend who you're not.
Thank you very much.
So, okay, so I think we need to move on to the next case, and I'm told that Dr. Masoud is here to present the case. And he's from Tunisia. Yeah, obviously the continent of Africa, North Africa, not South Africa, but.
Okay, thank you. Good evening, everybody. First of all, I would like to thank the ECC organization committee for inviting me to share this case from Tunisia. I have a long travel from Tunisia to Frankfurt yesterday to participate in the CSI Frankfurt Congress, and today I'm in Lausanne to participate with you in this Congress. As you see, the title of my presentation is CSI. I chose this title for 2 reasons. The first one is that CSI is the abbreviation of the famous television American series Crime Scene Investigation. And as you will see in this presentation, we will have a crime scene, which will be a very rare complication. I'm sure that the majority of you have never seen this complication. And we will have a fastidious investigation to determine the guilty of this rare complication. We usually talk about dissection, perforation, and thrombus in PCI complication. But you will see, we will see a very rare complication. Concerning the second reason, I let you know it at the end of this presentation. So, it's about a 71-year-old male patient with a history of smoking. He was referred to our department for PPCI in the setting of inferior STEMI with complete atrioventricular block. Medication before PPCI included clopidogrel, aspirin, heparin, and atropine. At the beginning of procedure, I decided to not perform a cardiac temporary pacing because the heart rate was acceptable under atropine, and because I thought that, I will have a great chance that the atrioventricular block will disappear after the culprit coronary artery reperfusion. So, coronary angiogram was performed through radial access. It showed no significant lesion in the left coronary artery and a total thrombotic occlusion of the first part of the right coronary artery. PPCI was successfully performed by a bare metal stent 3.513 millimeter. Just for information, in our department we use always drug-eluting stent, but in this period the hospital have a problem with the big sizes of the drug-eluting stents, so I was forced to take angioplasty with bare metal stent, and as you see, the result was good. Is there any comment about the result? No problem. Okay. Unfortunately, after the procedure, the atrioventricular block did not disappear, although I was waiting for 10 to 15 minutes. So I would like to ask you a question. How would you do in this situation? Do you perform a cardiac temporary pacing? Do you wait again for 10 or 15 minutes? Or you do not do anything? Stable. No problem. Patient was very well.
It's a tough question.
But I have a heart rate. You see in the angiogram that the patient is an atrioventricular block. The heart rate was about 40 maximum 50. But he was stable.
Natalie, can you again have the mic? Take a microphone, please.
What prevents you from putting a temporary pacemaker? What is the hazard of putting a temporary pacemaker?
What?
What is the risk of putting a temporary pacemaker? What is the risk? Why not?
Why not? It's invasive manipulation. We can have an hematoma in the vein femoral site. We can have tamponade. We have seen that. with temporary pacing. It's an invasive act, so we can have complication with that.
Let me ask you another way. What arrest after the procedure? You're just monitoring for 15 minutes.
I was waiting for 10 to 15 minutes. Patient was well, but the atrioventricular block did not disappear, and the heart rate was about 40.
I suspect we would have done the same. We would have waited. And if this patient had presented late, it may take some time for it to recover. It may not recover at all. But if he's hemodynamically stable, I think now we have a transcutaneous pacer as a backup. You can always put a temporary in if you really need to. But I think at this stage, I think I would just send the patient to the CCU and for monitoring and wait and see.
Yes.
I think it's difficult to predict when it's going to come back to sinus. I just had a case like this 3 days ago. So.
Yes, it's a difficult situation, but as we have seen in the last presentation, I haven't time to waste, so I decided to perform temporary cardiac pacing in this procedure. Okay, so temporary cardiac pacing was successfully performed, and concerning the patient outcome, the in-hospital outcome was favorable, with total disappearance of the atrioventricular block in 24 hours, leading to the cardiac pacing retrieval. Biological tests were normal at this moment, excepting high-level troponin. TTE showed ejection fraction about 50% with no other abnormalities, and patient was discharged at day 5 under aspirin, clopidogrel, and statin. But now, 2 weeks later, the patient was referred again to our department for persistent chest pain and new right bundle branch block in ECG. There was no history of DAPT discontinuation. So we performed urgent coronary angiogram, and it showed this strange aspect at the level of the distal part of the right coronary artery. Left coronary artery was normal. So I would like to ask you 2 questions. What's your interpretation? The first question. The second question, how would you treat this lesion? I think that there were only 5 options. I will ask you the 5 options. The first one was to stop procedure because of the TIMI3 flow, to administrate GP2B3A inhibitors, and to control coronary angiogram later, in 1 week, for example. The second one was to use IVUS or OCT to much better understand this lesion. The third one was to perform thromboaspiration and see. The fourth one was to perform an ad hoc angioplasty with an overlapping conventional stent, bare metal all drag eluting stent. And the fifth one was to perform an ad hoc angioplasty by an overlapping covered stent. I think they were the 5 options in this situation. If you have another option, I can hear you. He has a persistent chest pain. He has chest pain in this moment.
And a right bundle branch block.
Right bundle branch block.
So I think that I would like to understand more about this lesion, probably with some intravascular imaging, but I wondered, I can't quite tell here, but it looks big enough that you might even be able to see it on CT, because it seems disconnected from the vessel. I mean, obviously there's contrast coming into it, yes, but it doesn't look like your typical perforation or aneurysm.
Yes, it looks like a perforation hematoma. I am in the context of PPCI. I remember you that I am now in the context of emergency and see this aspect. I don't know if it's an hematoma, dissection, perforation.
Maybe we can ask if there is a brave person in the room who can stand up and give some ideas. You can only be wrong, but you can maybe be right too. Maybe you.
Yeah. Actually, I totally agree. You need to know what is your interpretation of what you are seeing, because what your interpretation will lead you to decide. What I can see here, I'm not seeing like a really thrombus. It is kind of like recurrence of lesion, like new edge very early, like recurrence of lesion in the distal edge of the stent, and some saccular aneurysm. So I think imaging is very appropriate in such a case.
Exactly.
Stent fracture is an option.
Oh,
Yes. Christian absolutely wants to speak. Wait, Christian, you first.
To add to all of you, we should do another review, another angiographic view.
I have the 3 views if you want to see them. I don't know how.
Christian needs a microphone.
We can. We have 3 views here. Yes, you have the. I cannot do rather than 3 views.
Which kind of stent did you use? But personally, maybe this is the quality of the image here, but I didn't see the stent. The stent is there. Because the occlusion, it was more proximal. How long it was the stent?
This lesion is at the level of the distal part of the stent.
Is it a stent migration?
No markers. There is no markers in this stent. But you can see it clearly if you...
Everybody wants to say something. Take your time. Because it's a very rare complication.
Yeah. How did you tackle the index BCI? Did you predilate or what? Because usually
I have predilate in the first procedure.
Usually you see this sacral aneurysm if you use cutting balloon or something like this. But I'm sure you didn't use cutting balloon in a primary BCI. But what size of balloon you predilated with?
Simple balloon, simple BOPA, 10 millimeter.
It's not 1-to-1, I mean.
No. It's
okay.
not.
It's
it
okay.
was a very easy procedure. The first procedure take about 5 to 10 minutes. Very easy. Very easy. It was not. I was waiting for the atrioventricular block more than the total time of the procedure.
Can we get the microphone up?
Wire crossing, predilatation, and stenting.
If it's a distal end of the stent, you said.
At the distal part of the stent.
Yeah. Most probably it's just the dissection, and most probably it's a progressive.
Maybe.
Yeah, and then thrombus at the end of the stent, I guess.
Yes.
I think would we all agree that this is very unusual to see 2 weeks afterwards? And if I saw this, I would want to go back and you don't have to do it here, but you go back and look at the original angiogram at the end of the procedure. There was no hint of any problem. And for this now to develop 2 weeks later, I would think be very, very unusual.
Yes.
And plus you kept the patient in the lab for a while. Maybe you took another picture before you sent him back to the CCU the first time. So you had plenty of time to look at this, and there was nothing there. And you're going to go back and look at the original ones, not a hint of a problem. So I think it's going to be something unusual, but I think we would all agree that this is a very, very uncommon thing to come back 2 weeks later and look like this.
Exactly. So
maybe we should move on here. You tell us what you did?
Yes. So your final decision is the first, second, third, or fourth option? For the first option? Second option. Okay. Unfortunately, in our department at this time, IVIS and OCT were not available. So at this time, I hadn't the second option. I had only the first, the third, the fourth, and the fifth option. Okay? So, how did I treat? At this moment, I decided to perform an ad hoc angioplasty with a conventional stent. I didn't prefer to perform angioplasty with a covered stent because I thought that there was a high risk of thrombosis in this case. So, I didn't understand the lesion mechanism. I thought that there were a dissection, perforation, hematoma. So I decided to perform an ad hoc angioplasty using a bare metal stent overlapping with the last one. And as you see, I think that the result at this moment was acceptable.
It may be some sort of endoleak. Like aortic stent.
Maybe, but at this moment, I didn't understand what happened. What really happened?
Wouldn't change what you did.
Do you have an angiographic image with the temporary wire in place? I can't see the images clearly, but that filling defect looks a bit like at the end of the stent. And I wonder whether the temporary wire may have somehow interfered with your original procedure.
I had 3 views, but I didn't understand really. Like you, now you are seeing the case, and I see that even the audience have not understand the lesion. So I decided at this time to perform an endocangioplasty, and as you see, the result was acceptable with the total disappearance of the thrombus and of the aneurysm of the right coronary artery. But we'll see after that. No, before no echo. There was not a reason to perform echography before PPCI because hemodynamic. Chest pain plus a new right bundle branch block, PPCI. We have not hemodynamic complication or mechanical complication.
Yeah. You know
I don't know. You do for the conventional STEMI like this. It's an ordinary STEMI with stable hemodynamic status. We perform immediately PPCI. We don't perform echography before PPCI.
No, I think she was saying afterwards for this current admission, and that's why I asked about a CT scan. I think that sometimes when you see something that you just don't know what it is, it may be that you do need additional imaging. So you've got intravascular imaging, you've got your angiogram, something,
we will see that,
or a CT, and sometimes you see something like this is so unusual that maybe that there's something that it's belying really what is really going on. So sometimes it may be the tip of the iceberg, it may be something else.
But you will see, it will be the investigation for this. We will do all the exams. In the intensive care unit, immediately after procedure, physical exam showed fever at 38.5 degree with tricuspid systolic regurgitation murmur. I think that anyone between us take temperature of patient before PPCI. Is there anyone who take the temperature of the patient before PPCI? Oh, I think no. Before PPCI. It's systematic.
Stop. We have 2 issues. We are a little bit behind time. I will resume what you said. So some people say here that they do standard temperature measurement and echo before going to the lab, but this is no hard data. So your practice is acceptable, but other practice is also.
Yes.
Yeah.
2 weeks later. Exactly. Okay. And biological tests showed septic syndrome, acute renal failure, hemolytic anemia, elevated liver enzymes, and positive blood culture to staphylococcus. So the diagnosis of tricuspid valve infective endocarditis was suspected. A bedside TTE was performed and showed these images. As you see, there vegetation at the level of the tricuspid valve with pericardial effusion and the kind of collection, abscess or hematoma around the right coronary artery site. You see? We completed with the TEE, which showed the same findings. So my question, is there another exam to much better understand these lesions? Do you indicate another exam? Another imaging exam?
Okay, we have someone who's got the answer in the back row here. If we could send it, yep. I think the women are taking control of this case.
Not so much of an answer, but a suggestion to look for other embolic lesions or mycotic aneurysms. Since the right coronary artery could be an exceptional location for a mycotic aneurysm. I've seen one in a pulmonary artery in one of my patients before.
Okay, we will see. You will have the answer after this. So the other exam was the CT coronary angiogram, which showed very interesting images consisting of the tricuspid valve vegetation, the pericardial effusion, and an hematoma around the right coronary artery, and a very interesting image of a mycotic aneurysm of the right coronary artery, which was excluded by the overlapping stent. There was the images by the CT coronary angiogram. So now I think that we can establish the crime scene investigation of what really happened. The principal guilty of this crime scene was the temporary cardiac pacing performed in the first procedure. And it was the risk of performing this temporary cardiac pacing, okay, which led to the Staphylococcus septicemia, which was the origin of the tricuspid valve infective endocarditis. This infective endocarditis led to the K word and the crime of this presentation, which was coronary stent infection. Its abbreviation in the literature is CSI, and it was the second reason to choose CSI as a title for my presentation. This CSI led to a mycotic aneurysm in the right coronary artery, which was the origin of the STEMI by a stent thrombosis. On the other hand, pericardial effusion and RCI hematoma could be explained by the aneurysm leak or rupture. How did I treat after PCI? I continue with antibiotic therapy, consisting of vancomycin, rifamycin, and gentamicin, and the in-hospital outcome was favorable with total regression of infection size, and patient was discharged after 6 weeks. The 1-year follow-up was unremarkable, and the patient was not referred to surgery. The literature review of CSI showed that the definition is based on the Dieter criteria. There are 5 Dieter criteria: implantation of coronary stent in 4 weeks, multiple repeat procedure, bacteremia with fever, acute coronary syndrome, and positive cardiac imaging. The diagnosis of CSI is established if at least 3 of the following criteria are present. The first reported case of CSI was in 1993 in Germany, near Switzerland, by Günther et al. It was about a 66-year-old woman with a stent infection of the right coronary artery. Patient was referred to surgery and she died. There are very few cases of CSI reported in the literature. In this paper published in 2012, only 16 cases were reported in 20 years. I searched for a case like our case, including concomitant CSI, mycotic aneurysm, infective endocarditis, and I found this article in India consisting of a huge mycotic coronary aneurysm of the stent of the first part of the LAD with mitral valve infective endocarditis, and patient was referred to surgery with stent extraction and mycotic aneurysm removal, and patient survived. Concerning the treatment, the literature review showed that the main treatment is surgical, with stent extraction, aneurysm removal, debridement, and CABG, mandatory associated to antibiotic therapy for at least 4 weeks. In our case, the follow-up at 1 year didn't show any signs of relapse. Consequently, the patient was not referred to surgery. What the interventional cardiologist must know about CSI, I was lucky to find this article just published now in June 2022. It's about a systematic review of the CSI in the Coronary Artery Disease Journal. 490 cases were screened and only 32 cases were included, and the case you are seeing now was included in this systematic review. What about the CSI epidemiology? Authors said that it's the rarest PCI complication in the world, with a rate inferior to 0.1%. It's more frequent in males after first stent implantation and with drug-eluting stent compared to bare metal stent, probably because of the inflammatory mechanism with drug-eluting stent. The earliest CSI was reported 1 day post-PCI and the latest 7 years post-PCI. Concerning the diagnosis, like in our case, it's based on clinical criteria, including fever and chest pain, biological criteria, including positive blood culture to staphylococcus in 80% of cases, and imaging criteria, including coronary angiography and other imaging tests. The mycotic aneurysm is the most frequent lesion, mostly in the LAD and the RCI. LAD in case of mitral valve infection, and RCI in case of tricuspid valve infection, like in our case. The treatment is mainly surgical with antibiotic therapy, and the outcome of CSI is worse, with a high mortality rate, about 26.5% in this systematic review. Other series talk about 39 to 47% of mortality. This mortality is higher 2 to 3 times in case of absence of surgery. My take-home message, my first take-home message is CSI with mycotic aneurysm is a rare life-threatening PCI complication. Confirming the diagnosis remains the most challenging aspect. Treatment modalities tend to favor surgery, but in our case, we showed that PCI with antibiotic therapy may be sufficient. It's important for the interventional cardiologist to remember that CSI might occur and should be prevented. And this, my second take-home message, in practice, to never see CSI in your interventional career, not like me. Interventional cardiologists must avoid sterility inadequacy, repeated local site puncture, repeated devices manipulation, repeated procedure through the same sheath, and prolonged procedure time. And thank you for your attention.
That was outstanding. Thank you so much for sharing that, and especially for the exhaustive review of the literature. I think just one other thing here, central lines, pacing from the femoral access site, much higher risk of infection than with subclavian and neck, and I think that's just another learning point there. But thank you very much. I think we do need to move to the next case, and we will, David, do you want to introduce our next speaker? I think it looks like Dr. Jama.
Yes, sure. Dr. Zamasa Jama is going to present the next case for us. He is an interventional fellow. He's a cardiologist who's doing advanced interventional training, and I think he's got an absolutely fantastic case, so let's enjoy it together. Thanks, Mr. Zamasa. You can please commence. And make sure you're unmuted.
Good afternoon, everyone. As I'm introduced, I'm Dr. Jama, one of the cardiologists here in South Africa. I'm a fellow with in Farrell's Helic Center. I'm going to be sharing you a case that we managed in about 3 to 4 months ago. So, in this case is 75-year-old lady who had a background history of rheumatic heart disease. He had 699 node dysfunction. He had a pacemaker implanted in 2017, and also subsequent to that developed paroxysmal AF. This is the sequence of her operations for her rheumatic heart disease. She had a mitral valvotomy at the age of 24 years of age, and that lasted for about 10 years. At 34, she needed a replacement of the mitral valve, where he had a metallic valve. That lasted up until the age of 61, and then at the age of 61, he had a redo mitral valve, of which he had, unfortunately, the same year he had a thrombosed valve, and then he had to have a redo at the same time, which he had about 2 redos and a PEG stenotomy. On the last one, the second redo, he had a bioprosthetic valve, a 27mm bioprosthetic valve. That valve lasted her for about 14 years, presented in 2020 and 2021 with repeated heart failure, hospitalizations in his treating cardiologist. This was her echocardiogram that was performed by a cardiologist at TE. What you can see here, she's got a degenerated stenotic bioprosthesis in the mitral area. And as you can see, this is the atrial view of the 3D. You see the valve is degenerated. The gradients were severe. And she was presented for the third redo in the heart team, of which she was turned down. Reason being that the surgeon that operated on her in 2007 reported that the chest was hostile, too much adhesions there. And he, in his notes, he made a note that don't ever come back on this chest ever again. She didn't have any other further option, and he was discussed with Professor Heilig at Sunning Hill Hospital if we can consider any percutaneous intervention for her. She underwent the investigation planning CT for a valve-in-valve percutaneous intervention, of which the valve-in-valve was performed in her using a 27.5 millimeter Marval valve in the mitral area. The reason for that, she had an automitral prosthesis angle of between 90 to 95 degrees. As you would be aware that in that angle, the risk of LVOT obstruction is much substantial. And then we chose this valve because of its small stent struts and to reduce the risk of LVOT obstruction. It was deployed successfully, the valve. And when we were about to take off our gear, we noticed that the patient has dropped the blood pressures to 60 over 30 systolic, and the pulse rate went up to 140. So I would ask a question now, what anyone would think, what's the problem at this point?
That's a good point. Maybe colleagues from South Africa, we can ask in the audience here if somebody has an idea. Christian, you have an idea?
The implantation of the valve, it was perfect, but I'm not sure where is the wire. Maybe perforation of the...
So perforation of the ventricle, left ventricle. Could be an option, hypotensive tachycardia. Yeah. That's the first point. Yeah. Other ideas? Have Henry from Cape Town give a view.
Outflow tract obstruction, I think, needs to be considered as well. So what's the gradient?
Okay, that's the second point, yeah. Any other opinion? Okay. So you heard the opinions from here. Maybe you can show us because you're very curious to know what really happened.
Thank you for those comments. The outflow tract was not obstructed. There was no any significant change from the pre and post procedure implantation. We did a pullback with an end-hole catheter from the LV into the heart, which we had a grade between about 10 to 15. We looked for pericardial effusion, we couldn't find one.
Maybe stop there, because the two options that people have cited are not the cause. There's certainly somebody in the room who knows the answer. Huh? Yeah? Please use the microphone, please. It's streamed as South African colleagues are.
Like the valve malfunction by itself, like the valve is deployed.
Valve malfunction. That's a good point. Anari, you want to make a point?
Is there significant mitral regurgitation? I mean, is there a good seal?
Mitral regurg, but that potentially also compatible with valve malfunction. Tito,
could the wire be splinting the valve open?
The wire stretching the valve open. I think the wire is still in, or is it out?
The wire is out at the moment. We took out the wire.
Okay. I think you need to give us the clue. I think we heard a few suggestions here in the audience.
Yeah. Thanks for that. Those are very good suggestions. Even ourselves, we brainstorm and try to figure out what could have been the problem here. We did arterial injection. The coronaries were non-obstructed. As you can see, the left and the right system was non-obstructed. The valve was functioning okay on a TOE with gradients of negligible that were about 2, and there was no paravalve leak and there was no mitral regurgitation. Perform an LV-gram. I just want to bring to your attention, as you can see here in the LV at the apex, there is extravasation of contrast from the apex into the pericardial pleural space. And there was a perforation of the LV apex by the CALD confeeder wire. And then because the patient had a previous closed valvotomy via the apex, there was a pseudoaneurysm in there, and there was a pericardial pleural space that was open. There was no pericardium. What will be your next step?
I guess what you're going to do. It's so obvious, knowing it's ferrohelic in charge, you will probably, I don't have to say, but I know what you're going. Anybody has an idea what's going to be done?
A plug of sorts.
It will be plugged, yeah. But which plug? That's the point. There are so many plugs around.
I think, Eric, that's the key point here, is which plug would you go for?
The good thing, this lady had already 3 times surgery. That's why she's still alive, I think. So which plug?
But is it fair to say we don't have any plugs that are made for this?
Yes. We tried a percutaneous intervention because this patient has been deemed unoperable and is unstable on the table. We went in because we got arterial access, went in into that pseudoaneurysm space with a normal workhorse wire. This is the 035 wire into the pericardial pleural space with a JR guide. A diagnostic catheter, and we tried to understand what was going on in there, and then we found that there was a collection in the pericardial pleural space, but not around the pericardium. As you can see, this is the same view. The wire, the confeeder wire, is at the same position where the collection is, which means that the wire has perforated through the pseudoaneurysm into the pericardial pleural space. With difficulty, we tried to measure the size of the defect. We took a duct occluder, a 6 millimeter, which is about 16 millimeters, but that we couldn't deploy it. It just pulled back into the ventricle. We took an oversized ASD occluder via delivery system, which we put into that cavity, and then we made a cup around the apex. And on the right-hand side, that's the LV-gram. Post plugging of that, you can see there's minimal extravasation of fluid, of blood, into that pericardial pleural space. And then we went back and looked at the CT scan prior to this. As you can see there is a pseudo-aneurysm in that apex with no myocardium. It's just a communication between the endocardium into the pericardial space. And because of the adhesions, that's what was holding all of this together all these years. And the wire just went into that soft space and went into the pericardial pleural space. On the right-hand side, you can see the plug on the CT scan post implantation of the plug. The patient was transfused in the cath lab, and the pneumothorax was drained, and he was extubated the same day, discharged after 10 days in hospital. 6 weeks later was completely asymptomatic in neuro class 1. My take-home message is that after closed valvotomy, be wary of the pseudoaneurysms, and you need to familiarize yourself with your equipment in your cath lab that can save you when you come to these situations, and you make sure that you have stock available. I thank you.
Yeah, thank you. That's an amazing case. I think it also, just an additional point, I think illustrates the value of a left ventriculogram, one that is done properly, not sort of an end-hole catheter with a hand injection. You had a very good quality ventriculogram, gave you the diagnosis. I bring this up because obviously they were looking for a big pericardial effusion, but it was much more localized. But we might see this from time to time with subacute ruptures and acute myocardial infarction. Sometimes you see a little track through there, and unless you're doing something like CT, you almost never see it with echo. But we've seen this a few times with a ventriculogram. But congratulations for getting out of trouble there. Any comments or questions? Anyone seen this before, or this approach? Christian?
So, can anyone hear me?
Yes, we can. Yes. Go ahead, Arthur.
So, look, I have a question. Jama, that's a beautiful case. It's always a privilege to work with Pharaoh Helig. There's a lot to learn from him. My question is that for centers where you have a patient like this with a bioprosthetic, say, mitral valve with significant prosthetic valve dysfunction in the form of stenosis, is there a role, if only perhaps as palliation, for doing a balloon valvotomy? Would you consider that perhaps to avoid a complex procedure as a valve involved in the mitral position?
I can answer that. It's absolutely contraindicated because you don't know what you're doing. So normally we had here one case a few years ago of a frozen bioprosthesis a few days after surgery, where you can basically already with the wire open up the, but this totally degenerated bioprosthesis can theoretically not be ballooned. It's not my opinion. I asked it like to people like Alec Vagnon. So you shouldn't do that. You shouldn't do it. Can't do that. It's totally, Russian roulette. You don't know what will be outcome. It can be catastrophic. So Christian, you were right. You want to say something?
We have maybe 1 year ago a similar case in our cath lab after the TAVI through the carotid access, and the access, it was performed as usual in our center by the surgeon, the cardiac surgeon, and we have a perforation of the left ventricle by the wire. It's like cut like a knife, and the surgeon was there. So initially it was the same situation. The patient, the blood pressure, it dropped. It was a critical situation, and when we inject in the Initially, we think that there was some problem with the valve, but when you inject through the left ventriculogram, we see the perforation, and the surgeon performed immediately sternotomy, and it was very difficult, but the patient was saved.
That's a good point, Christian, but that's perfectly possible in this case, but in this particular situation, it was impossible. After all this sternotomy, this patient was not a surgical candidate. I've also, concerning the choice of the device, I would also have done the same, an oversized CSD device. Even if they completely will be disproportionate distally, they will really seal off very nicely from the apical side. And as I said before, this was a contained pericardial effusion. That's why the patient survived. So that's the big difference with your patient. You had some time to think and to think how to solve it. Because if it's like in your case, Christian, it's a situation that is different. Surgery had to be done. Certainly, this patient was a different story. I think, Marco, we need to go on because we have to respect the other speakers.
So let's then introduce Dr. Abdurrahman Al-Hakim from Holstein in Germany for the next case.
Thank you. I would like to present this case post-LCX PCI precardial effusion. You may think about coronary artery perforation. Maybe it isn't the case. 80 years old patient presented with unstable anginal pain with known coronary artery disease and atrial fibrillation under dual therapy and ECG with right bundle branch block, echocardiography with low normal ejection fraction, about 50%. We did coronary angiography, as you see, left main LAD without any stenosis, Ramos with very good result after stent implantation for 2 months, and LCX proximal to medial 80% stenosis. RCA also with 80% stenosis. You may consider conservative therapy, or you do staging PCI, or only PCI if you have a positive physiological or stress test, or you do coronary artery bypass. We decided to do coronary angiography. A relatively good result was a relatively heavy calcific lesion. We did body wire technique and guideliner, but at the end, it's a very good result. 2 hours later on, the patient developed cardiogenic shock. We did ECG without any signs of pericardial without any signs of stent thrombosis. We did echocardiography. We see a pericardial effusion of about 15 millimeter. We didn't understand what happened, but we should do pericardiocentesis of about 600 milliliter hemorrhagic effusion. Surprising, it was a venous bloody effusion, not an arterial one. And to understand what happened, I did coronary angiography. I did levocardiography. I did RV angiography. I did aortography. There is no any signs of perforation. The patient, 30 minutes later on, deteriorated again. We did the second pericardiocentesis. We didn't understand what happened. The patient became 3 packed RBCs, and I decided in that moment to do cardio CT to understand what happened. Cardio CT showed circumferential pericardial effusion, and at the region of LCX, as you see, there is a haziness. That means this pericardial effusion is related to our intervention. But what happened, I didn't understand. Can anyone help me and tell me what happened?
Did you check for the coronary sinus?
Why coronary sinus?
It's related anatomically.
But coronary sinus has another anatomy other than LCX.
True.
It's in the near, but it isn't not a direct contact.
But his comment is, your comment is well taken.
Well, yeah.
It's well taken, yeah. Because I don't say what it can be, but we know what we think what it can be.
It's okay. Another suggestion?
Everybody's tired.
Okay, no problem. I try to understand what happened, maybe from down to top. Maybe I have intramyocardial injury, hematoma, or I have coronary perforation. In that case, you have a venous blood effusion, you don't have any signs of perforation, and hematoma, you see hematoma in CT, but I expected to have a venous blood effusion, not an arterial blood effusion, not a venous one. Then we did RV angiography, hepatic and intra-abdominal vessels without any signs of injury. Maybe we have spontaneous bleeding due to triple therapy under the dabigatran, aspirin, and clopidogrel therapy. But in this case, maybe it's a cause, but you see there was a hematoma in the LCX region. Or you have post-LCX intervention great coronary vein injury with large myocardial hematoma, maybe. What do you think about the most suitable treatment in this case? You consider only conservative therapy, you stop antiplatelet therapy, or you do surgical evacuation of hematoma and blood sealing of the injured vessels, or you do covered stent in LCX, or only precardiocentesis, or A and D? Any answer?
It's time to the surgery. You have two times 600 pericardial infusion. I think it's the time to surgeon to be open and see what happened inside.
Very good answer. That means we as interventional cardiologists, we need a heart surgeon. Okay. I transferred the patient to a tertiary heart center. The heart surgeon decided to wait and see, and he gave the patient digibend against the dabigatran with the hope that the patient may be stable. 6 hours later on, the patient had the same symptoms and precardial effusion. He decided to do explorative surgical pericardiotomy. And there was a large myocardial hematoma, and he tried to evacuate the hematoma, and he tried to seal the injured vessels. And to understand exactly what happened, this is cardio CT photos. There is a relationship between artery and vein. As you see, normally in the population, the vein, the great coronary vein, pass over the artery in about 80%, 70% of population. And in about 20% of population, the vein pass under the artery. In our case, the vein pass under the artery. We did a relatively heavy calcific lesion. And during stent implantation, our plaque protrude outside the vessel, injures the vein, causing hematoma, and the vessel continue to bleed. To summarize my case, patient with unstable anginal pain, we did intervention, post-intervention pericardial effusion, we did 2 times precardiocentesis, we did explorative pericardiotomy. The whole hematoma was removed, and the injured vessel was sealed, and the patient discharged after 3 weeks. This is the third question: what is the most common cause of hemorrhagic arterial or venous pericardial effusion after PCI? Maybe spontaneous bleeding, or cancer, or injury of the surrounding structure, artery or vein. Take home. A great coronary vein injury during percutaneous coronary intervention is a very rare condition. It isn't enough discussed in the literature.
It's a diagnosis of exclusion if you have, number one, a venous pericardial effusion directly after PCI, no injury of the RV or any surrounding structure, and a hematoma in PCI region, especially LCX. Then suspect great coronary vein injury, consider CT thorax. A hematoma can deteriorate the hemodynamic status without pericardial tamponade. In our case, there was no signs of pericardial tamponade, but the patient was hemodynamically unstable. At first, consider conservative therapy. If the patient hemodynamically unstable or bleed progressively, then do pericardiocentesis and contact a heart surgeon as soon as possible to do explorative pericardiotomy, evacuate the hematoma, and seal the injured vein. Thank you for your attention.
So I guess the coronary sinus wasn't too far away. So I think we should give you that. That's a good suggestion. Did the surgeon actually see where the trauma was? I didn't quite catch that from your slide there. It was swollen, there was blood there, but could they actually see the trauma to that vein? Or that's the supposition?
Yeah. The surgeon had seen everything during the operation. These photos from the anesthesiologist. He did this photo with a mobile, and it wasn't a professional one, but he told everything about this complication. He told me there was a very large hematoma and the vein is injured, and has told me also, we as a heart surgeon, we see often post-PCI epicardial hematoma after normal intervention. The heart surgeon seen oft this complication, but in that case, the vein, our hypothesis, retrospective, the vein passed under the artery. We did a calcific lesion. During stent implantation, this plaque protrude outside the vessel. It happened in PCI also. And the vein has no place to move. Yeah. This plaque makes this...
so that's the hypothesis there.
It's
for this case.
But injured vein is also observed.
No, I get that. It's and hopefully the surgeons are not seeing too many hematomas over the myocardium after PCI.
He told me maybe I don't.
Well, I'm just saying. Hopefully not too many, because most of our patients don't go. Most of our patients don't go to surgery. It was a poor joke, but I think we need to move on to the next case. But thank you very much. This is a great case, and also another wonderful illustration of using CT to help try to put things together. And I think we've seen a few examples of this now, and something I think we're going to see more and more. So, David, I'm going to hand it back to you to introduce our last speaker.
Yeah, thank you very much. This is one of our office fellows, Dr. Vaishak Vinod, and he's going to show us a case from Charlotte Matei Academic Hospital in Johannesburg. Vinod, thank you very much. Please take it away.
Well, thank you. I just want to just confirm that everyone can see my screen and my slides.
We can see and hear you. We can't see your slides yet.
Oh.
I can see them.
We can see them over here in South Africa. I don't know.
Yeah, we don't see them in the room here.
Okay, let me just try and reshare it.
I think it's our organizers, because my screen layout has changed radically during the last presentation. Without any input.
We couldn't see your screens when the present.
Any luck now?
Yes. Thank you.
Great. Good afternoon, everyone. It's about 5 o'clock here, or 6 o'clock actually. My name is Vaishak Vinod. I'm one of the fellows at Charlotte Matei Johannesburg Academic Hospital, affiliated to the University of Witwatersrand. First, I want to just thank you for the opportunity to be able to show this case on this platform. It's a bit different, but in keeping a similar theme to the cases we've seen so far today. Not a true direct complication to PCI, but something that we do encounter ever so often. Maybe not so often in other parts of the world, with early and easy access to healthcare. So the case I'm presenting is Mrs. A.W. She's a 78-year-old lady that we treated earlier this year. She presented to a private facility with features in keeping with the anterolateral stemming, and about 3 hours since peak onset of chest pain. So total ischemic times around 3 hours and a bit. The cardiovascular risk factors being that of hypertension, dyslipidemia, her age, and a postmenopausal state. Just other relevant comorbidities just to be aware of. She's got pulmonary atrial fibrillation, for which she's on warfarin, and she's hypothyroid. The treating unit on that side, they opted to go with pharmacoinvasive strategy, and there were several other delays to be, because this case was done around the COVID time, where there's lots of COVID protocols. So they went along this pharmacoinvasive strategy, and the lytic that they used was tenecteplase. They gave 35 milligrams of lytic. Wasn't dose adjusted for her age. Probably may consider doing it so. The adjuncts given were antiplatelets in terms of aspirin and clopidogrel, 300 milligrams of clopidogrel and 150 milligrams of aspirin. And anticoagulant they used enoxaparin. They did not give an IV loading dose, but a subcut dose was given of 60 milligrams. These are relevant blood investigations. As you can see, nothing major, hemoglobin of 13.5, platelets of 300, mild renal dysfunction, but in view of age, not so bad. And the INR at the time of lytic was 1.8, and a peak troponin of 8,200. As you can see from the ECG, ECG on the left and the right, pre and post lytic. As you can see, I mean, AC segment resolution was promising, and we were informed that from a clinical perspective as well, that it was a successful lytic, her chest pain had apparently settled, and she was hemodynamically stable. As she had no funds to undergo a diagnostic coronary angiogram, at the center, she was referred to us at our facility, where we're a public hospital. However, on arrival to our center, she had ongoing chest pain. She was unfortunately in cardiogenic shock and requiring inotropic support. The agent we had used was dobutamine. Fortunately, she wasn't in pulmonary edema at this point in time and did not require ventilatory support. We activated our cath lab team as soon as we could and got her to the cath lab. Due to all these delays with COVID and transport issues, now we're at a total ischemic time around 12 hours. Her admission echocardiogram, which I actually don't have, it showed an EF around 25 to 30% with apical, anterolateral, anteroseptal wall akinesia. There were no features in keeping the acute mechanical complications on this echocardiogram. They really didn't see any VSDs, there's no MR, and at this point in time, there was no pericardial effusion at all. Okay, so we rushed into the cath lab and just see my pictures. As you can see, we went the radial access, and we're shooting the right coronary artery. As you can see, there's just mild disease in the RCA, but there's TIMI3 flow. This is just the LAO-caudal view of the left system. You can see here the left main looks normal. The proximal segment of the left circumflex is okay, and the LAD, it's a lot of overlap, but the proximal segment of the LAD looks okay, but we can't really see the outline of the distal LAD, which we expect to see. In the epicranial view, you can see there's areocranial view. You can see that the flow down the LAD is abysmal. There's some luminal irregularities in the proximal vessel, but there's no flow past the mid-vessel. It's most likely related to distal thrombus embolization and vascular permeability, all keeping with coronary microcirculatory dysfunction. The likelihood of a distal lesion, unlikely, but something to consider. So at this point in time, we gave her 6,000 units of heparin for our procedure. We went down with a plain cyan guide wire. We down the vessel. We used the fine cross microcatheter, then to administer bolus of adenosine. We wanted to administer adenosine as distally as possible. And we repeated this a couple of times. And then using the same microcatheter, we just injected down the vessel. As you can see, there's very sluggish flow down the vessel. Nothing much sinister to see there. But we, just in the distal vessel, we thought there might have been some disease. We used a 2/12 millimeter semi-compliant balloon, just a gentle dilatation, 8 atmospheres pressure. And this was our final shot down the vessel. So as you can see, nothing clearly to stent, just poor flow down the vessel, all probably related to microvascular dysfunction. At this point in time, she's still on inotropic support, dobutamine at 15 mics per kilogram per minute. Nothing much we could fix. So, at this point in time, we thought, let's support acutely. We put in a short-term mechanical circulatory support. What we had access to was intra-aortic balloon pump to try and offload this left ventricle and give this myocardium some time to recover if at all. She was then subsequently transferred to our ICU and on a heparin infusion. So, this is what unfortunately happened. So around 90 minutes after the initial procedure, we were called to the ICU. My colleague who was looking after the patient noted that she had progressive deterioration in her condition. She had worsening tachycardia, wasn't perfusing so well, and the inotropic requirements were now going up. As you can see from the blood gas, her perfusion was poor, lactates were climbing. To refresh, at this point in time, she's on started on a second inotrope, and she's got mechanical circulatory support. At this point in time, our biggest concerns were the usual culprits post a potential intervention, or when you put a wire down a vessel and done some inflations. Does anyone want to, and it's a very simple case, but anyone want to hazard any suggestions what else could have gone wrong?
Could you just clarify, so how long after lytic therapy is this occurring?
So this is about 9 hours after lytic therapy. Her total ischemic time is about 12 hours.
Okay, so lytic therapy was given with a delayed presentation. So as you said, you're thinking about something in the coronaries, but in an acute MI, I think with this sort of, particularly showing us the ECG there, doesn't really show sort of a new STEMI. I think we have to be thinking about mechanical complications, and it's still probably one of the commonest causes of death in hospitalized patients with MI. And she did receive lytic therapy, sounds a little bit late. So I think we're probably going to be hearing something about some form of rupture.
Yeah, this is spot on. So this is the echocardiogram done at the point of time of deterioration. You can see it's the off-axis, parietal long-axis view. There is a small pericardial, mild to moderate sized pericardial effusion. And in the next 15 or 20 minutes going forward, her effusion got much larger, and the second inotrope was started, and we performed emergency pericardiocentesis, and we got fresh blood. So those are the possibilities we thought. Did we cause the injury? Was there a mechanical complication? Obviously, on the echo, we didn't see any other features like the BSG or MR, so there's only one mechanical complication left over to think of. But we rushed her back to cath lab just to make sure we hadn't maybe dissected the coronary artery, that we hadn't caused an injury to the aorta when we put in the intra-aortic balloon pump. So as you can see, the flow down the vessel, really not much different to when we had taken off the table. And at this time, her inotrope requirements are going up. She's on max dose of dobutamine. She's on adrenaline as well. So we quickly wanted to just make sure we didn't cause any vessel injury. We used the same microcatheter. We went down distal to the vessel and we injected, and we looked at it in multiple views. We're quite happy that we hadn't caused any vascular injury based on these pictures. Then the other possibility was, it's sometimes, did the pericardiocentesis was done in an emergency setting, did we cause further injury? Could we have maybe injured the right ventricle because they'd gone subcostally? Could we have put the drain into the right ventricle? Because as we were doing the angiogram, we were aspirating and blood was coming back quite freely. So we were just a bit curious as to what exactly went on. So while we wanted to repeat our echocardiogram, while we were waiting for the echocardiogram, we connected our tracing to the central venous line that we kept in the pericardial space and looked at the tracings. Didn't look like a ventricular tracing, so we're quite happy. It wasn't ventricle. Then we injected through the venous catheter into the pericardium to see where the contrast was extravasating into, and it looked like it was in the pericardium. So, as you correctly suggested, at this point in time, we only had one choice left. Unfortunately, time was running up. She was deteriorating quite rapidly. She was on dual inotropes. The only form of mechanical circulatory support we had was intra-aortic balloon pump, which she was already on. And the left ventricle did show a free rupture of the anterolateral wall, unfortunately. With the rapid deterioration, we were unable to get our surgical team on board, and unfortunately, the patient unfortunately demised. I think what we learned from this case is, we're seeing this quite often, especially with delays that, when you have an elderly patient, she's an elderly female, when you undergo a pharmacoinvasive strategy, there's always a risk of getting complications, giving a late lytic and late intervention. Always when you see refractory shock post-coronary intervention, our first step is always to think, is it something we've done? Did we cause a vessel injury? Have we injured some other structure? But it's always to think of, in the elderly folk, mechanical complications. This mechanical complication, a bit more difficult to pick up. I mean, if it was a VSD, we would have picked it up on echo. Clinically, we would have heard murmurs. Papillary muscle rupture would also picked it up on an echocardiogram. Clinically, it would have been in more respiratory distress and pulmonary edema. So I think the point here was a pericardial effusion post a procedure that's rapidly reaccumulating. We should always think of mechanical complication. And as you have a very little or small, narrow window of opportunity to intervene on. The other thing to also consider at this point in time is, what mechanical acute mechanical circulatory support modalities that you have available at your institution as a bridge to your definitive treatment. I mean, this patient needs to go to surgery. So, it's very easy to say that, the two modalities we have are the intra-aortic balloon pump and the access to ECMO, via ECMO. The problem is via ECMO, we may be able to support the patient, but we won't be able to unload the ventricle or unload left ventricle. So sometimes, you may need to use a combination of impeller with the ECMO, like an impeller. So sometimes an impeller for us, we don't have access to impeller. So it was quite an interesting case in that regard, just to say that, to pick up these complications quite early and quickly, to think about it, make the early diagnosis and get the adequate intervention. Otherwise, unfortunately, we may not have good outcomes. And I'm not aware of any percutaneous mechanisms or methods to fix this problem in terms of the free wall rupture. I think it's a bit difficult to localize, and we just didn't have time in this case, unfortunately. Thank you. I just wanted to share this case as we're seeing more and more mechanical complications post-MI, especially with periods of COVID and the delays. We've had quite a few cases that we've seen with acute mechanical complications. I just wanted to share one of them. Thank you.
Well, thank you. You presented it very well. There are so many educational teaching points with this case. So let's just quickly go through them for our trainees. First of all, it's an under-recognized complication. I've seen many of these over the years. Someone collapses in the CCU, they were doing well. It's usually sudden death, it's PEA. And then we get a call from the cath lab to say that they've got stent thrombosis, and you go into the room and they're having CPR, and no one's even thought about a mechanical complication. So it's an older woman, that's a risk factor. It's her first MI, risk factor. She had delayed reperfusion therapy, risk factor. And so the most important thing is to be thinking about it, because if you work in a primary PCI center, you're not going to see this very often. But we saw this years ago before primary PCI and everyone was getting neolytic therapy. But I wouldn't want people to think that the pharmacoinvasive approach is not a good thing and it leads to rupture, because it doesn't if it's given early on. So in the first few hours, the first 3-4 hours, pharmacoinvasive approach is pretty good. I remember at medical school, and maybe we're taught the same thing at medical school, that rupture is a delayed delayed occurrence. It occurs a day or 2 or 3 days later. But it's very clear that it can happen in the first few hours, even in someone who is not reperfused. And I had a case recently. Patient had presented within 7 hours, had a small PDA occlusion, but it was very distal, and she had a reason for us not to intervene. It seemed so small, and there were going to be some risks associated with it, a very bad anatomy, and was left alone. And 7 hours later, she died, sudden cardiac death from rupture. Most of these you'll never resuscitate. There have been a few get to surgery. That's the only way you're going to save that patient. Balloon pump is not going to work. Impeller's not going to work. ECMO probably is not going to work. You've either got to have a surgeon in the room, or the patient stabilizes with maybe a large pseudoaneurysm and it hasn't completely ruptured. So I don't think there's much you can do in these cases, and survivors are few and far between. And maybe just one other point I made in the other case about the ventriculogram. In your case, that's the first thing that needs to be done there. I mean, you did pericardocentesis for a really good reason. So don't think then you then caused another complication. And at that point, you have to do a ventriculogram. Don't waste your time doing anything else because time is so precious. But most of these people die. Eric, you want to add anything there? Any comments?
Maybe I can make a comment.
Sure.
That
Go ahead,
these rupture cases, thank you. These rupture cases sometimes present as recurrent ST elevation with repeat pain. I remember in the thrombolytic days when I was working in the UK, in our hospital, we had a policy of repeat episodes of thrombolytic administration. Hard to believe now, but we used to do that at one stage, and it was abandoned because of these cases, because there was a confusion sometimes between rupture and reinfarction, because of a similar presentation in many. So I think the thing is that when a patient who's a late presenter has still got persisting elevated ST segments, one of the potential causes of ST segment derangements in late patient, presenters is in fact rupture, especially if it's associated with localizing pain. So I think that it really is a great case that reminds us of the reality of rupture in late presenters, and you've highlighted the risk factors for that. Thank you.
Thank you, Dave. I think we come to the end of this second day and of this day. I would like to highlight that we have 5 people from South Africa over here, still in the audience, and really take the opportunity to thank all of you for traveling, coming to Lausanne all the way. I know it's a long trip. I'd like to thank the South African colleagues at home and Dave. This was in association with the official South African Interventional Society. So really thank you for being part of ECC. Thank you to everybody. Have a nice evening, and we'll reconvene tomorrow morning. And don't forget your umbrellas or cover you because it seems to be raining strongly outside. Have a nice evening and see you soon.
Thank you, Eric. Thank you, everybody.
Thank you.